Dr. Ravi, can you hear me? Dr. Ravi, can you hear me?
Hello.
Present.
Yes, now I'm audible.
Yeah, you're audible. So our speakers are here, so we can start with the session.
Okay, please start.
Do you want to switch on your video camera or something? Because so you can invite our speakers, the order wise which I've sent you, and then they can present it to you. Each has 10 minutes to present, okay?
Each has 10 minutes. Any timer is
Starting
there?
from now.
Timer
I'll
is there?
put the timer. I'll put the timer, don't worry.
Okay.
So should we start?
Yes, please start now.
So you can invite our first speaker on the dais so that she can present.
Okay. So how can I do that? Who will do it,
Just
the invitation? From my side, or you will do it?
no, actually the chairperson has to do it.
Okay, where is that option?
What option?
So invite the
No,
invitation.
she's already present here.
Okay. So please start now.
So I'll just invite Dr. Sabha Anam on stage to present her free paper. Yeah.
Okay.
Good morning, everyone. I'm Dr. Sava. First of all, I'd like to thank ANSIPS for giving me the opportunity to present my paper. The title of my paper is Effectiveness of TDCS in Reduction of Craving in Alcohol Dependence Syndrome. Introduction. Alcohol is one of the most commonly abused psychoactive substances, and alcohol use disorder is a chronic, relapsing, and remitting disorder, which it is known to cause disease, disability, and death worldwide. The early prevalence of alcohol use
Sorry
disorders.
for the disturbance. Can you share the slides? The slide. Okay, can continue.
So can you see the slides now?
Yes.
Yeah.
Please
All right.
continue now.
The yearly prevalence of alcohol use disorders in India was 2.1%, and that of alcohol dependence was 2.6% in 2010. The National Mental Health Survey of India 2015-16 estimates the prevalence of AUDs as 9% in adult men, and it causes 5.4% of all deaths nationally. The conventional components of management at the primary level include psychotherapy, use of aversive and anti-craving agents, and support groups like Alcoholic Anonymous. The low response rates in these methods could be due to the addressal of acute symptoms and problems in alcoholism and not the underlying neurobiological elements of addiction. So the functional neuroimaging techniques like fMRI and PET scanning implies that functional frontal dysfunction is a characteristic change in individuals with alcohol dependence. DLPFC specifically is associated with attentional memory process response inhibition and cognitive flexibility, which is known to be implicated in substance users. Craving involves activation of reward system pathway, that is repeated intense dopamine release through mesocortical limbic pathway into the nucleus accumbens. So it has been postulated that the augmentation of DLPFC through stimulation and modulation could have a potential role in reduction of craving. TDCS is a simple technique of non-invasive brain stimulation in which a low-intensity constant current is applied onto scalp for several minutes. The net result is a polarity-dependent modulation of brain activity, where the anodal stimulation increases the cortical excitability and the cathodal stimulation decreases the excitability. It has been the preferred technique of stimulation in view of its easiness to use, low-cost, benign side effect profile, and favorable results from the prior research in the field. So in this study, we have tried to evaluate the effectiveness of TDCS or transcranial direct current stimulation in reducing craving in persons with alcohol dependence. The study place is the General Hospital Psychiatric Unit of Tertiary Care Hospital in New Delhi. Study period was from 1st November 2018 to 31st March 2020. Study population is male, 46 as a sample size, aged 18 to 50 years, who were diagnosed with alcohol dependence by ICD-10 and were included in the study after screening through audit scale. Study design is a randomized, single-blind, and sham-controlled study. Clinical assessments of the subjects were done through a semi-structured questionnaire for obtaining socio-demographic data and clinical institute of withdrawal assessment of alcohol use CYAR to determine the withdrawal, alcohol use disorder identification test for screening of the subjects, and visual analog scale for alcohol craving. Hindi version was used. The device which was specifically used was Focus Co-Flow TDCS device. So about visual analog scale, it is self-rated scale to measure reduction of craving. As you can see, there is a 0 to 100 millimeter line. So visually it is presented to the patients and they can see that 0 represents no craving and 100 millimeter mark represents maximum craving. Inclusion criteria, as I said, it was male patients aged 18 to 50 years. They were screened through audit, had a diagnosis of alcohol use disorder, alcohol dependence. CYAR score should be less than 8, and it has been for the last 24 hours. The patient should have stable vitals. And exclusion criteria was those with comorbid drug dependence, except that for nicotine, chronic skin disease of scalp, or any or those who were on any other anti-craving agent in the last 2 weeks, comorbid organic psychiatric illnesses that interferes with the diagnosis of craving. Methodology, the patients 18 to 50 years of alcohol dependence syndrome undergoing detoxification and willing to take part in the study were admitted and oral consent was taken. We had screened the patient for dependence using audit, and the assessment of craving was done through application of visual analog scale for craving. And the study sample, that is 46 subjects, were divided into 2 groups, sham and real TDCS, in 1:1 ratio using a computer generated block randomization sequence. And this was done by an unblinded coordinator who revealed the subjects group to the researcher before the first session. TDCS was applied via 2 carbonated silicon electrodes connected to a DC stimulator of 20 volts. Saline solution, 90% normal saline plus 10% distilled water with low dose lidocaine gel 4% was applied to reduce irritation and promote conductance. Stimulation level, 2 milliampere for 20 minutes with fade in and fade out period of 30 seconds. And sessions were done twice a day for 5 days consecutively, that is 10 sessions in total. For real TDCS, cathode was placed over F3, that is left DLPFC, and anode was placed over F4, that is right DLPFC. For sham TDCS in group B, the stimulator was automatically turned off 30 seconds after to simulate the sensation produced in either of the stimulation. Craving assessment was repeated through the application of VAS after the final session to detect any change. Statistical analysis, the data was tabulated in MS Excel and analyzed using SPSS version 21.0. Categorical variables were presented in number and percentage. Continuous variables were presented as mean plus or minus ST and median. Quantitative variables were compared using independent t-test and man-Whitney U-test between the 2 groups. A p-value of less than 0.05 was considered as statistically significant. As you can see, the results of the socio-demographic data that was obtained. The age of the subjects mean was 36.17 plus or minus 7.78. Education and occupation, about 8 of the subjects had studied up to class 5 and 8 of the subjects were unemployed. Marital status, maximum around 34 of the subjects were married, only 5 subjects were living alone, and age of onset at the time of drinking was 22.28 mean. And year of drinking, maximum year of drinking which was recorded is more than 20 years. 10 subjects had maximum years of drinking, and about 27 subjects had family history positive for alcohol use disorder. The total audit score between group A and group B, there was no significant difference, statistically significant difference. And in CYAR score, there was statistically significant difference between the 2 groups. Now the assessment of craving was through visual analog scale. You can see that before intervention and after intervention in the real TDCS group, which is marked by the blue bar, there is a significant decrease in the score. And between group A and group B, there was no statistically significant difference. It was around 8.35 in the scores, and but after intervention, the p-value is reduced to 0.0001. So in this study, there was significant decrease in BAS score of craving, which was in line with the findings of decrease in BAS scores in the study by Boggio et al. 2009. So here the Q-induced craving for nicotine was assessed post-intervention between the 2 groups, real and sham TDCS. The current study may have produced similar results because of the similarity in TDCS parameters, cathode over the left and anode over the right versus sham. And the duration of study was also same for 1 week, and the method of craving of evaluation was through VAS application. Strengths and limitation. Limitation of the study has been the limited sample size, n is equal to 46. There was no follow-up beyond the 1 week period. Limited generalizability because we did not consider any other substance use except for alcohol use disorder with or without nicotine. Strengths has been there were no dropouts because we ensured that the patients were admitted and given the intervention through 1 week time and then discharged. It was a non-invasive novel treatment modality, which was largely accepted by the patients. It has been a safe alternative for medication intolerant or non-responsive subjects. So in conclusion, the study reported significant reduction in craving as reported by VAS score in patients treated with a real TDCS in comparison to those treated with a sham TDCS. TDCS can be considered as a positive, promising, safe, non-expensive add-on clinical tool that can help reduce craving in persons with alcohol dependence syndrome. These are my references. Thank you.
Dr. Ravi, can you hear?
Yes.
Yeah, if you have any
Okay.
doubts, you can ask, or we can move on.
What is the duration of the study?
Yes, sir.
What is the duration of this study?
So duration was from November 2018, 1st November 2018 to 31st March 2020.
Okay. Why did you choose the blocked randomization method?
So it was easier and it was available. That's why.
Why?
It was easily available, and I could do it on my own. So I just chose
No
that.
statistician will decide. Okay, whatever it is. That. Okay. Okay, thank you. Nice presentation.
Thank you.
Go ahead.
So I would like to invite the next speaker, Dr. Sahili Dey, on stage to present her paper.
Okay. Please start your presentation.
Good morning, everyone. I am Dr. Saheli Dey, Junior Resident from Institute of Psychiatry, SSKM, Kolkata. I am going to present my paper on sociodemographic profile and pattern of psychiatric presentation of patient attending the emergency unit of a psychiatry department of a tertiary care teaching hospital in West Bengal. Psychiatry emergency are different from other medical emergency as they are characterized by acute condition of disturbances of affect, mood, behavior, and thought, and they need to be managed with immediate therapeutic intervention. Otherwise, they can cause great harm to the patient or to the surrounding. These emergency services are thus now an important part of mental health system globally. There are various emergency conditions we encounter daily, like suicide, delivery self-harm, acute intoxicated state, acute behavioral abnormality, and many other conditions. In other countries, psychiatric services are widely available in many of the tertiary care hospitals, but they are mostly belong to the inpatient and outpatient-based service and consultation license service from other non-psychiatric department as referral basis. Thus, majority of the institutions lack emergency psychiatric unit, which is one of the reasons behind underutilization of this service in India. To overcome this situation, the WHO has recommended that centers for proper prompt recognition and rapid management of acute conditions should be made available for at least 50% of the population of a given area. There are very few literature out there regarding the pattern of presentation and sociodemographic profile of the patient coming with acute psychiatric emergency in the emergency psychiatry unit of a hospital available in our country. Thus, our study conducted here aims at assessment of sociodemographic profile, presenting symptom at psychiatry emergency unit, and the final diagnosis according to International Classification of Disease 10, that is ICD-10. Our study has been conducted on the patient attending the emergency unit in a tertiary care hospital in West Bengal, which runs a 24-hour-based emergency services. It is a prospective longitudinal hospital-based study conducted for a period of 3 months from May 2021 to July 2021. Diagnoses were made according to the ICD-10, and the details recorded include sociodemographic profile, sources of referral, presenting complaint, final psychiatric diagnosis, and intervention provided. And we have taken the ethical approval from Institutional Ethical Committee before proceeding for the study. Total 200 patients were assessed for over the 3-month period, and as you can see, that the majorly age belongs to the 21 to 40 years, with the mean age of being 34.6 years. Among them, most of them belongs to the married female, and rest of them are 64 of them were unmarried, where 20 patients were separated from their spouse, and rest of them were widowed. And we can see here majority, that means 42% belongs to the semi-urban area and mostly belongs to the either Hindu or Muslim religion. And most of them I at least have completed their primary education. And according to the modified BG process socioeconomic classification, we can found here, most of them belong to the either lower middle class or from the upper middle class society. As you can see here, the most referral we have got here from the general emergency department, that is almost 26%. And a significant number of patients have attended at their own in our department, which accounts for 17%. And rest of the referral from emergency unit of the following department like general medicine emergency, neuromedicine, neurosurgery, PMR, pediatrics, gynae-obs, dermatology, etc. The most common complaint we have found is episode of unresponsiveness, shortness of breath, and histrionic symptom, followed by excitement and agitation and substance abuse, account for 11.5%. Other complaints are sleep disturbances, anxiety symptom, altered sensorium, suicidal attempt, and various other complaints listed here. The most common MSA we have got here is the psychomotor agitation, which accounts for 36.5%, followed by anxious effort and anxiety symptom. Thus, a variety of diagnoses we have found among the patient attending our unit of a hospital. And the most common among them were dissociative conversion disorder, which accounts for 16% with female predominant, followed by substance use disorder. The most common was alcohol, that is 15 cause, and all of them were found to be male. And the last one was a bipolar affective disorder. Other patients of acute and transient psychotic disorder, schizophrenia, and organicity due to other causes were also found. Thus, we can see here that one of the commonest presentation we have got is from a 48 group, that is neurotic and stress-related somatoform disorder, which accounts for around 54%, 27% of the population. Thus, you can see the emergency psychiatry is one of the important psychiatry branch to provide treatment and relief in acute case of medical illness. And it is a relatively new subspecialty in India that has been introduced since last few decades. And in West Bengal, our institute is the only institute that provides a 24-hour emergency psychiatry services to the patient in association with the indoor and outdoor facility. And we can see here that majorly patients belong to the age group of 21 to 40 years, with majority of them are female. These differences among gender may be affected by factors like perception and judgment about behavior tolerated differently between the sexes. And we can find here that most of the patients were referred from the Department of General Emergency, which is different from other study where the referral have come from the general medicine. The difference may be due to the presence of effective triage system in our emergency department of a hospital. And it has been found that the patient referred from the general medicine and other department are mostly patients who are treated in outdoor. A significant number of patients also came to the psychiatry emergency unit directly, which is not seen in other previous study. Most of the patients presented here with the complaining of shortness of breath, unresponsiveness, and histrionic symptom, which is different from the study conducted by Vogel et al. And Kelkal et al. In India. Delivery self-harm was found to be the most common presentation in certain study like Kumar et al. The reason for acute emergencies such as suicide is less referral to the psychiatric emergency unit in a hospital because these cases are found to be mainly treated at the emergency department on observation basis. And psychiatric treatment is provided to this patient on consultation license basis. On MSc, psychomotor agitation is found to be the one of the important finding. According to the diagnostic point of view, from ICD-10, we have found DCD was the most common psychiatric diagnosis with a female predominance, followed by substance use disorder. The most common was alcohol with male predominant, and the patient of bipolar affective disorder. This is contrary to the study conducted by Noskar et al., where delirium was found to be one of the common diagnoses. Difference may be due to the fact that the young married female are predominant here in a study population, where dissociative conversion disorder is one of the common psychiatric conditions to be found. We have noted a few rare cases where the patient known case of psychiatric illness presented with some complication. They developed after taking psychotropic medication for a long duration, like acute dystonia, akathisia, neuroleptic malignant syndrome, and very certain cases of post-injection syndrome were also found in our emergency unit. After initial assessment, majorly the patient were given pharmacotherapy, which accounts for 64%, and sent back to home after initial management, and brief psychoeducation was provided to the family member and to the patient depending on the diagnosis. And a number of patients, which accounts for 17.5%, were primarily diagnosed with organicity. They were referred to other department according to symptomatology for further management. The major limitation we can found in our study was COVID-19 pandemic, which posed a restriction of transportation due to the effect of lockdown, result in limited sample size. Moreover, one of the important limitation lies in it being a tertiary care hospital-based study. The findings may not reflect the current pattern of emergency care on a large community basis. Thus, we can see that with increasing in mental health care burden, it has been important that emergency psychiatry, it plays a very important role to manage acute psychiatry emergency situation, which can be life-threatening. To improve the service of the mental health care, increased awareness is needed, and facilities in government hospital should be provided to treat acute psychiatric condition for 24-hour basis should be made available for reducing mortality and morbidity associated with various mental illness. Thus, we hope the result from this study could help in gaining knowledge regarding emergency psychiatric condition and would preparedness for the rapid management. As well, it would lead to improvement of emergency psychiatry services to meet the mental health care demand in our state. Thank you. These are my references.
Dr. Ravi, do you have any questions? You're on mute.
One, show the study design slide.
So can you see here?
No, show the study designs.
So can you see now?
Yes, yes. Show that slide, methodology. What type of study it is?
Sir, it is a longitudinal hospital-based study.
Okay, prospective means it is cross-sectional, what it is? Cohort, what
Sir,
type of
we have
study?
conducted over a cross-sectional study for a period of 3 months.
Okay, that is you should do mention. Okay, thank you. Go ahead, next presenter.
We have Dr. Harini for our next presentation.
Please start now.
Good morning, all. My presentation is about impulsivity differences between euthemic bipolar and unipolar depression, healthy volunteers, a comparative study. Introduction. Depression is one of the most commonly diagnosed mental disorders among adults. The total population with depression worldwide, according to WHO, is estimated to be 4.3% of world population. Depression is ranked as the single largest contributor to global disability. In India, National Mental Health Survey, which was done in 2015 to 2016, revealed that 1 in 20 Indians suffer from depression. Bipolar depression and unipolar depression differs in terms of cause, severity, symptoms, and treatment process, which was established in various studies. Yet another distinctive feature is impulsivity. Impulsivity has been defined as predisposition towards rapid, unplanned reactions to internal or external stimuli without regard to negative consequences. This increased impulsivity adversely affects the course of both bipolar and unipolar depression by increasing the suicidal risk. This increased impulsivity in bipolar depression and unipolar depression during the disease episodes, as well as in euthemic states, supports that impulsivity is related to mood disorders in general. If this was confirmed, then therapies targeting impulsivity could represent novel interventions for mental disorders with impulsivity at its core. The aim of my study is to determine the difference of impulsivity in euthemic bipolar and unipolar depressive patients. Coming to methodology, it was done in outpatient department of psychiatry in tertiary care center. Study participants were euthemic bipolar and unipolar depressive patients diagnosed based on DSM-5 criteria with at least 2 months of remission. And further, they were under Hamilton depression rating scale, which with a score less than or equal to 7, and Young's mania rating scale, score less than or equal to 12 are taken. Coming to the inclusion criteria, age more than or equal to 18 years of both male and female were taken. And euthemic bipolar depressive patients and unipolar depressive patients with a HAM-D score less than or equal to 7 and YMRS score less than or equal to 12 are taken. Persons who scored less than or equal to 12 on general health questionnaire was included into the healthy controls, and subjects who are willing to give consent for the studies are taken. Exclusion criteria, we have excluded the presence of any chronic physical illnesses and other comorbid psychiatric disorders. Sampling technique is a convenient sampling, and the sample size is 60, 20 euthymic bipolar depressive patients, 20 euthymic unipolar depressive patients, and 20 healthy volunteers. And it is a cross-sectional comparative study. The study period was about June to September 2021. The scales used were Barrett Impulsiveness Scale, which is in revised version, General Health Questionnaire, Hamilton Depression Rating Scale, and Young's Mania Rating Scale. Barrett Impulsiveness Scale, which was first developed by Ernst Barrett in 1995 to measure the person's level of impulsiveness. Here used is the revised version of self-report, which measures, this measure has 30 questions involving 3 facets, that is a motor, attention, and planning. Statistical analysis was done using SPSS software version 16, and descriptive analysis done for socio-demographic factors like gender, age, marital status, educational location. Chi-square test used to compare categorical variable between the groups of bipolar disorder, unipolar disorder, normal people. ANOVA test, post-hoc Turkey test, and independent t-test used for compare mean score of Barrett Impulsiveness Scale for attention, planning, motor facet, and number of episodes and duration of illness. This table shows the descriptive analysis of socio-demographic factors of study subjects. Here, the general gender distribution is about 60% females and 40% were males, and the mean age was 37.63. And the educational status, it is about 36.7 were completed a middle school, and 35% has completed higher secondary, and 15% completed primary education, and 13.3% has completed graduate. And in marital status, 58.3% were married, 31.7% were unmarried, and 10% were divorced. And residents, most of the people were from rural area. And this bar chart denotes in a married group, most of them had bipolar depression, and in unmarried group, most of them had unipolar depression, and divorced. A slightly higher rate is there for unipolar depression. While comparing the mean age within the groups and residential places within the groups, there is no significant difference was found. And while comparing the number of episodes and duration of illness within bipolar and unipolar depressive groups, there is no difference. This line diagram shows that the unipolar depressive patients and bipolar depressive patients had scored high in all the 3 facets, that is attention, motor, and planning facet in Barrett's impulsiveness scale compared to the healthy population. But this motor scale was higher than the 2 groups, that is healthy groups and unipolar groups, in case of bipolar depressive patients. This table shows the post-hoc TQ test done for comparison of Barrett's impulsiveness case within the group. Coming to the results, while comparing the mean difference between Barrett's impulsiveness scale scores for attention, motor, and planning facet within the groups, here the attention and the planning group scored has a significant difference while comparing the unipolar depression in healthy controls and the bipolar depression in healthy controls. While in case of motor facet, there is a significant difference in all the 3. That is comparing unipolar depression, healthy controls, and comparing bipolar depression, healthy controls, and comparing unipolar depression and bipolar depression. Coming to discussion, impulsivity is associated with the mechanisms and consequences of affective symptoms. Schwann et al. Demonstrated that both depression and mania are significantly associated with total and attentional impulsivity. Study done by Henna et al. Showed bipolar and unipolar disorders scored significantly higher than the healthy controls in all the measures of impulsiveness scale. Study done in 2007 found that patients with major depression did not report increased impulsive behavior compared with healthy individuals. The euthymic bipolar patients had impulsivity at higher levels than the healthy individuals. Here in this study, both the inter-episode bipolar depression and unipolar depressive patients had increased total impulsivity than the healthy controls. The subscales attention and non-planning impulsivity has no significant difference between bipolar and unipolar depression. The motor impulsivity was higher in bipolar depression group than the unipolar depression group. Limitations of the study, it's a convenient sampling technique is taken, and it is a small sample size, and it's only cross-sectional study, so long-term associations were not assessed. Only one clinical measurement for impulsiveness was used, and the personality of the patient and history regarding the substance use have not been included. Use of psychotropic medication in this patient, despite being remission, might alter the results. Coming to conclusion, impulsivity score was elevated in patients with isolated inter-episode bipolar depression and unipolar depression, confirming that impulsivity is relatively independent of the mood state. On a motor subscale, bipolar patients were more impulsive than the unipolar patients, and the motor impulsivity appeared to be related to bipolar depression rather than the unipolar depression. This suggests that the motor impulsivity may be a trait that differentiates bipolar depression from unipolar individuals. Thank you.
Hello. Yes, what about the age criteria in this study? How you adjusted age? What type of sample?
Sir, I have taken age group more than or equal to 18.
18.
18. Yes, sir.
Okay. Have you compared this impulsivity according to age criteria? Because in the early age, there is a more impulsive than.
No, sir.
Okay, thank you. Go ahead
Thank
with
you,
next one.
So we have Dr. Harini, our
Okay.
next present. Sorry, you're done. I'm sorry. Dr. Rehan, I'm sorry.
Assalamu alaikum and good morning to all of you. I am Dr. Rehan Matin, third year MD student from the Department of Psychiatry, JNMCH Aligarh. I'm going to present one of the papers on one of the most puzzling disorders of psychiatry, that is the conversion disorder. So we have a brief introduction about Dr. Sigmund Freud, who is considered as the father of psychoanalysis. And he talked about the pleasure principle. He believed that any given process originates in an unpleasant state of tension and thereupon determines for itself such a path that its ultimately issue coincides with relaxation of this tension, that is with avoidance of pain or with production of pleasure. So earlier it was called as hysteria and has engaged prominent individuals in the history of medicine, neurology, and psychiatry. Convergent disorders presents with partial loss of voluntary motor control, altered bodily sensations, non-epileptic seizures, paralysis of one or more limbs, tremor or involuntary movement, blindness and deafness. And if you talk about the cognition is the brain's ability to process, retain and use information, and it includes thinking, knowing, remembering, judging and problem solving. So these are the types of cognitive processes that includes attention, language, learning, memory, perception and thought. These are the uses of cognition that includes learning new things, forming memories, making decisions, perceiving the world, forming impressions and interacting with the world. So we know there is no specific investigation modality is helpful in diagnosing conversion disorder. However, we can use different types of neuropsychological tools focusing on attention, executive functioning, memory, language, visual, spatial skills and social cognition. So these are the research objectives. The first objective is to study the socio-demographic characteristics of patients diagnosed with conversion disorder. And then we applied the neuropsychological tools that includes Wisconsin card sorting test, comprehensive trail making test, and a strict neuropsychological screening test. The last research objective was to correlate between different socio-demographic characteristics and a specified neuropsychological test in CD patients. So coming on to the methodology, this study was done in Department of Psychiatry, JNMCH Aligarh. We incorporated 67 patients with conversion disorder between December 2019 to November 2021. We also included 60 normal age and 6 control subjects. And the cognitive domains were evaluated on different neuropsychological tools that I described earlier. So the inclusion criteria that was included as the diagnosis of conversion disorder as per DSM-5 and the age between 15 and 16 years, both the genders, primary level of education, patients who give consent for the study, and patients who were drug naive or off the drugs for 2 weeks. In exclusion criteria, age less than 15 years and more than 60 years, patients with other comorbid psychiatric disorders and neurological disorders, illiterate patients, patients subjective having visual disturbances, and patients caregivers who did not give consent for the study. So these were the investigations done in all the CD patients, CBC, RFT, blood sugar, serum electrolyte, ECG, and neuroimaging techniques to rule out any organic etiology. Then we have used certain techniques like DSM-5 diagnostic criteria, socio-demographic data sheet, WCST, CTMT, SNST, GHQ, and modified BG Prasad's classification state updated in 2019. So coming on to the statistical analysis, the data obtained for this study was analyzed with the help of SPSS 2017, frequency distribution, group distribution, and Mann-Whitney U-test, along with experiments correlation was used in this study. So coming on to the results, these are the socio-demographic profile of the study participants. We use various variables like age, range, sex, and education. In education, we found that there was significant difference in the categories of education as p-value was significant. It was about 0.007 and it was less than 0.05. In occupation, we also found there is significant differences between the different categories. And similarly, in locality and socioeconomic status, we also found that there was a significant association. So this is the finding with the WCST and convergent disorder. Most of the patients shown mild to moderate impairment, whereas most of the control subjects were normal. In CTMT, we found that there was mild to moderately impairment in most of the patients, and in control group, it was normal. In SNST, we also found that most of the patients had shown brain damaged as per the screening tool, and in control group, it was normal. So coming on to the cognitive impairments in a convergent disorder and control group, we overall tested with the Mann-Whitney U-test, and it was done in all the CD patients and control subjects. And the observed values in all the 3 tests were greater than critical values, and hence this difference was statistically significant as p-value was less than 0.05. We can see from a different correlation technique that we used in experiments correlation. In sex, age, education, occupation, marital status, there was weak to moderate association. In socio-demographic profile of locality, we found that there was inverse correlation in the locality. So coming on to discussion, it's a puzzle for both it's almost all of the physicians, neurologists, and psychiatrists when diagnosing convergent disorder. So we go for the neuropsychological tests, and these are the findings with every socio-demographic characteristics. In age, we found that most of the patients and subjects in the control group were in the age group of 15 to 13 years, and only about 4% and 5% were belonging to the control subjects in the age group of 46 to 50 years. In sex, most of the CD patients and control subjects were females, and they outnumbered in CD patients. In educational status, we found that most of the CD patients were studied up to secondary level, that is about 75%. In occupation, most of the CD patients were students and homemakers. In marital status, there was greater percentage of unmarried individuals, unlike earlier, and unlike in previous studies. In religion, 60% of CD patients and 65% of control group were belonging to Hindu religion. This disparity is attributed because the hospital from where the data has been collected is situated in close proximity to Muslim majority populace, which might explain for the above trends. In locality, almost 64% and 36% of CD patients were residing in rural and urban area respectively. In family type, most of the CD patients and control subjects were belonging to nuclear family. So in socioeconomic status, 97% of CD patients were classified in lower and middle socioeconomic status. So cognitive impairment in convergent disorder, on all of the specified neuropsychological tools, that is Wisconsin card sorting test, CTMT, and SNST, significant number of CD patients were having some kind of cognitive impairment, ranging from mild to severe, varying over different tools. In the present study, socio-demographic profile, sex, age, education, occupation, marital status, religion, family type, locality, socioeconomic status were correlated with the cognition. No previous study has been done, unlike this study. However, many previous studies have suggested that some socio-demographic profile of CD patients play a significant role in disturbance of cognition. So coming finally to the summary and conclusion, several studies have reported certain socio-demographic characteristics like younger age, female sex, a rural population, physical abuse, lower socioeconomic status, and lack of education are associated with convergent disorder. Very few studies have evaluated the relation of socio-demographic characteristics and cognition in CD patients. This study focused socio-demographic profile of CD patients and their association with the cognitive impairment seen in CD patients. Findings from socio-demographic characteristics, a frequency distribution was used, and most of the patients were female in the age group of 15 to 13 years, unmarried, less educated, students and homemakers belonging to rural area, living in a nuclear family, and classified in lower and middle socioeconomic status. In cognitive impairment, most of the CD patients showed mild to moderate cognitive impairment. Almost half of the CD patients had mild to moderate impairment on CTMT, and more than half of CD patients are categorized as brain damage when they are screened on SNST. Almost all of the healthy controls were considered among the normal group. So there was weak to moderate correlation between different socio-demographic characteristics and cognitive impairment in CD patients measured on WCST, CTMT, and SSTD. Finally, the conclusion is made as a specific socio-demographic characteristics: younger age, female sex, less education, homemakers, unmarried, marital status, rural area, nuclear family, and lower and middle socio-economic status were associated with patients of convergent disorder. Most of the CD patients had some level of cognitive impairment. Hence, the present study emphasizes the relevance of socio-demographic profile and cognition into consideration while evaluating CD patients. It is recommended that future studies should be undertaken to assess the cognitive assessment. However, every study has certain limitations. The first limitation of this study is the sample size. We recruited only 60 patients. Secondly, the cognitive assessment of CD patients in this study was done on cross-sectional basis, which is not reliable to some extent, because in convergent disorder, there is waxing and waning course. Thirdly, conventional tools like mini mental status examination could have been used to validate the study. So these are the references, and thank you all of you.
Okay, nice presentation. And any studies for follow-up after conversion disorder?
Sir, in follow-up studies, as far as I have explored,
Follow-up studies on cases.
Yes, sir, on cases, and it was done on cross-sectional basis. There was no longitudinal study, because most of the presentations in convergent disorder symptom presentation there is waxing and waning course. So in between the periods, interim periods, patients is completely normal. So such studies have not been done, had not been done previously.
Okay, thank you. Go ahead with
Thank you.
next presenter. Thank you.
We have Dr. Nitya for our next presentation.
Good morning to everyone present here. So I'm Dr. Nitya Raghavi from Institute of Human Behavior and Allied Sciences. I'm here to present a case study on management of clozapine-resistant schizophrenia, which is a retrospective file review-based study. So schizophrenia is a severe mental disorder affecting around 1% of the global population with a prevalence of around 1.4 to 1.6 per thousand population. The World Health Organization estimates the presence of around 24 million people living with schizophrenia, with maximum population in the 15 to 35 years of age. Despite the low prevalence, it is a major contributor to the global burden of disease and a leading cause of disability, imposing substantial socioeconomic burden as it is associated with greater severity of symptoms, poorer quality of life, chronic hospitalization, and rehabilitation. Despite the great efficacy of the antipsychotic medication over the period of years, the failure to respond to treatment of patients with schizophrenia remains a challenge. Around 20 to 35% of the patients are resistant to drug treatment, a finding that has been consistent over the decades. Clozapine, which is the only FDA-approved and treatment of choice in treatment-resistant schizophrenia. Even with optimal treatment for an adequate time period, around 40 to 70% of the patients do not show any response to clozapine monotherapy. And these patients are designated by the term clozapine-resistant schizophrenia. Patients with clozapine-resistant schizophrenia in comparison with the TRS have significantly higher severity of illness and poorer quality of life, requiring chronic hospitalization. So, to understand the definition of treatment-resistant schizophrenia, we are all well aware that the treatment-resistant schizophrenia definition started with the Keynes criteria in 1992, which was based on 3 antipsychotic regimen over a period of years, adequate time period. But currently, in this study, I have adapted the modified Keynes criteria, which is as follows, which states that there is at least 2 prior drug trials of 4 to 6 weeks duration, which is equivalent to 400 to 600 milligram of chlorpromazine, in which there is no clinical improvement as seen on the brief psychiatric rating scale, wherein the score is more than 45 on an 18-item scale, and at least 2 of the 4 positive symptoms in the BPRS score should be more than 4. And the persistence of illness should be more than 5 years with no period of good social or occupational functioning. And with the definition of clozapine resistant schizophrenia, though there is not a standard definition, but over the period of years, in the recent various meta-analysis, this definition has been approved by the TRIP working group of schizophrenia. So according to the TRIP working group, the clozapine resistant schizophrenia is defined as a patient who is receiving the clozapine dose of around 200 to 500 milligram per day, which amounts to the blood level of serum level of clozapine level around more than or equal to 350 nanogram per milliliter over a treatment duration of 2 to 3 months. Here, the proposed duration of clozapine trials is 2 months for patients with aggression or self-harm, 3 months for those with positive symptoms, and 4 months for those with negative and cognitive symptoms. And the treatment adherence should be around more than or equal to 80% of the prescribed doses for the duration of the treatment. And the response to clozapine is assessed by the following scales, which is the BPRS, which is the Brief Psychiatric Rating Scale, and PANASS, SAPS, SANS, and the Clinical Global Impression Scale. So we take a baseline symptom severity scale, and over the period with the clozapine drug, we see the improvement as the clinical and the functional improvement. And non-responders are told to be patients who show less than 20% reduction in the symptoms and a minimal response in levels of functional impairment during an adequate trial of clozapine treatment. So with this background, I moved on to the objectives of my study. The first objective is to study the incidence of the treatment-resistant schizophrenia and clozapine-resistant schizophrenia in patients admitted in a tertiary care setting with the diagnosis of schizophrenia. The second objective is to study the various antipsychotic augmentation strategies used in patients with clozapine-resistant schizophrenia. The methodology, the study design is basically a retrospective case file-based study, and the universe of the study is the patients diagnosed with schizophrenia as per the ICD-10 DCR criteria. And the study population were adult male patients from age of 15 to 60 admitted in a tertiary healthcare setting with the diagnosis of schizophrenia. The duration was around 2 years, which started from September 2019 to September 2021. And the selection criteria, in the inclusion criteria, I have taken the patients who are diagnosed with schizophrenia as per the ICD-10 DCR criteria, admitted as inpatient in IBAS hospital. And we have taken adult male patient who are more than 18 years but less than 16 years. And the exclusion criteria is the presence of any other comorbid axis 1 disorder, as well as debilitating any neurological illness, which might have an impedance to the assessment of the patient. And as we all know, smoking reduces the clozapine serum levels. So I have ruled out the patients who are having mental and behavioral disorders due to tobacco dependence. And third is the non-compliance to treatment. So the results of my study were the number of patients who were admitted with the diagnosis of schizophrenia were around 212 in number over the period of 2 years, out of which the response to treatment with antipsychotics was shown by around 170 people, which is 80% of the population. And the treatment-resistant schizophrenia, as I have already told, by using modified Keynes criteria, were around 42, which were 19% of the population. Further, these treatment-resistant schizophrenia patients were given clozapine, and the response to clozapine was seen using the TRIP working group resistant schizophrenia criteria, on which the responders were 36, which is 17% of the initial 212 population, and the clozapine-resistant schizophrenia were around 8 patients, which is 3% of the 212. But if we see about the from the TRS criteria group, it is around almost 20%. So further, the clinical profile of the clozapine-resistant patients that I have seen, the mean age of the patient was around 42 years, and the mean age of onset of illness was around 20 years. And 3 of the patients had family history of schizophrenia positive and other 5 didn't. And the majority of the subtype of schizophrenia will fall into undifferentiated schizophrenia type, which is 5 patients, followed by paranoid schizophrenia. And the mean duration of the illness was around 20 years. The mean dose of clozapine every patient received was around 680 milligram per day. Non-compliance to treatment among these patients were around 6, and the mean number of hospitalization that they required, which was 5 in the whole duration of the illness, with duration of the stay in the hospital mean for each patient was around 3.5 years. So my study, the second objective of my study was to study the antipsychotic augmentation, which is used in clozapine resistant schizophrenia. So to augment clozapine, there were 3 preparations, which is the oral preparation, depot preparation, combination preparation. Though the number of people were significantly less, but there is no robust evidence of what is the augmentation done for clozapine. In my study, among the 8 patients, 2 patients showed improvement when augmented with oral preparation of aripiprazole and risperidone. And 3 of the patients showed improvement with haloperidol decanoate in augmentation with clozapine. And 3 other patients showed a combination preparation augmentation improvement. 2 were showing improvement on haloperidol decanoate plus amisulpride with clozapine, and 1 patient showed with zuclopentixol decanoate and risperidone and clozapine. Thus, the limitations of my study were the sample size are relatively very small and comprised of only the inpatient admission patients. Hence, the results cannot be generalized for the whole population. And again, inclusion of only male patient for the homogeneity of the sample may have compromised the representation of the general population. And again, another thing was the lack of the clozapine plasma level monitoring, which is quite expensive. And in a government setting, we cannot afford that for every patient. But according to the TRIP working group, as they said that around 350 to 500 milligram if we give, they will be having around 350 nanogram per milliliter of clozapine level. So we have taken into that consent that as the mean dose of the clozapine they were receiving were above that range, so the patient would have had adequate clozapine plasma level. The current study reviews focuses on the antipsychotic augmentation of clozapine in patient, but other pharmacological agents like mood stabilizer, antidepressant, and further modalities of treatment like modified ECT or psychosocial treatment are lacking. And again, the major and significant limitation was the COVID pandemic, because of which there were limited number of inpatient admissions, which might have led to the reduced number. Concluding my presentation, we all know clozapine is a proven drug in treatment-resistant schizophrenia. However, a significant proportion, as I have told, around 20 to 35% of the patients does not respond to the clozapine as well. So further research in the area of management of clozapine treatment schizophrenia is necessary, especially in the Indian subcontext with large sample size. So here are my references.
Okay, nice presentation. And what is the sample type of sampling in this study, and what are the stats used in this study? These are the 2 questions.
So the study that I have used is a retrospective file case-based study over a period of 2 years. So from September 2019 to September 2021, we have gone through the file cases and with the diagnosis.
Type of sampling I am asking.
So type of sampling, it was more of a case review based sampling. So it was like whatever patients were diagnosed with the schizophrenia, I have taken that into consideration. In
statistics. What statistics you used?
Sir, actually there was no control. It was more like there was no comparison between 2 groups. So it was all like a case record based study. So there was not much of statistics. It is more like whatever I did was a manual case review kind of a thing. So.
Okay. Okay. Thank you. Go ahead with next presenter.
Thank you, sir.
So for the last free paper session, we have Dr. Meenu.
So my study is on emptiness syndrome, its prevalence and predictors in middle-aged adults in Eastern India. This study has been done in Caring Minds Mental Wellness Clinic in Eastern India. So ENS is a psychological condition in which parents experience unhappiness, worry, loneliness, depression from their children's departure from home. The desire to see one's kids achieve their dreams and become independent comes with the consequence of having to let them go and deal with their absence. Research has shown that some parents who are unable to stay alone have close tied with their own identity to be a parent, who have loose family ties, and those who have issues in their interpersonal marriage suffer more. There is also no difference in the reactions of males and females to children leaving home due to attachment and spending more time on rearing the child. Need of the study. Emptiness syndrome is becoming more prevalent in modern time as extended family is becoming less common. ENS leads to significant distress and manifested as clinical depression and anxiety. Indian studies are few, and thus it is important to know the associated psychological factors of ENS to ensure psychological well-being of parent when their children leaves. Objectives. The current study aimed to see the prevalence of ENS in middle-aged male and female adults in Kolkata. Second phase of the study attempts to examine the psychological factors contributing to ENS in terms of temperament, character, family environment, and existential loneliness. Method. Phase 1. Multi-stage stratified random sampling, sample size estimation done, prevalence study. Participants, 1,000 adults between the age group of 45 to 55 years of age, 500 males and 500 females. Inclusion criteria. Age range was 45 to 55 years, both genders. It was English-speaking urban population, middle upper socioeconomic status, assessed using Kupaswamy socioeconomic status scale. Adults whose children have left home for studies or got married in last 6 months were selected. Exclusion, history of chronic physical illness, psychiatric illness, substance abuse, and history of separation or divorce. Widows, widowers, and adults with no children were excluded. Tools used. Emptiness syndrome scale, Jain and Dubey, 218. Procedure, informed consent was taken, ENS scale was administered, prevalence percent for ENS in selected sample was calculated. Phase 2. Independent variable, ENS, adults with emptiness syndrome, adults without emptiness syndrome. Participants, 60 males and females between 45 to 55 years of age, 30 adults with emptiness syndrome, 15 male and 15 female, 30 adults without ENS, 15 males, 15 females. Inclusion criteria. The age was 45 to 55, both gender, English-speaking urban population, and elevation in ENS in study group. Scores in ENS in control group less than 118, no syndrome. Exclusion criteria, history of chronic physical and psychiatric disorder and substance abuse. Tools used, family environment scale, existential loneliness questionnaire, temperament and character inventory. Data collection, participants were randomly selected using fishbowl draw method, family environment scale, temperament and character inventory. Existential loneliness questions were administered. Statistical analysis, Mann-Whitney U-test, discussion and interpretation, results and discussion. Prevalence rate for emptiness syndrome in phase 1, male 15.23%, female 26.45%. Prevalence was found to be higher among females, females being the primary caregiver for children see their departure as a major life transition leading to increased stress. Biologically, around the same time, females undergo hormonal changes owing to menopause. This also contributes to their increased stress perception on being alone. This is the table 1. Adults with ENS tends to have poor communication, effective responsiveness, and involvement in the family. Research suggests that existing family conflicts are heightened in the absence of children, along with lack of communication. Children usually facilitate communication among the family members. This is the table 2. Table 3. Adults with ENS tends to have high harm avoidance and reward dependence. ENS for parents means less recreation and affectional reciprocation received from children, leading to need for high reward dependence. Further, existing insecurity in terms of high avoidance may lead to more distress in adults, leading to manifestation of ENS. Table 4. Adults with ENS tends to have high existential loneliness. ENS means loneliness and often accompanied by lack in purpose in life. This leads to increased existential loneliness in ENS. Table 5. Significant predictors for ENS are existential loneliness, high reward dependence, poor communication, and effective responsiveness. Adults perceiving loneliness would turn to their children for affectional rewards. Conflicts in the family would further thwart these needs of the adults, leading to high distress manifested as ENS in middle-aged adults. Conclusion. In the current study, prevalence rate for ENS is higher in females as compared to males. Adults with ENS have high existential loneliness along with higher reward dependence and harm avoidance. In terms of family, there is low communication, effective responsiveness, and effective involvement. Thus, the study would be useful in gaining better insight about the psychopathology contributing to the development of ENS and formation of comprehensive treatment program. Strengths and limitations. Strength. The present study assists in determining the prevalence and predictors for ENS in order to modify the deficit through therapeutic intervention, bridging the gap in Indian research on ENS. Limitation. Small size, only limited to urban population. Rating scale was used, leading to self-reporting biases. Gender differences for associated psychological factors were not determined. Future directions. Large size sample with inclusion of rural and suburban population. Therapeutic intervention can be done. Gender differences to be studied. These are the references. Thank you. I will call my co-author Megha Rathi to answer the questions.
Okay, nice presentation. Nice study. Okay, what about the sample size? Where did you conducted this study?
It was done in Kolkata. It was a multi-state sampling. So we had divided the zone of the city into 4 zones, like north, south, east, west, and we took it accordingly, according to the sample size estimation done from the formula calculated.
Okay, it is multicentric study.
Yeah, multi-stage stratified random sampling.
Okay, nice presentation. Thank you.
Thank you.
So can you hear me?
Yes, please tell me.
So since you're not here, I'll just give the certificates to the presenters.
Okay, you
On your
can
behalf.
proceed it.
Yeah, because we're already running late for our next session.
Yes. Shall I leave or wait for the pre?
You can just wait until I give the certificates and then you can leave.
Okay, thank you.
Dr. Sabah Aman. Dr. Sabah, she's not here. Dr. Meenu. Dr. I'm so sorry, the chairperson is not here. Dr. Saili. Dr. Saili, she's not here. Dr. Harini. Dr. Rehan. Dr. Nitya. We are done for this session. We are going to start with the next session in 2 minutes.
Okay, thank you all for the presenters. I'm leaving. Thank you.
You're welcome, sir.
आप भी ले लीजिए, नहीं लंबा लीजिए, पोर्ट्रेट। क्लोजअप पे देखें, वीडियो लीजिए ना, शॉर्ट वीडियो, तो उसमें वो करके फिर मेरा आ जाएगा, फिर थोड़ा सा उधर का ले लीजिए। नहीं 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 नहीं, पोर्ट्रेट।
Dr. Ravindra, are you there online?
Yes, I am. Am I audible?
So we'll start with the session. So should I play Dr. Roshan's video first?
Yes, the sequence will be Dr. Roshan, followed by Dr. Jaswant, who is also there online, I believe. And the last speaker will be myself.
Okay. So for our chairperson today, it's Dr. S.D. Singh. He'll be chairing the session for today. He's present here in the hall. I would like to invite him on stage. One, we have a video recorded lecture. We'll play that first. Okay. So we'll start with Dr. Roshan's video.
Good afternoon, everyone. My name is Dr. Roshan Khan. I'm a Department of Psychiatry and National Development in India. In today's symposium, I will be presenting on community-based telemedication for delivery of mental treatment during COVID-19 pandemic and India. Treatment in India. Model which is being used in India, and then I'll be sharing the COVID-19 experience. So this will be outline of the presentation. As all of you are aware, globally, this is 2% of world people are dependent on alcohol or drugs. There is no line last. And opiates are one of the most problematic illegal substances in the world because they are highest contributor to disability and life years and useful drug use among the illegal substances. More than half of the deaths in men nevertheless are contributed by illicit drugs. Most problems related to drugs disorder. Good morning. India, because India's geographical location, where it is situated between the and Golden Triangle. It is a destination country for the and not only for the trafficking but also the destination. Can you do it from one? It's a young country with more than 18% world population, 20% of world population to age bracket. Most commonly tobacco and cannabis I is exposed to opioids around Southeast Asia, which are the largest region in the world related opioids. So you can do 12 to 1. The golden substance, Iran, Pakistan, Afghanistan. It is OCD. I'll send you the photo of the session. Which one? Now, okay. I'll just say WhatsApp it. Yeah. All right. Thank you so much. Which are contributing to the production of opioids. And India is located between these two regions, and it is the country with trafficking of illegal opioids. It is also especially for illegal opioids. After the latest epidemiological study which was conducted by National Drug Dependence Treatment Center in 2019, they found that there was it's around 4.5 years that students will be utilizing it. And for the adults, more than year, it's around 12, which is mostly the problem of the adults and even in the young population, not yet. If we see the top states in India in terms of the prevalence, there are two regions. One region is Punjab, Delhi, Haryana, which is nearer to the Pakistan border, the northwest part of India, and then the north of India, which is closer to the Golden Triangle. In terms of the number of opioid users, the most number of people who are using opioids, followed by Punjab, Haryana, and then Maharashtra. Delhi comes sixth in India in terms of the number of opioid users. Now, if we compare this statistic with the global opioid users, we can see that on cannabis, cocaine, and amphetamine-like stimulants, the Indian less than the global prevalence. However, for the opioid, the global prevalence is in India it is 2.06%, which is much higher. So, opioid is a major public health problem and emerging problem in India. So, there are growing number of opioid users in the country. Significant unmet treatment services gap are there. Also, people are shifted from natural opioids to semi-synthetic or synthetic opioids. And there's also significant increase in number of drugs, which was mentioned in the national survey. If you see the journey of opioid substitution therapy, the Mukta field was started as a year 1989, started in the day and followed by that initially law. The major pool came from National Cultural Organization. They opened up between 1 and 2% of the NAC. Followed by that, there was a rapid increase in and by 2016, we had 213 open. So the domestic but are not only in a 5 years. Across different government hospitals and like other parts of came first and followed nothing but India is nothing much other than so if our conductor which are coming in and move forward. We have the left side like later type of state or we put it in that right process. Natural and not all the disorder patients. Then show our medication group that those who are methodology. Now, community-based being delivered for more than 30 years, and family delivered to treatment centers and outreach clinics. So, mobile measurement land is a model of video started in 2009. And there was also establishment of short-term free of cost treatment services with management team member staff. This is Dr. Nelson Counselors, supported by your health and science. The major challenges to committee there's the human resource challenges like awareness of training, awareness of training of then there is the issue of funding, lack of funding for so in a way because of train human resources, particularly the psychiatrists and clinical psychologists, in some of the centers, including our center, who have been trained in superior treatment and opioid overdose in the treatment of and it seems to be good in those now. With this background, the COVID-19 pandemic came in 2020. The first wave was between June to October 2020, and the second wave came from March to June 2021. This has actually posed many challenges for the existing opioid agonist treatment in India, which was already strained, and which further resulted into our patients who were receiving opioid agonist treatment being affected. So then, if you see, there has been global efforts to understand what should be the healthcare response and how the healthcare response is being delivered in response to COVID-19, including in India, and which of the digital technology services were used for the delivering opioid agonist treatment services or streamlining opioid agonist treatment services. And in this survey, which was conducted by International Society of Addiction Medicine, we found that 23% of countries reported specific podcast, 68% reported online service helpline, 37% countries reported specific mobile application, and more than 75%, like 27% reported online therapy services, and 88% reported counseling using the telephone. So if we see in India also, some of the services like counseling using telephone, then reported online therapy services they are being now increasingly used after the COVID-19 pandemic. So COVID-19 pandemic threatened already strained treatment system, and serious restriction of movement resulted in dropout from treatment, inability to obtain opioid agonist treatment. New patient registration decreased due to diversion of resources for COVID-19 management. And there was a lot of myths and stigma related to substance use treatment and COVID-19 pandemic. Like many people thought that the patients with substance use disorder are more, prone for the COVID-19 pandemic and more likely to spread COVID-19 pandemic initially. However, we have not found any such features or any such measures. And there was also some myths that the medication taken for the management of substance use disorder may impact the treatment of COVID-19 pandemic, but that has not found to be true. At the same time, although it has brought many challenges and problems for the existing system, but there were some good changes also. There was a boost for telemedicine. There's a further reducing threshold of treatment services like take-home medications, increase in overall awareness about health, nutrition, increase in compliance, and also there was an increased budget, overall health and infrastructure. So that is some of the good challenges. Now, what are the digital technologies for delivering opioid agonist treatment services? And what are the things which have been done in India? So web-based self-help interventions are one of the commonly used digital technologies, and web-based training programs for healthcare workers, paramedical workers, which were mainly used for the training of the human resource. And then telemedicine. So the telemedicine is using teleconsultation for dispensing of medicine and consultation by physician and giving the remote consultation to the patient. However, the telemedicine guidelines issued by Government of India does not figure opioid agonist treatment. This you can see at AIMS how the telemedicine consultation is being given using various apps and various projects like ECO, and also there's a huge telemedicine department at the AIMS. Now, to be able to deliver telemedicine, we must also have the robust digital record system or patient information management system, because that comes handy when delivering the intervention or delivering the dispensing the medication. So clinical workflow automation is one of the such method which can be used, and we use this method to build an online platform for the patient information system. So in this platform, we could actually see the number of registrations, the medication dispense, the dose, and the follow-up visits, how many follow-up visits are done, etc. And it also shows the calendar where the patient has taken the medication or not, or it has taken or not. And there are various other parameters, basic parameters. So with this system, actually, this was already existed in our clinic before COVID-19 pandemic, and this has actually helped us to build on the telemedicine services. There are follow-up details also, treatment details also. So the advantage of this system was doctors could access data for the patient remotely. Confidentiality of patient was maintained because it was only accessed by the doctors and staff of the clinic. Tablet with the software provided to the nursing staff at the methadone van and dispensing in the clinic. Nurses could view the instructions and medication dose prescribed by the doctors and give the doses accordingly. So it was a very handy system before we introduced the telemedicine. So once the lockdown started in 25th March in 2020 in India, so there was a restriction of movements like doctors, staff, patients, and van movement. There was also risk of crowding at the clinic and near the methadone van. There was also fear of COVID-19 pandemic, not only among the patient, but also at the staff and the at the clinic. So that actually compelled us to take number of steps and introduce a number of innovations in our existing system to counter these challenges. So one of the things we did was giving the take-home medication. We started giving methadone twice a week. This was the first time we have given the take-home medication, take-home methadone. Buprenorphine was given 1 week to 2 weeks. That was also, the time was increased also in NACO opioid agonist treatment center. Also, that has helped us in reducing number of patients per day and also reducing the number of staff per day with the use of adequate PPE for the staff and social distancing. Then we started telepsychiatry services on site. So in telemedicine services, digitalization records, which was already done, as I explained in earlier slide. We also started teleconsultation only for the patients who were already registered in clinic and receiving the medication. So we started with the Skype, which is the Google service for the online video consultation through laptop in a community clinic. So patients were given an appointment within a week, and around 10 to 15 patients were seen per day through the online teleconsultation. Those was also adjusted to the software by the doctors, and psychological support was provided online. So this is how we have actually giving the consultation. This is the digital record system, and this is the online consultation being given to the patient. Now, mobile methadone van started in 2019, average 300 patients per day. Telemedicine services started at mobile van in July 2021. So, for the patient satisfaction services were good as treated by the patient, but we also actually, this is actually the add-on. The telemedicine services were added to the mobile methadone van, which is already easy to access and low threshold treatment services for opioid agonist treatment. Now, some of the challenges we faced during the medication assisted treatment delivery, that there was a lot of background noise because the van was situated on the road, and sometimes it was actually difficult to conduct interview because of the noise. There was also network problem because it was again located in an area with a less network. Some patients had a difficulty in using technology. Also, it was difficult to ask sensitive questions because of the privacy issue. And there is also restriction in physical examination and referral services. However, at the same time, there were a large number of benefits of TMAT, primarily able to include patients who had dropped out of treatment, missed treatment, and required dose adjustment. Also, we were able to provide minimal psychological support when required, and teleconsultation could be done 6 days a week, able to address problem faced during day-to-day functioning. And most importantly, we could save the cost and time for the patients, and because of that, it became popular among the patients. So we also evaluated the TMAT services through the self-report online Google questionnaire and client satisfaction questionnaire. The average score was 26/32, high satisfaction rate, and the convenience was almost all the patients reported that it's convenient, and average money saved was around 300, that is $4 per month, which is around 3 to 4% of their income. So we could actually save the 3 to 4% of patients' income using this simple technology and simple innovation. There was a privacy-related issue. 70% almost dissatisfied due to the privacy issues, which were addressed subsequently. The other challenges which were faced because to the TMAT were it intentionally taking low doses of medication to increase the duration of follow-up by the patient. Because every time the dose adjustment is done, patient has to go to the on-site clinic for the consultation, and patient started avoiding this thing by reducing the doses. Then diversion of methadone also, patient trying to manipulate to increase the dose for diversion purpose, and patients not wearing the mask properly. So what learnings we got from this experience was digital technology. Integration of digital technology in delivery of opioid overdose treatment is feasible. It is easy to use. It is cheap, one-time investment, and maintenance charges are minimal. It is convenient not only for patients but also treatment providers, and it is also very safe because practically there is no face-to-face interaction or immediate the social distancing could be maintained. It is important method for treatment with increasing number of smartphone users. Basically, smartphone users, because it is possible to deliver this intervention through app as well. So to conclude my presentation, opioid use disorders are public health problems in India, and the coverage of opioid overdose treatment and treatment gap prior to COVID-19 pandemic was huge. And this COVID-19 pandemic threatened the existing training system. However, at the same time, there was a major boost to telemedicine, online training programs, and this has actually compelled us to integrate digital technology in clinical practice. TMAT, the services which were started at NDDC, has the potential to improve access to treatment, not only during lockdown situations like current pandemic, but can also improve access to hard-to-reach areas. I would like to acknowledge nursing staff and support staff for their continuous involvement in this TMAT services, because it is the ground staff, nursing staff, which were dispensing medication, and the other support staff, including security guard and mobile van driver, who were actually important stakeholders in delivering successfully TMAT services in the community. With this, I would like to conclude my presentation. Thank you. If you have any questions, clarification, you can get back to me, or you can post in a chat box. Thank you.
Thank you, Dr. Roshan. You had done excellent. And now I would like to invite the next speaker, that is Dr. Deepak Yadav. Sorry, Dr. Jaswant Jagra.
Yeah, thank you, sir. So today I'll be talking about delivering telemedication assisted treatment during COVID-19 pandemic. I will be covering my presentation with the following headings, beginning with the introduction and a brief about TMAT services. I'll also tell about the study that we conducted regarding the telemedication assisted treatment services, the objectives, study design, outcome measures, and the findings and the conclusions. So as we all know, opioid use disorders, they account for the largest burden of the disease attributed to the drug use as per the World Drug Report. So like in the recent report of magnitude of substance use, in India, it was found that heroin is the most common form of opioid use, and the estimated prevalence of current use of any opioid is around 2.1%. And a significant number of people, around 8.5 lakh, they inject drugs, mainly opioids. So as we know, and study conducted by Dr. R. Rao and his team, we get to know that the coverage of opioid agonist treatment is abysmally low. That is, only around 1% of the patient are able to receive opioid agonist treatment. Also, there is poor retention for the opioid agonist treatment, which is a significant problem. Also, it was suggested that the community-based treatment for the opioid use disorder should be initiated and is helpful in increasing OAT coverage and improving retention rate. So, talking about the digital technology for delivering opioid agonist treatment services, as Dr. Roshan told about this in the detail. So I'll briefly touch the topics uh, which are not covered by sir. So mainly this telemedicine assisted treatment, that is TMAT services, it includes three components, that is patient online registration or dispensing system, telemedicine platform, and communication hardware. So the patient online registration and dispensing system, it is a clinical workflow automation based digital platform. It is used by physician for giving dispensing instruction and by the nursing staff for the actual dispensing. So there is provision of capturing basic socio-demographic and clinical details using intake performa, and also the biometric details including photograph is also captured along with the verification of mobile number. So it helps in avoiding duplicate patient record, which is very commonly seen in the patients of opioid use disorder. Uh, Telemedicine, so telemedicine platform is a patient physician real-time video consult platform. So at the patient's and at our center, which is located in the East Delhi, the Sundarnagari area. So here we installed a computer tablet using pre-installed Skype software at the patient's end and a laptop with clinical workflow automation-based digital platform, and using the same software Skype for the connectivity. This software was developed in-house for the patient's identification, registration, and dispensing management. So the communication hardware, we used a wired headphone at physician's end, compatible for the laptop, and a microphone at the patient's end with compatibility to the connected tablet, which is mounted on the mobile methadone dispensing unit. For better communication, as Roshan sir mentioned, that usually the mobile dispensing when usually they dispense medications roadside for the age of the patient. So like there is a lot of noise. So for the better communication, we installed microphone and headphones. So the next one is we have a good system at Sundarnagari community clinic that using patient listing, if we input the registration number, we get the details of the patient. We get the details with we get the details of some social demographic details of the patient, along with the follow up with the doctor or with MSSO. Also, we get the other details like substance use details, along with the opioids, other substances which were used during the last 1 month, if the patient is still injecting or not, other medical illnesses or psychiatric illnesses, and if the patient is compliant to the treatment or not. In the end, we do fill the treatment details, the plan of treatment, and the type of medication, their dose, and the next follow-up date for the patient, dispensing type, and the dispensing plan. So this for this clinical workflow automation, the doctors can access the data of the patient remotely, and here the confidentiality of the patient is maintained, that the access is only by the doctors and the staff of the clinic, and other people cannot access. The tablet with the software provided to the nursing staff at the van, so they can get the prescription which is filled in and submitted by the doctor, and then they can view the instructions and they can dispense the medications which is prescribed by the doctor. So yeah, digitalization of record was already done and both before COVID pandemic, and both the staff and the doctors were comfortable with the digitalization. Many patients who missed the doses and required follow-up by the doctors, so they were followed up on the days other than the clinic days. This teleconsultation was initiated only for the patients who are already registered in the clinic, and the patients were communicated using Skype through the laptop in the community clinic. And the patients were given appointment, preferably within a week. And during the daytime, around 10 to 15 patients were seen using these services, this service. And the psychological support was also provided online. So the study we conducted at Sundarnagari, so the objective we had to assess feasibility of community-based telemedication assisted treatment for the delivery of methadone maintenance treatment at the mobile methadone dispensing unit. It was a single arm prospective study conducted at Community Drug Treatment Clinic run by National Drug Dependence Treatment Center. So the patients who were included, all the patients were male who were registered for methadone maintenance treatment. The patients of age between 18 to 65 years were included, and all those patients who are availing these services at the mobile dispensing unit were covered. The patient who refused informed consent were excluded from the study, and the ethical clearance was obtained from the AIIMS New Delhi. The patients who were enrolled for the methadone maintenance treatment program were invited to join the study. After obtaining consent, the information was collected by the video call by the resident doctor, and out of the 115 patients, 5 patients refused consent. So we had the sample size of 110, and the patients were recruited in the month of July 2021 and were followed up till December 2021. We used outcome measures of retention rate and perceived satisfaction. So the retention rate was defined as the patient receiving number of patients receiving methadone maintenance treatment at least 25 days a month. Also, the 3 months pre-implementation and post-implementation rates were calculated using the dispensing data recorded in the digital platform. For the perceived satisfaction, the client satisfaction questionnaire was used, and these are the 8 questions, the standard questions used in the CSQ8. So the findings were the majority of the patient were unmarried, around 52%. Around 48% of the patients were married, among which only 4% of the patients were not staying with the partner, and the rest of the patients were on treatment and were staying with their family. Majority of them were educated and received education of high school or more. Among them, around 30% of the patients had primary education, and around 11% of the patients were illiterate. The average duration of opioid use among those patients was 5.3 years. There were patients with the duration of opioid use from 1 year to 15 years. Around 8% of the patients were injectable drug users. For the perceived satisfaction, out of the total number of patients, the average score was 26, which indicates a high satisfaction rate. And the majority that the patients reported, and the greatest score that we got in convenience, all the patients, they reported convenience using this TMET services. Also, average money saved per month was around 300 rupees per month, and which was a significant amount of their income. But a major concern was noted that around 70% of the patients, they reported privacy issues, because at the site where this tablet was located, was mounted, was visible to other patients also. So this was a major issue, and this need to be looked after So also the retention rate that we found out that 3 months pre-implementation retention was the mean duration was 49 days for the patients. However, it increased to 69 days post-implementation of TMET services. So there was significant improvement in the mean duration of treatment retention. Also, the retention rate that is more than 25 days per month, it increased from 53% to 68% from pre-implementation to post-implementation. So I'm concluding my presentation that opioid use disorders are public health problems in India, as we all know. So the community-based telemedicine assisted treatment, TMAT, this is feasible, low cost. It is easy to implement, very user friendly. It reduces the treatment cost for the patient and also increases their retention into the treatment. So effectiveness of the model vis-a-vis faith consultation need to be studied in larger sample and longer period of observation. So I would like to acknowledge our nursing staff and support staff for their significant support in collecting data and in assisting the patients. My colleague, Dr. Deepak MB, and my teachers, Dr. Ravindra Rao and Dr. Roshni. So thank you.
Thank you, Dr. Jaswant. I think we can have the discussion at the end. Can we go to the last paper, Dr. Ravindra Rao? He is talking on providing addiction treatment services in India during COVID-19, experiences and learning from community drug treatment clinic.
Am I audible?
Yes, you are audible.
Yes, sir.
Thank you. Talk about particular aspect of what changes being made. Sorry?
Yeah, intermittent voice issues were there, sir. Now it's good, sir.
Now, okay, thank you. So my previous two speakers have talked about different facets of changes that we made or modifications we made in our community clinic for providing addiction treatment services during the COVID-19 pandemic. It was challenging for many of us. We are aware of that, providing services, both the consultation services as well as for giving the medications. So that has been a challenge, but we, by implementing this community clinic services during COVID-19 pandemic, we have had some lessons. So if you look at the community clinic that we were running before the COVID pandemic started, the situation was that we were treating patients with opioid dependence from a specified catchment area. And we were providing both short-term as well as long-term pharmacotherapy apart from psychosocial intervention. So in terms of pharmacotherapy, long-term, both agonist maintenance, that is including buprenorphine, methadone, as well as antagonist maintenance, there is naltrexone. So a whole basket of interventions for opioid dependence syndrome was being provided from this small community clinic. We were dispensing both buprenorphine and methadone on a daily basis because we were operating within a specific catchment area of about 5 to 7 kilometers. We believe that patients would be able to come on a daily basis, take their medications and go for their work as well. In fact, for improving the access to medications, what we also did about 3 years, that is about in 2019, we also started dispensing methadone through a mobile van for those patients who are living in the periphery of this catchment area. We were registering new patients twice a week, and the daily footfall at that point of time was about 500 to 700 patients in a day. So about 500 to 700 patients would come to this community clinic or the mobile van and drink or consume their medications in front of the nursing staff. So that is how the pre-COVID situation was there. Now, the challenge for our clinic was that there was a nationwide lockdown due to the COVID-19 pandemic from 25th March. So there were severe restrictions on travel including shutdown of public transport as well. So also the other challenge was that where these clinics were located, because they were in busy urban setting. So this clinic also had sizable number of COVID-19 positive cases. In fact, there were some containment zones which were there within the catchment area that we were working in. It also was difficult for the staff to reach the clinics because of public transport not being there, or even private vehicles. There was restriction in movement. Now, there was difficulty for the patients as well in visiting the clinic daily for receiving their medications due to restrictions on travel. So we also were afraid or apprehensive of possibility of overcrowding in the clinic premises. Because if that happens, then the local law enforcement authorities may also react adversely to the clinic, and that would have led to a problem because one was not sure whether addiction treatment will be taken as an emergency service or not. So that was that was an issue. So we didn't want to be on the wrong side in that sense. There were blockade of roads because of the containment zones, and it was making it difficult for the van also to reach its destination. So all of these issues were challenging, were challenges that we had encountered. So we had two options. So one option is that you close the community clinics, and our main center was operating at that point of time. So we asked the patients to come to the main clinic and take treatment there. As I said, addiction treatment can be seen as a non-essential service in that sense. So that would have been that we would have been legally right. There was not a problem, but morally we did not feel that that was an option. The second option was that you modify the functioning of the community clinic to make it safer for the patient as well as for the staff who are operating the community clinic. So we took the second route of modifying the functioning of the community clinic that we were operating. So what did we do? One is that we changed our dispensing regimen from daily dispensing to take-home dispensing. Now, with regards to buprenorphine, take-home of buprenorphine was an easy decision because the formulation which is given as a take-home medication, that is naloxone formulation in combination with buprenorphine, was available, and take-home was practiced in other places, including in our main center. So that was an easy decision. We could do that. There was a challenge in giving methadone as a take-home because that was the first, before that it was never dispensed as a take-home, not only in our clinic or center, but anywhere in India. That was not the case. Existing narcotic laws did not explicitly forbid take-home. They are silent. So they have not said that it should be compulsory daily dispensing. So they have not forbidden take-home as such. But there was fear of diversion, and most importantly, because methadone is a full agonist, we were fearful that there may be related overdose that can lead to problem with this. But what we did was we made use of this opportunity. Methadone is given as take home in some of the other countries outside. So what we did was we allowed take home of both buprenorphine and methadone, and that is what has been followed in other clinics also, which we are supporting indirectly, which provide methadone. So this is how the take home methadone was initiated, that the person would come on the day when he has to collect his medication. He'll consume his dose of methadone in front of us only. For the remaining 3 days, 4 days, we would give it in bottles. Every day's dose was filled separately in each of these bottles. What happened as a result of take home was that it helped in reducing the daily footfall from 500 to almost 150 to 180, so almost 1/3, because we are giving medications take home for 3 days. So it helped us in reducing the footfall. So what meant as a result of that was there was reduced exposure of patients and staff to each other. So potential contracting of COVID-19 to each other was minimized as a result of this. Now, what was also interesting was that because the dispensing points, either the clinic or the take home, was located near the residence, it was easy for the patients to access the medication or to come to these halt points for taking the medications, even during lockdown. So that is something, because within the area, movement was not that much of a problem. When the law enforcement authorities, the police were explained that they are coming for medications, they could understand that this is an important medication which they need to take. So that was something which happened. The daily staff strength also was reduced in these clinics, thereby ensuring staff safety. Safety protocols were put in place, as was done in all the healthcare settings everywhere else also. Regular sanitization of the clinic was done. We also ensure that there is social distancing maintained by the patients when they come to the medication. So if you see here, we have this mobile van which dispenses methadone, and the patients are waiting for their dose at a safe distance from each other. This is a nursing staff who are in full overalls, protecting themselves and protecting others also from COVID-19. We stopped registration of new patients for the initial 3 months when the wave one was there. And also compulsory renewal of treatment by doctors was removed. That requirement is removed. And teleconsultation services were initiated for those who require consultation in terms of modification of dose. So those things we did. My colleagues have mentioned already what services we started, that is the telemedicine assisted treatment. And Dr. Jaswant has also spoken of what the benefits of this have been. So this was only for patients already registered in the clinic through Skype, through a laptop in the community clinic daily from 9 a.m. to 1 p.m. Because the patients had to visit the clinic for collecting the medication, they attend the Skype call from there, and the doctor would provide consultation online from home itself. The dose adjustment and instruction to the nursing staff for doses were provided through the software, which already was being used in the clinic since the last 4-5 years. So in this manner, even through this telephone consultations were provided to about 10 to 15 patients on any given day. The post-lockdown, what we did was we have opened up new client registration have started. Though in wave 2 and wave 3 also, we had to halt new registrations for some time. Physical consultations have resumed here. Take-home methadone has been continued. So twice a week for both buprenorphine and methadone, depending on patient to patient. And the numbers, in fact, now have exceeded pre-COVID levels because of ease of the patients to take their medication. So because of take home, so that is there. We had only 2 healthcare workers before the wave 3 that they had turned COVID positive till date and recovered completely and resumed the duties. Of course, in wave 3, many healthcare workers they turned positive because of the high infectivity of that particular strain. Even other community clinics which are operated by NTC, they also have used similar approaches, like I have discussed in this for this clinic as such. So what is the lesson that we learned? We learned that locating treatment services closer to patient's locality, either through static clinics or through mobile van, has eased or eases treatment access. And that is something which is very important for opioid dependence treatment when we talk of opioid agonist treatment. Take-home buprenorphine methadone have helped in reducing client load as well as patient travel, and we saw the benefit of that during the COVID-19 pandemic. Digitization has helped in initiating teleconsultation services as an emergency response, and because the patients liked it, so we have continued that even after the lockdown. So what Dr. Jaswant showed that there is saving, there is improved retention rate, there is improved, there is greater client satisfaction. So those are the things that have been helpful for the patients. Of course, we need to see the impact of take-home doses. In fact, take-home methadone, we have conducted a study on what is the benefit or what is the impact of take-home methadone compared to the daily methadone. That we are still analyzing the results of that. We have collected the data already, but we are into data analysis at this point of time. Thank you. So that was in brief about what lessons we learned through implementation to the community. Thank you.
I think with that we conclude the presentation of all the papers. And
Yeah, if you have any questions, you can ask, or any discussion you want.
those who are attending can go ahead with the questions, and I hand over the mic to the chairperson.
Hello. My question is Dr. Ravindra Rao. Because can you tell me the clinic of community drug treatment can be generalized in district hospital, particularly the remote area in Rajasthan, like desert area. We in the Rajasthan, particular the opium dependence is the huge problem, and in lockdown situation, they feel a lot of trouble for there, because in Rajasthan there is no such kind of facilities available from here. So what's your view regarding this community drug treatment clinic in particular, your experience as well as your suggestion to the our state?
Thank you, sir. No, I mean, we have been implementing this community drug treatment clinics since the last 20 years also. So we have had fair experience, and what we have seen is that locating a clinic closer to the patients, where the patients are, is very helpful in ensuring treatment access. So in that sense, it is very much possible. District hospitals, I mean, medical college can take up, the Department of Psychiatry can take up such community or establish such community clinics in district hospitals or even PHC in a village with a sizable number of opium dependent patients. It is very much possible. In fact, that is something which we have published a couple of papers on that. That is something which is very much required for our country, because in every place we can't have a psychiatrist. Like the community clinic, you don't require the medical officer and the counselors, etc., to be present on a daily basis. We require the nursing staff to be there on a daily basis for the daily dispensing of medication. The doctor can visit twice a week. That is good enough, where the patient will be, new patients will be seen, the follow-ups will be done. So that is very much possible. So this is something which needs to be scaled up on a in a big way.
One more problem in the community drug treatment clinic, that is the legal problems. Sometimes covert medicine is given, like the patient individual has the COVID positive and their relatives has come to the clinics and they take the treatment for their opium dependence. So what is your view regarding this? Is the legal issues, very big issues in narcotics law?
Sir, in the laws, there is no explicitly, it has not been written that it should be given or it should not be given. So law is silent to that extent. The important thing is that we are, I mean, we should have enough safeguards to ensure that there is no diversion. It reaches the patient who requires it rather than this being sold, because we know that there is a good black market demand for these medications. So what we do is we don't give take home immediately soon after initiation of medication. So after a 3 months period or so, at least the patient should be on daily dispensing, after which only we provide take home. And that also is not that every patient after 3 months will be given take home. It will be as on demand basis. For example, if the patient's work is such that he is not able to come to the clinic on a daily basis, we can give him alternate day medication or bi-weekly dispensing can be done. At times when the patient is not well, like you said, that COVID. Now, sometimes what happens is somebody else says that the patient is not well, so please give the medication, I'll give it to the patient. We have strict this one, that it is only the mother or the wife or the father who has to come. The COVID-19 certificate has to be shown, or at least the COVID positivity has to be shown to the clinician, and then only we'll be providing these medications as taken. So those kind of safeguard measures have to be instituted before we blanketly give this medication to anybody in the name of the patient.
One more question. Safer medication is the buprenorphine and naltrexone combination or methadone in this clinic or particular this situation?
Yeah. Sir, our clinic is one of the few clinics where you have both of these medications in the same place. In majority of the countries also, if you see, there are separate specialized methadone clinics and you have office-based practice of buprenorphine which is followed. This clinic is one of the few clinics where in the same place you have buprenorphine, methadone. In that sense, the patient has a choice to use either buprenorphine or methadone, whatever they feel like, whatever the choice is, of course, guided by the physician, by the clinician. So that is there. In terms of safety, obviously, because buprenorphine has a ceiling effect, it is much safer as compared to methadone, which is a full agonist. There is a chance of overdose with methadone if you give higher than the tolerance dose of the patient. But in our experience, what we have seen is that the overdose with methadone, that is definitely a concern, but that is a concern during the induction or the termination phase. During the maintenance phase, you can very well maintain the patient on methadone. We have not come across, apart from a couple of cases, we have not had major issues with overdose with methadone as well. So both the medications are safe if we follow the right kind of protocols and the right kind of safeguards for dispensing these medications.
Hello.
I would like to ask Dr. Arabinder to felicitate our speakers. Dr. S.D. Singh, please.
I can felicitate online, but somebody will have to give the felicitation there itself.
Yeah, Dr. Arabinder is here. He is going to felicitate.
Okay, there is another Dr. Ravindra. Okay. Right.
Dr. S.D. Singh. Dr. Arvind Baran. Thank you so much, everyone. We are done for this session.
Thank you.
I would like to start with the next session. I'd like to invite Dr. Sanjeev Salji on stage for chairing this session. CVs are there. You can call Dr. Samit. He's here.
Good morning, everyone. So we'll invite our speakers for this session, Dr. Ashirumochan Sahu, Dr. Arbinda Brahma, and Dr. Samrat Kar. All three are presenting one online. Okay. So who is first? Dr. Samrat Kar. So briefly introduce yourself and you can proceed with your presentation.
I practice privately. I left our government and private job. We have our own small hospital, 20-30 bedded hospital, and we are running that hospital only. So I am completely in private practice. And we have our co-authors, Dr. Arvind Brahma is there. You must be knowing him. He is our General Secretary, and Dr. Ashirumochan Sahu is our second co-speaker. He is Secretary of Odisha State Branch. Coming to our mental health services, I will be focusing on developing countries, and Dr. Ashirumochan Sahu, he will be focusing on India, and Brahma sir will tell about future direction. Coming to introduction, more than 85% of world's population live in 153 low and middle income countries. So I will use the term this LAMI for low and middle income countries. More than 80% people who have mental disorder are residents in LAMI, low and middle income countries. As we know, there are some studies. Bihar having population of 10 crore, but they have more schizophrenia than North America with a population of 57,000 crore. 57 crore. So mental disorder definitely at risk in these developing countries, low and middle income countries. And there are also risk factor for other health problem. For example, somebody is taking alcohol, is addicted to alcohol, he or she can have liver problem, other health problem can be there, or traffic accident can be there. Coming to impact in developing countries, neuropsychiatric disorder account for 9.8% of total burden of disease. Among total burden, it is 9.8%. Only depression, unipolar depression, accounts for 3.1%, and self-inflicted injury account for 1.5% of all death. So what are the determinants of mental disorder? First is poverty. Poverty and social exclusion, these are well established as risk factor for mental disorder in high income countries, but many studies have implicated in association also in low and middle income countries. And mostly when the people, the patient come to us, they tell, sir, we are not ready for mental disorder because they do not think mental disorder, they have to keep or they have to save money because they save money for heart disease or any kidney renal transplant. But for psychiatric disorder, they have no savings. So it is mostly, they say 40 to 50%, it is out of their pocket. I mean, actually, it is a vicious cycle of poverty and mental illness. Because many people come to us and they tell, sir, we didn't know that it is psychiatric illness. Though we have illness, we could not afford. That's why for schizophrenia, they come after 15 years. Many people, they come, they say, we didn't know there is less awareness in this country. And they tell when we grow elder or bigger, we earn money. That's after that we come for this illness to treat this illness. They think this mental disorder might be so much costly as it is a brain disorder. So this is cycle of poverty, and there is economic deprivation leads to depression. Depression leads to less accumulation. So poverty gradually increases. So what are the challenges? The first challenge, legislation and policy. Many LMICs lack mental health policies and laws to direct their mental health program and services, particularly in Africa and Southeast Asia, in our SAARC countries. Mental health policy and the service guidance in WHO describes many steps, but they are same for all the countries, not contextually for or culturally, it is not different. They have guidelines, or they similar guidelines for all the countries. The second important challenge, finance. Globally, the expenditure of mental health is less than $2 per year. All countries, and it is in low and middle income countries, it is less than 25 cents. And in LMIC, including 15 to 19 African countries, they allocate less than 1%. If you find in India, it is only 0.06%. Last year, we were very happy because they increased the budget of mental health. Now they have allocated 597 crore. But total health budget is 79,216 crore. So it is around 0.5%. They have increased the amount, but still it is less than 1%. Pakistan spends 3.9% GDP on health, among which only 0.4% they spend on mental health. Coming to organization planning, this should be focused, this focus and attention, because there is problem in infrastructure and system, and there is not specific that can allow easy and early access to referral system and sources, including health personnel and availability. And there are those who can link the system. So the most important is psychotherapy. We do not have psychotherapeutic intervention properly. For in pharmacology, we are giving medication, that is okay, nice, but psychotherapy intervention are very few. These are due to main two reasons. One is lack of resources. Second one is inadequate training in these countries. Coming to sharing a population, you can find the red dot and red, there's mental disorder is more. You can find in North America, Australia, few places of South America like Brazil, it is much higher. India is in between, but we can say here maybe in these countries, Southeast Asia, data variability also, data taken is less. That can be a reason also. So coming to mental health service, there are different kind of wide variety of service in developed and developing countries, and most countries share a mismatch between developed and developing countries. So what are our strengths? The weakness, we have many weaknesses, but we can have more strength. We can work in partnership. There can be innovation in practice and transparency in administration. That this will be more explained by my other co-speaker, Dr. Ravin Brahma. So this is our future. This can be a strength. How can we modify? So there is one, just I have put this slide because there is one program that is called PRIME, Program for Improving Mental Health Care. Its aim is to generate evidence on implementation and scaling of integrated package of care for priority mental disorder in primary and maternal healthcare setting. It is Ethiopia, India, Nepal, South Africa, and Uganda. India, in Madhya Pradesh, they have covered 51 districts. Still, they have not covered, they have not tried. This is a pilot study. They're trying to do this, replicate this other states also. So type of health services, we have international and national. International WHO is there. We know they have a comprehensive integrated response plan, but this is same for all the countries. It is not different. They have not differentiated between the low countries or low income countries and different for different culture. And we have a World Federation for Mental Health to promote cooperation at international level between government and NGO and to improve care and treatment of those with mental, neurological, and psychosocial services. The International Society for Mental Health online is there to promote understanding, use of, and development of online communication, information, and technology. It serves as valuable resources for researchers, clinical and general people interested in online mental health. So types of mental health services, as I am talking about low and middle income countries, so I should specifically say about India. And in government, we have National Mental Health Program and District Mental Health Program. My second co-speaker, Dr. Asrumochan Sahu, will cover this government part. So I'll give some details about NGOs, some which are important, and the government part will be discussed by Dr. Sahu. So in India, we have those important services. One is Alzheimer's and Disorder Related Disease Society in India. It is an NGO, and it started since 1992, and they have their branches over 24 cities. Its objective to initiate formation of daycare and home care and undertake research for prevalence, caretaking, and other aspect of Alzheimer's, and to educate general people about Alzheimer's. And we all know about SCARF, the Schizophrenia Research Foundation, 1984. We are very aware of Dr. Sarda Menon and Dr. R. Padmavati. She got Padma Shri Award. And today I had Dr. Thara got some award for this SCARF Foundation. And what is their objective? It is a community outreach program in urban slum and villages, and to educate public about schizophrenia, to create awareness, understanding, and the most important is to eliminate stigma. Sangha Society is there. It is based in Goa particularly, and it provides access to rural population in physical, psychosocial, psychological, and social therapies. Umid, this is also an leading NGO known for their work, particularly children with disabilities, and provides specialist care for both developmental disabilities and moved into areas of training, research, and advocacy. Shraddha Rehabilitation Foundation, we know about Dr. Bharat Batwani, how he used to take the street, the wandering psychiatry patient, those present in the street, and he takes care of them. And till now, as far as know, 5,000 to 6,000 families, the psychiatry patient, they got their family, their reunion. His main aim to those who are wandering to reunify with their family. So you have Live, Love, Laugh Foundation, that is an NGO that deals with mental health issues. It is founded in 2015 to create awareness and reduce stigma due to depression, and it fund and support community-based mental health project that can have sustainable and large-scale impact on society. Mental health service that mainly focus on substance abuse. I have named few. Actually, in every city, if you go, you can find 2-3 NGOs are there. They are working on this. But this Parivartan in Maharashtra, Krupa Foundation, Alcoholic Anonymous, and Samarthians, I have named few. And for suicide prevention, Sneha is there. It is Chennai-based NGO. Delhi, you have Sarthak Suicide Prevention Foundation, India Foundation is there. Implication for policy and practice. There are 10 recommendations: provide treatment in primary care, make psychotropics available, because most of the time if we treat the patient, the psychotropics are not available, and government and NGO, if you can treat them freely also, it is difficult for them to buy, and that is definitely lack of resources is there. So many states they are allowing only the pharmacies, they can online consultation with psychiatrists, pharmacies can distribute medication. This will be mostly did by Dr. Brahma. He will say about the future. So this future goal. So these are implementation of legislation and organization plan, and about the future of mental health services. This will be dealt by Dr. Brahma. So my conclusion: barriers to improving mental health services can be overcome by political will, social enlightenment, and public movement to improve care of people who suffer with mental health problem. And mental health treatment and training program in developing countries need to be responsive for local culture, and they should incorporate with public health approach and embrace diverse needs of population. These are my references. Thank you.
They have questions together at the end.
Next speaker, Dr. Asumachan Sao is there. He is online. You can start.
Dr. Ashrumashan, are you there online?
Yes, yes. Madam, there is some net problem. I am just trying to do it.
Yeah, sure.
I am visible.
Can you please make it full screen?
Okay, ma'am. Okay. I'm visible, ma'am.
Yeah.
Your slides are visible. You are not visible. Probably you are sharing the screen. Please share
Yes,
the
yes.
window.
Oh.
Choose window for sharing. If it is difficult, you can go ahead with slides only. That's all.
Sir, I will start. Sir, I will start.
Yeah, start, please. Introduce yourself in few sentences.
Sir, sir, good morning. Namaskar. I am Dr. Asumachan Sao. I am working as an assistant professor in PRA Medical College, Baripada, Odisha, which is the northern part of the Odisha. And important today discussion, the mental health service in India, where I am working in a medical college, where this mental health program is jointly we are working with this Department of Psychiatry and the District Mental Health Program. So I'll, as Dr. Samratkar has talked about many things about the mental health service in developing countries and told about a leading NGO like SCAR, Sagnath, Umed, Sadha Foundation. I will talk to more of the District Mental Health Program and National Mental Health Program. At the outset, I also thanks to the organizing team for this opportunity, giving the opportunity for this topic. Coming to my topic, as you know, the health budget of the India is less compared to the world developed country, as told by the Dr. Kar. Around the maximum 2 to 3%, and the mental health budget is also less. And this pandemic has forced to change the mindset of the policymaker to increase the budget for provision of the health sector, but it is far less than what is expected, what is the need of the time. So this coming to the mental health, coming to the developed country, and particularly in the India setting, what is the government is doing in our country, in our state, in our district, we'll discussing that. No wonder that the mental health has been sidelined. The public health service in India is often insufficient, inaccessible, and of poor quality. As you know, only 43 government-funded mental health hospital and around 0.3 psychiatrists per 1 lakh population, even fewer psychologists. As I have told, less than 1% total health budget is spent in the mental health. One article is published where what is the attitude of the policymaker. This mental health is not a priority case in policymaker. As Dr. Kar has told, they give the priority to the heart disease, infectious disease, other disease which is more important. But now they should learn that the indirect cost of mental health is higher than the direct cost, because in a World Economic Forum, it has told that the negative economic consequence not treating the mental health is much more higher than the cost of treatment. So we should invest for the mental health, for the socio development, to get hand in hand to invest mental health, it will better for the development. Coming to the direct topic, National Mental Health Program, which is the government program for the particularly low socioeconomic status and marginalized person those are staying in the country, and particularly MNSUD. I will tell many times this MNSUD, but this stands for mental illness, neurological and substance use disorder, as a broad domain which under the non-communicable diseases. And these are the disorders currently addressed, at least in terms of community attention, identification, and treatment, which proportionally reflect a large mental health gap. And India is one of the major countries to adopt the national program in mental health at the national level for the meeting of the WHO Mental Health Survey Advisory Group. So this national mental health program is implemented all over the country in a phase-wise manner, and the workout which has done, different programs which are done in the national mental health program. The objective was to ensure the availability and accessibility of mental health care for all the foreseeable future, to encourage the application of mental health knowledge in general health care and the social development, and to promote the community participation in mental health service development and stimulate efforts toward the self-help in the community. First, to do it, that should be available and accessible to the mental health to the future group, and application of mental health to the society, to the people, those who are not aware of the mental health issues. What are the strategies? Integration of mental health to the primary health care with the national mental health program, provision of tertiary care institute for the treatment of mental health disorder, and importantly, the eradicating stigmatization of the mentally ill patient and protecting their rights through the regulatory institutions like Central Mental Health Authority and State Mental Health Authority. Particularly, as you know, the mental health is more of many stigma. Every day we are in the paper, in the news, where because of the stigma, the people are born, someone is killing because of the false belief. So we should have a strict guideline by the Central Mental Health Authority or the State Mental Authority, which is governing on that area, so that we can develop better mental health care, which is the main strategy for the National Mental Health Program. What are the different components? I will talking one by one different program components of National Mental Health Program. First, the manpower development is the most important component is the National Mental Health Program. Manpower development, upgrading the existing central mental health institutions, supporting for the central and state mental health authorities, central mental health team, training and research, information, education and communication activity, monitoring and evaluation, and mental health information management system. These are the important component, but the most important is the manpower development scheme, where the two scheme, one is scheme A and scheme B, scheme is the basically center of making up 11 institutes are the center of excellence. My previous institute was SC Medical College, which was upgraded as a center of excellence. Was in between 11 centers of in the scheme A, and scheme B were strengthening of the PG department of the mental health. But 27 PG department receiving support. To extend this support for the 93 additional departments, 23 department of psychiatry, clinical psychology, psychiatry, nursing of each, and 24 department of psychiatry, social worker. This is the most aim was for the manpower development. Next, in the upgrading of central mental health institutes. As you know, important upgrading like NIMHANS, like making of NIMHANS like institute, like Central Institute of Psychiatry, and LGBRI, that is Lokpriya Gopinath Borodale Institute of Mental Health, Tezpur, and providing along with the mental health with the neurology and neurosurgery as of NIMHANS by upgrading the two institute and providing neurology and neurosurgery facility in this institute. That support to the central and state mental health authorities, making in charge of all the mental health service under the central and state government and the concerned matter under Mental Health Act, making a mental health act including their secretary, health secretary, and the member board, making a board leading constituting of the health secretary and the professor of the senior most professor of the medical college and psychologist and layman, making a board that can govern the and they can make some regulation of that particular area. Supervision and mental health service agency under the central and state government, advise the central state government for the related mental health matters. As you know, it is a diverse sociocultural diverse. What is the mental health problem? What is the situation of particular area may differ from different area. So we can give some advice to the central government and state government if you develop some mental health authority body in that particular area, and advocate for the integration of mental service in the general health care. That is the most important, which the DMHP program, which is main aim is organized by this National Mental Health Program. Then making a central team which consists of two consultants, one consultant for mental health and other is consultant for public health, and two program associate and two data entry operators, and they assist the Minister of Health to smooth the implementation of national health schemes. Then training and research, that is the most important part. Training of the master trainer for the each state and union territory, training to be standardized and delivered in identified centers along with the manuals. To training of the clinical and managerial skill, and telemedicine and short training psychiatry and allied field through e-route. As our SCV Medical has declared a center of excellence, and he has NIMHANS in NIMHANS like institute also planning in our state also, and where VKN, where virtual mode, where NIMHANS consultant and our consultant seat and other DMHP project working same together, so that we can do better training and research. Then IEC activity, the information, education, communication, to strengthen the activity at national level through mass media campaign, and to establish central website for the mental health problem, and to resource and activity under the National Mental Health Program. Then that is the last is the mental health information management system, making the online data monitoring system, and to facilitate bilateral communication between the participating unit under the various scheme. And this 12th year plan of DMSP, which consists of psychiatrist, clinical psychologist, psychiatrist, social worker, community nurse, program manager, and record keeper and case register. What is that? But there is a limitation. What is the limitation? Because the lack of steady administration structure and adequate funding, there is no supervision, and the program could not emphasize on the curative component rather than the promotive aspect. And it is important lack of manpower resources. So the plan for the another program, that is district mental health program, which is the important component to live that is the main which cure the limitation of the NMSP. And as you know, the DMHP started at NIMHANS at a pilot project at Bellary district from 1985 to 1990, where it was a successful work. Then this was implemented all over the India. Now in around 655 districts are covered in the DMSP district, and around 500 districts are operational in DMSP project. One important component DMSP is service provision, capacity building, and IEC. Service means provisions, management of cases of mental disorder and counseling in different level of district through healthcare system. Capacity building, manpower training, development of prevention, early identification, management of mental health disorder, and important is the IEC, information, education, and communication activity. Main objective to provide sustainable mental health services, early detection, to take pressure on mental health hospital, and reduce stigma. And lastly, as it is told, it is epilepsy comes under on that, detect early case, manage, and refer the case to the epilepsy. What are the service provided? Clinical service and training of these Anganwadi workers, ASA workers, ANMs, training of the medical officers, IEC activity, target intervention, particularly life skill education for the school and college counseling service, workplace stress management, and suicide prevention service, particularly to those who are working in government sector and private sector, to how to do stress management. And this is the training of medical officers, where I am sitting with my DMS program officer Pradeep and the CDMO. It is regular going on this district. And LSC, life skill education training of the teachers about the how to teach they will teach the students of 8, 9, 10 students, and training of the ASA and NMs. And lastly, the service delivery framework for the mental and neurological substance disorder, that is community health service, providing the mental health literacy, early identification, community-based follow-up, screening at the community, diagnosis at the medical officer level, and reduction in the treatment gap. These are the main service. First of the role of the, it is the primary role. We are training to the ASA people, NMs about the mental illness, and we are giving the community-based assessment checklist, and they go to home and find whether they have any disease persons in their family members. If they screen and they come to the district hospital where DMSP is functioning, or they come to the medical officer where we have trained the medical officer of the particular PSC or CSC. And role of community health workers, screening and identifications of mental, neurological, and substance disorder, ensuring referral to higher authority. If they cannot treat the patient, they refer to the higher center DMSP program going district or to the medical college, and dispensing the medicines, suicide risk management, and include the patient for the community-based rehabilitation. And at the last, the role of medical officer, we are training to the medical officer. They should at least minimum treat the depression, anxiety, other with the minimum like escitalopram, olanzapine, and while providing these drugs also to the PSC and CSC level. And particularly, they will assess identification. If they are feeling emergency, they should refer to the higher center. And if they can do the patient, treat the patient at the and treat that at that OPD also. And to conclude, as India is the socio-culturally diverse and populous nation, adapt a model that is fit for our local context, needs, and conceptualized for mental health. A partnership between psychiatrists, local healers, particularly religious healers, psychiatrist, social worker, anthropologist, NGO, and local volunteers should play an important role to making the mental health service effective and accessible to the larger population. And take home message: the DME is an important component of mental health service, which need to be strengthened by the all the stakeholders, including NGO, government service, medical and paramedical staff. And thank you. Thank you. I also invite you to the next ANICPS 2023 to the Holy Land of Lord Jagannath. Thank you.
Yeah. Nice presentation, Dr. Sahu. Short and sweet. To be online, we'll proceed with the third presentation. Brahma. Introduce yourself.
I'm Dr. Aurobindo Brahma. I'm the director and consultant psychiatrist at Girindo Shekhar Clinic, Kolkata, and currently the Honorary General Secretary of Indian Psychiatric Society. Today I will speak on human resource development in mental health at primary care level, experiment that we done from Sundarban region of West Bengal. Particularly, I've chosen this topic because where my previous speaker has just finished his job, that we need a model for our country, because you know, in our country, we cannot consider only the urban people. We have to take care of the rural, remote villages where people till date they do not get psychiatric service. So we know that mental health resources are scanty all over the world, especially in the low and middle income countries. Already Dr. Shamratkar has mentioned that. In Indian healthcare system, there is a large deficiency of mental health professionals and a substantial disparity of workforce distribution at the primary care level. And the rural inhabitants are unable to access primary health care from qualified medical practitioners because of extreme lack of health professionals and wide cultural and geographical disparity in the country. As our country is lacking necessary human resources and adequate health infrastructure for mental health care, so a vast proportion of rural Indians are uncared for their mental illnesses. So development of a trained mental health human resource in the primary care and community setting, it's a big challenge in the current India. So we had this experiment with the aim to develop an effective community-based mental health service network by utilizing local human resources at the primary care level in the island of Sundarban region, West Bengal, what my previous speaker, Dr. Shah, has just mentioned. So here is the eco-demography of Sundarban. Just a quick look. It is the, it is the largest intertidal delta in the world and harbors the largest mangrove vegetation. It is one of the poorest and most densely populated region of South Asia. Millions of people depend on Sundarban ecosystem for their livelihood and sustenance through fishing, collection of honey, fuel wood, and timber. And most of the people lie below the poverty line. And provision of healthcare is extremely poor, and electricity is almost non-existent even till date. Safe drinking water is a problem in these island blocks. And by all standards, yardstick of development, Sundarban is an extremely backward region with a very poor quality of life of its inhabitants. And that is the reason why we have chosen this area to develop a model for the psychiatric service to the primary care physicians. So this is the map of Sundarban region. There are total 13 islands in the Indian part of Sundarban, and rest of the Sundarban is in the Bangladesh. And the first clinical contact, it is a local healthcare providers, that is HCPs, locally called as quack doctors, for most of their health problem, including mental illness. And Namkhana is one of the 13th block of Sundarban, having a block primary health center where we conducted a bi-weekly mental health clinic during the study period. I'm not going into the details of Sundarban. Here you can see some pictorial presentation of Sundarban. This is the typical households in the Sundarban region. You can see that this is Gosaba block. Gosaba, is famous for the tiger reserve forest. Here you can see this is Sagar Island. The Kapil Muni Ashram, Ganga Sagar Mela every year that is occurred in the month of January. Here some of the pictures of mangrove forest, the largest mangrove forest of India, of world. Royal Bengal tiger, that is the characteristic of Sundarban reserve forest. Here the tiger is swimming while we are conducting our study. We catch this photograph and the crocodile in Ramganga river. Here you can see how one of their occupation, that is collection of tiger prawn seeds. And this lady here who is having this, that crocodile scar mark while collecting this tiger prawn seed in the river. So this is the eco stress. That's why I'm showing this photos. The tidal waves, the high tide and low tide, soil erosion, and the displaced population. That is a regular event of Sundarban region that we cannot understand living in the city. So this is the climatic insult. Almost every year Sundarban is affected by one of the cyclones or storms like Amphan or Ayla or Bulbul, Foni. Every year something is coming, and that is mainly because of now the mangrove forest is destroyed. So this is the picture of displacements of population after this climatic insults. And here the main mode of transport is the country boat or mechanized boat and van rickshaw with the engine, that is they call helicopter in their local language. So whether carrying the patient or whether they are going for marriage party, every time these are the main way of transportation there. And this area is typically dependent on agriculture. So availability of pesticide is very common in every household. And that is one of the easiest method of committing deliberate self-harm in this particular area. So healthcare providers or co-ops are the sole authority to treat any illness whatsoever without consulting the healthcare providers. Usually they never try any other medication or willing to visit any other health professionals. A cultural distance exists between us, that is the modern medical doctors, and the people who cannot be approached for mental health intervention directly except via the healthcare providers. So in the experiment, we have given skill development program to healthcare providers, then to the ICDS workers, and lastly to the multi-purpose health workers. So we developed a training material in consultation with community stakeholders and the local health staffs. I'm not going into the village survey. So in Namkhana block, we found total 587 healthcare providers. This is their list. So 30 healthcare providers were selected from 72 healthcare providers of 4 villages, that is Amaravati, Bagdanga, Bijoyabati, and Namkhana. These are the pictures of a map of those villages. So a list of these 30 HCPs were prepared on the basis of 3 criteria: practice type, either allopathy or homeopathy. They must have a moderate to good community credentials, and those who showed willingness to participate voluntarily. And healthcare providers were trained in 3 separate sessions, 10 in each group. Each training was of 2 days and total duration of 6 hours in each day. Training was conducted by 1 consultant psychiatrist, 1 consultant psychologist, 1 junior psychiatrist, and 1 sociological research officer. And training was primarily aimed to impart overall knowledge of mental health and illness, including deliberate self-harm, skill development for identification of common neuropsychiatric disorders like depression, generalized anxiety disorder, OCD, psychosis, epilepsy, dementia, mental subnormality, and deliberate self-harm. They were asked not to diagnose the potential cases, but to identify the mental and behavioral abnormalities. Skill development about the simple steps of psychosocial counseling and monitoring of identified cases. And the primary stress of the training was on the identification skill of mental illness and referral to the block primary health center clinic. So these are the photographs of few HCP training. So here you can see some IEC materials that we developed. Here it is in the Bengali language for them. We developed this different IEC materials on the depression, on the suicide, on the mental subnormality, on alcohol addiction, epilepsy, child abuse, suicide by pesticide injection, which is very common in that area, and stigma and false belief about mental illness. In the next experiment with the ICDS workers, 6 ICDS workers in Mycenae Island were selected and trained with the same objective, same team and procedures were followed. And the third experiment is with multipurpose health workers. We know multipurpose health workers are basically field staff of BPHC who visit every household allotted to them as a part of their usual duties. So 20 multipurpose health workers showed keen interest in this program and were trained in a group of 10 each over 4 days at the Namkhana Block Primary Health Center. So these are the photographs of ICDS worker training and multipurpose health workers training. So the result is, out of 30 healthcare providers, 8 of them referred a total of 51 cases, of which 37 cases, that is 72.5%, found to have a psychiatric diagnosis. Now, testing the hypothesis of ineffective training using binomial probability method, then probability of observing 37 or more correct diagnosis is 8.84, which is highly significant. So the training is effective to impart skill of identification of mental disorders to the healthcare providers. Again, for ICDS workers, a total of 29 cases they referred, of which 22 were found to have psychiatric diagnosis. And again, testing the hypothesis of ineffective training using binomial probability. Here again, it is found that the highly significant result. So training was again effective to impart the identification of mental disorder by them. And for multipurpose health workers, they sent total 44 cases, of which 29 were found to have psychiatric diagnosis. And again, this result found to be highly significant. So the IRMC, that is identification, referral, monitoring, and counseling, that is the model we generated there, IRMC. So identification of the mental ill cases, referral of the mentally ill patients to the primary health center or block primary health center, monitoring of those cases, that is mainly for the follow-up purpose, and counseling, the initial counseling mainly for the suicide attempters or for other depression, anxiety. So here HCPs referred 51 cases, multipurpose health workers referred 44 cases, and ICDS workers found 29 cases. So this shows that the referred highest number of cases were mental retardation, followed by major depression. That is interesting. That the cases they referred, most of them are mental retardation, followed by major depression. So this is a distribution of all referred cases after the diagnosis done by us. We found schizophrenia, major depressive disorder, generalized anxiety disorder, manic psychosis, somatization, generalized tonic-clonic seizure, and mental retardation. The cases referred by healthcare providers, ICDS workers, and multipurpose health workers. So in the present work, we tried to explore that how we can effectively distribute some of the mental health care responsibilities among our primary care health workers and the local healthcare providers. Healthcare providers who treat about 80 to 90% of the total rural population as a part of first contact. They are the potentially valuable human resource to be effectively utilized in community mental health care. And the current attempt was to organize this huge human resource with the scientific skill and knowledge transfer for helping the community mental health care at the primary care level. But there is a debate. Should these healthcare providers, because they are non-registered, be involved as cultural blocker in the community psychiatry program at the primary care level? But we know that local human resources are already being utilized. Like we can take the example of polio or HIV public health program, where the already government is taking their help. So there are few favorable points here also, like they have got very good community acceptance, trust, and high dependency. Community family ties and local residents. Proper insight about the emic perspective of disorder and dysfunction. 24/7 ensured availability. Because in most cases, you know, when we went to their household or when we are talking to the patients, they are telling, doctor, you are coming from city in every 15 days. So for everyday availability, we depend on the healthcare providers. Continuity of care that we get through IRMC or multipurpose health workers, and huge local human resource with potential community credibility, and thus influence the health seeking decision making at the individual and family level. So for some time, the Ministry of Health of India and the state have been considering these healthcare providers as a real human resource at the rural healthcare system. In the past, Government of India created a similar health force known as Community Health Guide from the local communities who are still working in the villages and mainly involved in referral and health counseling. So in a similar note, these ICDS workers and multipurpose health workers are already working at the community level and collecting and documented different household morbidity data of each household as a part of their duty. So if they are empowered with reasonable skill and knowledge about mental illness, they would provide a huge help for any community psychiatric program. So empowerment of this local human resource not only improve the community psychiatric care, but also of immense aid to break the cultural stigma that facilitate access to vulnerable individuals, especially in deliberate self-harm cases. This would be a remarkable aspect of suicide prevention work at the primary care. So it is also evident that the present experiment that most of the referral was mental subnormality and depressive disorders. This is of unique importance, especially to focus the antenatal care and hospital delivery advocacy as a part of public mental health program in the community. Secondly, WHO, has given a call to fight depression as a health slogan in 2017, because by 2020, they told depression would be the second most costly disease in the world. So this experiment shows that this working force can effectively identify probable psychiatric cases and refer them to referral center, and thus help to develop an effective network of community mental health care at the primary care level. So this model may be adapted in a large scale with suitable modification to meet the challenge of mental health care at the primary health care of the country. So this is the model that we have generated. And already it was, we have presented in different national and international forum, and we got very positive response from there. But in our country, we need more and more experiments, so we can modify something. Now, the take-home message for today's overall discussion, that is the strategic direction from Indian mental health policy. We need an effective governance and accountability of mental health care, prevention of mental illness, reduction of suicide and attempted suicide, improved availability of adequately trained mental health human resource. Research is very important. Promotion of mental health, another very important aspect. Universal access to mental health services and community participation, which is again very important. And this is already covered by my two earlier speakers, Dr. Kaur and Dr. Shahu. So this is the, the strategy we can take for this community healthcare services in our country. So thank you very much. This is a picture of Sundari tree, Sundari, from where the name Sundarban came. Okay, thank you.
Congratulations, Dr. Brahma, for a very nice presentation and making us aware of what is Sundarban is at the same time. So we can proceed with the questions.
Shamrat.
Correction probably for Dr. Kar. He wrote Dr. Bharat Batwani. Because of Bengali, I suppose that mistake happened. It is not Batwani, it is Batwani.
Okay. He is from Odisha, sir.
Okay. So it's same. They changed word to birth.
What one?
Yeah.
He got his Magasesa award last
Yeah. I don't know. We talk a lot of about the mental health facilities and mental health, education in India. Till recently, maybe 10 years or something, most of the medical colleges did not have psychiatric departments. And even now, majority of them don't have full-fledged departments, which includes social workers, psychologists, and all that. They have psychiatrists, but it is not adequate. So, because there were no departments, no PGs were generated. And so, the lack of the paucity of members is one of that reason. Is second reason is probably that monetary returns which we get in psychiatry are much less than in other faculties.
Exactly.
And therefore, students don't easily turn to psychiatry. That is probably another reason. And third reason why it is ignored is we have not focused the scope of psychiatry. Like what I tell to my students is, you pick up any field of knowledge in the world and attach psychology to it, it becomes an independent field of knowledge. The psychology of space, psychology of sports, psychology of engineering, psychology of organization, whatever. This is the scope of psychiatry and psychology. If we focus that, then probably the government will also realize the importance and people will turn to psychiatry, this field more.
So you were right, sir. I think we need more advocacy, and in policy making, we need to collaborate more with the government in the government level.
Yeah, but they don't know what psychiatry is and what mental health is.
Exactly, sir. Because now I am the council member of RCI Rehabilitation Council. So when I am attended their meetings and I am telling IPS can be collaborated with you, so they told, okay, then you send me some proposal because we don't have any idea that IPS can work with us. But
Right.
Definitely IPS has a big role to work with the rehabilitation psychiatry of our patient. So that is a very
Right. Even in the training of IAS and IPS, psychiatrists can be useful faculties.
Exactly.
Right. This scope is not really focused.
Yes.
Highlighted. Any further questions?
No, we'll just conclude the session because we already have a plenary lecture going on down.
Okay.
Yeah.
So thank you.
just have
Thank
felicitation.
you all
just
the
one.
speakers. Congratulations to you. And thank you organizers for giving me this opportunity to chair such
Thank
a
you,
fine
sir.
session.
Thank you, sir.
Thank you.
I request the Honorable Chairperson, Dr. Sanjeev Suji sir, to felicitate the speakers, Samrat Kaur sir. I request the Chairperson, Sanjeev Suji sir, to felicitate the speaker, Arvind Brahma sir. I request Arvind Brahma sir to felicitate our chairperson for this session, Dr. Sanjay Suri sir.
We have a plenary session going on in Hall 1, so you all can go there. Um, good morning, everyone. We have 2 minutes till afternoon, so I would like to start the session by inviting the chairperson on stage, Dr. Rupinder Kapoor. So you can start by inviting the speakers on stage.
Good afternoon, everybody. Those who are present here and those who are online. We are going to have a session on OCD, the newer perspectives. The speakers are very well known, Dr. Naresh, Dr. Sona, and
It's on the screen, on the screen.
Dr. Naresh is psychiatrist at Columbus Hospital Institute of Psychiatry and De-Addiction, Begumpet. Dr. Amla Imani, she is working at the same hospital. Then we have Dr. Sona Kakat. She is a renowned psychotherapist, and I think all of you must be knowing her very well. Then we have Rajivi Ita. She is also from Hyderabad, Osmania Medical College. I welcome them all, and let's start the session without wasting time.
Dr. Rajiv.
Rajivi, I said.
First she.
Okay. First to speak will be Dr. Rajivi Kitha. I welcome her. Please, ma'am, you start with your session.
Yeah.
Good morning, respected chairperson, all the delegates. Today we are going to deal with the overview and phenomenology of OCD and the recent studies during the COVID pandemic. So recent systematic literature review, which says that, which has conducted some studies in United States, China, United Kingdom, and India. So, which says that due to global pandemic, there is intensified personal perception of distress. So this leads to intense psychosocial impact. And the existing mental disorders are more prone to relapses during this time. And there are hectic adverse effects on their mental health and their state of relaxation who are suffering with OCD. OCD is a chronic waxing and waning neuropsychiatric disorder by recurrent obsessional thoughts and acts. It is causing distressing, time-consuming, and impairing. The associated features are with a range of content and fears, different effects, insight, and comorbidities. And WHO says that it is the 6th largest contributor to non-fatal health loss globally, and it is one among the 10 most disabling medical conditions worldwide. And the NICE guidelines also says that OCD occupies the 5th position in women aged 15 to 44 years. OCD is the 4th most common psychiatric disorder, and it is twice as prevalent as schizophrenia and bipolar. And the lifetime prevalence is as low as 0.7% to 2.5%. It is called as hidden epidemic with 1 to 3% lifetime prevalence worldwide. These are the statistics worldwide and in India. It is more in adults. It is more common in females than in males. In adolescents, it is more in boys than girls. Around mean age of onset is around 19 years, and the earliest age being 10 years, and it is very rare after 30 years. In India, around 12 to 14 years is the mean age of onset, and it is more common in single persons than in married persons, and most common among lower socioeconomic status. As being a multidimensional disorder, it is having heterogeneity, but still it is marked cross-cultural similarity with cognitive, affective, and executive behavioral disorders. The existing neurobiological models of OCD highlight the dysfunction in frontostriato-thalamocortical circuit substrate. And these circuits and genetics are detailed by Dr. Amala. So they lead to effective and reward processing, executive function issues, working memory and planning, and motor preparation and response inhibition. These are the sensory motor, dorsal cognitive, ventral cognitive, and mental reward frontal limb circuits which are involved. And the neurotransmitters involved are glutamate, serotonin, dopamine, and the triggers being the environmental factors like perinatal events, stress, trauma, neuroinflammation, and the genetic factors makes it vulnerable for these, which lead to different OCD dimensions like symmetry, taboo thoughts, contamination, and hoarding. So glutamate abnormalities has been considered to be a core feature responsible for illness. There are elevated glutamate levels in CSF also. So these are the neurocognitive abnormalities which are seen with the different tests we conduct in different areas of brain. The overactive conflict and error detection, go, no go, stop, signal reaction time, set shifting, decision making, and non-verbal memory. So these are the structural abnormalities which are seen in neuroimaging in white matter and gray matter. The abnormalities being in white matter, abnormalities in cingulum, and There is altered white matter integrity in anterior and posterior limb of the internal capsule and the prefrontal regions and in parietal, temporal, and occipital areas. The gray matter alterations being volume reduction, OFC, cardiac thalamus, amygdala, and ACC. So these are the subcortical volume alterations. In adults, a smaller hippocampus could be related to comorbid depression, and larger pallidum related to early disease onset chronicity. And in juvenile, larger thalamus unmedicated is most seen in unmedicated kids. These are the fMRI studies which says end of phenotype status of emotional interference, and there are bold changes. So these are the genetics which are dealt by other co-speaker. These are the neuroimmune aberrations which are seen in AB hemophilic streptococcal bacterial infections, antineural antibodies, and the presence of the D870 surface antigen on lymphocytes. Cytokine alterations are also seen, and immune glutamate link. Coming to phenomenology, so the internal or external stimulus which leads to obsessions and that lead to distress and anxiety, and vice versa, which lead to ritualized behavior, and that helps in temporary relief from distress and anxiety, which causes reinforcement of behavior and again ritualized behavior. So these are the obsessions and compulsions, which are the obsessions are own thoughts but not voluntary. Repetitive images, impulses, intrusive, time consuming, and causes anxiety and distress. Irrational, unwanted, excessive, resisted but poorly controlled. And the compulsions, repetitive behavior, mental acts, intrusive, time consuming, relieves and reduces anxiety. They are clearly excessive intent to prevent something. Repetitive behaviors or cognitions performed in a stereotype manner. So these are the DSM given obsessions and compulsion definitions. And these are differ across the patient as well as in the time, and more common are mixed OCD than predominantly obsessions and predominantly compulsions. The form is the structure of the phenomenon and content is the meaning conveyed by it. These are the forms of obsessions, thoughts, impulses, and images. Compulsions including yielding and non-yielding, self-proxy, ritual, rigid set of rules. So these are the different types of obsessions, which include obsessive thoughts, which are the words, ideas, and beliefs which are recognized by patients as their own and that intrude forcibly into the mind. For example, my hand is dirty and I need to clean it. And some of the obsessive images, which are vivid scenes often of a violent or disgusting kind. For example, I see repeated images of road traffic accidents and people dying. There are some obsessive urges and impulses, which are the urges to perform acts usually of a violent or embarrassing kind. For example, I want to touch the table and leaping in front of a car, etc. Other forms include obsessive ruminations, which are internal debates in which arguments for and against even the simplest everyday action and reviewed endlessly. For example, unusual and clearly defined topics like contamination and sex. Other are obsessive phobias and obsessive doubts. And other forms include obsessive rituals, obsessive slowness. Obsessive rituals are includes both mental activities and repeated or senseless behavior. Obsessive slowness, it is extreme need to perform tasks in exacting detail. It is the extreme perfectionism. Others include obsessive fears, aggressive obsession, religious obsession, and somatic obsessions like fear of getting illness, AIDS, etc. What are the forms of compulsions, which include yielding compulsions, controlling compulsions, and common compulsions include washing and cleaning, checking, counting, ordering, and repeating rituals. Mental compulsions are cognitive, which include sexual obsessions. These are the common obsessions with compulsions. Fear of contamination, which is the obsession, and the compulsions are washing and cleaning, need of symmetry, precise and arranging. The compulsions are ordering, balancing, straightening until just right. Unwanted sexual or aggressive thoughts or images. Compulsions being checking, praying, asking for reassurance. And the doubts, the compulsions are repeated checking and behaviors. So this is the content of obsessions and compulsions, which widely varies. Most are plausible, but some can be bizarre. Most prominent are the fear of harm befalling self or others. So this is the OCD cycle, which we dealt before. The obsessions which lead to anxiety and distress, which lead to compulsions, and after compulsion there is temporary relief. Again, the reinformance will be present, and that triggers again, like for example, looking at the door, which causes again obsessive thoughts. So this is the symptom dimension with the dimensions including cleaning, forbidden thoughts, symmetry, and hoarding, which lead to obsessions and compulsions. The obsession being cleaning dirt or contamination that leads to washing. Aggressive, sexual and religious, somatic, forbidden thoughts leads to checking and frequently. Symmetry and ordering, which leads to ordering and repeating compulsions. And the hoarding, like I cannot figure out what to throw away and what to keep. So that leads to I collect items such as used papers, old newspapers, batteries, etc. And the defense mechanisms involved are reaction formation, displacement, and inhibition. The other common symptoms include anxiety, depression, depersonalization, and suicide. Suicide, about 1/3 of the patients with OCD have major depressive disorder, and suicide is at risk for all the patients in OCD. So other aspects to be considered are harm avoidance, sense of incompleteness, sensory phenomenon, and disgust. So in harm avoidance, the primary neural substrate involved is amygdala. It is a personality trait characterized by excessive worrying and desire to prevent potential harm. And the sense of incompleteness, the sense of imperfection lead to repetition of action until there is conformity to an absolute, often inarticulate subjective standard, checking, ordering, and washing. Sensory phenomenon, uncomfortable, unpleasant, aversive. And the discussed strong association with contamination marked by revulsion towards inducing stimuli. So these are the diagnostic criteria: ICD-10, 11, and DSM-5. ICD-10, it included in neurotic stress related and somatoform disorders. In DSM-5 and 11, it is given separately. And there is shared definition in ICD-10, and it is separate in DSM-5 and 11. The duration being more than 2 weeks, which is given in ICD-10. And response and impairment, at least one obsessive or compulsive unsuccessfully resisted. And in DSM-5 and 11, it is given as more than 1 hour in a day, it should be there. Inside, good, fair, or absent, in it is recently given in DSM-5 and ICD-11. The exclusion criteria being obsessional symptoms in schizophrenia, Tourette syndrome, and organic mental disorder, which is given in ICD-10. In 11 and DSM-5, in 11, obsessive compulsive behavior is given in exclusion, and in DSM-5, substrate induced and another medical conditions are given in exclusion. And the specifiers being predominantly obsessions or compulsions are mixed in ICD-10. And DSM-5, it is insight and tick related, and ICD-11, it is insight. So coming to insight is the acknowledgement of the irrational nature of OCD symptoms and recognizing that their experience are excessive or unreasonable. So it interferes with the work. It is a non-static and dynamic phenomenon, varies across the patient as well as the time. DSM-4 given as 29% had poor insight. The predictors being for poor insight are greater symptom severity, higher functional impairment, poor quality of life, and poor adherence, earlier onset, and more comorbidities. Insight improves with treatment. This is the insight spectrum, and it is assessed by Y-box 11 and Brown's assessment belief scale. Around 25% of greater deterioration in the total Y-box score in recent studies in 21 and 2020, and which suggests that environment and psychology interaction might be involved in OCD, and that a fear of negative events might play a role in etiology of OCD. So here we need to discuss about the comorbidities. Persons with OCD are
You
commonly,
have 1 minute only, please.
OCD are commonly affected by all these medical disorders. And 2/3 of the patients with OCD have comorbid psychiatric disorders and neuro disorders also. So these are the OCD spectrum disorders. These are the different body dysmorphic disorder, hypochondriasis, anorexia, neurological disorders, and impulse disorders. So these are the different differential diagnosis with the rumination, generalized anxiety, and hypochondriasis, compulsives, and personality and body dysmorphic disorders. So this is the poor quality of life and severe disability in these areas, biological, occupational, marital, and social functioning due to OCD. These are some of the studies in 21 and 20, which has given that there is worsening of OCD symptoms during the pandemic, and proper treatment on the time helps in decreasing of worsening of the OCD symptoms. And these are the some of the studies which has conducted from 2019 to 2021 during the pandemic, which showed that there is improved relapse prevention during the periods of social restrictions. Finally, to conclude, it is a chronic illness, and if it is under recognized, there is manifestations of symptoms will increase, and the current crisis constitutes a risk factor with worsening of symptoms and suicidal ideation. Early recognition and treatment improves outcomes. Patients with OCD should be closely monitored for psychiatric comorbidities and suicidal ideation. Thank you so much.
That you said something and we should remember it. Please. Dr. Amla, speak on update on genetics and intracellular mechanisms. Please start.
Hello everyone, respected chairperson. So I would like to start my discussion with corticostriatothalamic cortical circuit, and the reverberating circuits were mainly determined responsible for the OCD. There are many parallel open loops that connect frontal cortical and subcortical areas. Participate mainly in specialized motor and cognitive functions depending on the specific cortical area. Cortical neurons, they project onto the striatum, which form the glutamagic synapse onto the medium spiny, which are GABAergic, which link to globus pallidus internus substantia nigra reticulata through direct or indirect pathway. Direct pathway, they link to links striatum to the globus pallidus internus directly, which are mediated by dopamine 1 receptor, and indirect pathway link striatum to globus pallidus internus indirectly through from globus pallidus externus and subthalamic nucleus. This indirect pathway provide the inhibitory tone to the thalamus. So imbalance in this system with increased activity in the direct pathway would disinhibit the thalamus and promote repetitive behavioral sequences. Most accepted model of pathogenesis of OCD is Baxter's model. Dynamically balanced direct and indirect pathway within corticostriatothalamic cortical circuit, which are tightly regulated by glutamate and GABA. So this gives me the idea of this alternately flickering LED lights. So glutamate and GABA. Glutamate mainly executes, helps in execution of the activity, and GABA, it's an inhibitory neurotransmitter, and mainly to stop the propagation of the neural transmission. So role of glutamate, it is an ubiquitous primary excitatory neurotransmitter, and extrasynaptic activation of an NMDA receptor can lead to excitotoxicity, neural damage, and death of the neural cells. Therefore, glutamate concentration is tightly regulated by excitatory amino acid transporters. It's present on astrocytes and glial cells, and also by the glutamate cysteine antibody. So it is found that CSF fluid have elevated glutamate in OCD patients compared with the healthy patients. Corticostriatal circuitry are implicated in both in OCD and drug addiction with symptomatology of compulsive motor activities and that do not respond to the normal inhibitory limbic signals. Dysregulation of transporters or exchanges which regulate concentration of glutamate in synapse may explain the abundance of the intersynaptic striatal glutamate implicated in the symptomatology of OCD. So, though they are category of excited amino acid transporter, amino acid transporter 3 is found on neural cells and is encoded by SLC1A1 gene, and SLC1A1 is the susceptibility locus of OCD. So Potan and et al. Found sliced mRNA transcript which inhibit glutamate uptake from full-length excited amino acid transporter 3 protein. It has shown to regulate the activity of both inotropic and metabotropic glutamate receptors. Postsynaptic glutamate receptors are embedded in a matrix of proteins called postsynaptic density, and SAPAP3 gene encodes PSD components, mainly in the animal model. SAPAP3 knockout mouse model shown to produce increased anxiety and compulsive-like behavior due to defect in synaptic transmission. So, DLGAP3 is human counterpart of SAPAP3. So, mice deficient in another animal model, mice deficient in neuron-specific transmembrane protein like SLT and NTRK-like protein showed excessive grooming. And DICT7 mutant mice showed hyperactivity of striatal direct pathway, provided indirect evidence of role of glutamate dysfunction in OCD. So then the role of serotonin in OCD. It is an well-characterized neurotransmitter implicated in OCD. Serotonin is categorized diffuse modulatory neurotransmitter, and serotonin is crucial for orbitofrontal cortex function. So low serotonin leads to preservative neuronal activity with the network getting stuck in specific states. Low serotonin leads to an increased tendency to develop obsessions and difficult to escape. Increasing serotonin decreases these pathological tendencies even if there is excessive glutamatergic activity. Polymorphisms of genes such as SLC6A4 gene that encodes the serotonin transporter and HTR24 gene encodes HT2A receptor are focused in most genetic studies and show the role of HTT4 gene in OCD with 5-HTT linked polymorphic region polymorphism. So as the GABA is the inhibitory neurotransmitter and stops the propagation of the transmission, plasma levels of GABA known to be decreased in patients with OCD compared to health controls. GABA levels were significantly reduced in prefrontal cortex of OCD patients. Polymorphisms in gene encoding GABA B receptors found to be significantly associated with OCD. Next, role of dopamine in OCD. Dopaminergic cell bodies are located in the ventral tegmental area and substantia nigra. OCD patients experience increased nigrostriatal dopaminergic drive. Increased prefrontal dopamine levels can contribute to obsessive symptoms. Catechol-O-methyltransferase enzyme gene is regulated by estrogen, and males are more likely to have catechol-O-methyltransferase polymorphism that are associated with OCD. Increased presynaptic dopamine transporter availability has been detected in primarily the left basal ganglia of the OCD patient. Decreased D2 like autoreceptor availability and decreased presynaptic dopamine transporters availability in the basal ganglia. Excessive dopaminergic transmission is a mediating factor in model of compulsive behavior. And SSRIs have been found to modulate dopamine transporters at higher doses. These are my references, and thank you. Thank you.
Thank you so much. And our next speaker, I think she is online. Dr. Sona, please.
Thank you, Dr. Rubinder.
How are you?
I'm good. How are you? Good to see you.
I'm fine. Yeah, thank you. Please
And-
enlighten us.
Thank you, Dr. Rubinder. I'm so glad to be part of the team from Hyderabad. So my role was to just bring in a bit of psychotherapeutic interviewing that may be helpful to a patient who suffers from OCD. And why I thought of bringing up this topic is before that, we are going to be just looking at some ISTDP principles when we work with this patient. ISTDP is intensive short-term psychodynamic psychotherapy. It was developed by Dr. Habib Davanlu, as most of you know, and now it is taught in several training institutes. So the problem is that when a patient of OCD presents to us, it is often many years have passed before he really presents to a psychiatrist. So obviously this is a very crippling disorder. And if you pay attention to what causes this patient to not really show up and take help and suffer alone, we get some insights as to what is really causing this patient to not really attend to his problem early on compared to other mental illnesses, which kind of take help more sooner. Now, in any psychotherapeutic interviewing, it is a patient, though we are made to believe that we know everything about the patient, but it is a patient who actually is the expert on his problems. So it is his problems which will guide us to the direction of the right intervention. But if he doesn't tell us all his problems, we will really not be able to treat all the problems effectively. So especially in OCD, it's very hard for the patient to reveal very difficult thoughts, crippling thoughts, shaming thoughts that he may be having. And so when we interview this patient, we just keep noticing moment to moment as to where this patient is getting stuck and see if we can help him get unstuck and move on. So this is a case of a 32-year-old male IT employee. And we just, as usual, we'll ask the question, that is, what is a problem that I can help you with? Now the patient says, I have a habit of checking locks. So we get a clear idea that there is a compulsion. But he also adds another problem. And he says, I feel that people will judge me in my office if they see it. So now we see that other than the problem of compulsion, he's also bringing us a problem of projection. He has a feeling that other people are judging him. Now the question for the doctor is, what do we explore first? In case we start exploring his other compulsions and thoughts, and he feels that people judge him, you will not be an exception. You will also be coming into one of those people who might judge him. And if he feels you're going to judge him, he's going to be more anxious and he's going to close up. So before we explore the problem of compulsions and thoughts, we'll have to first work on the projection to see how we can deactivate this projection that he may place on us, that we are judging him and not helping him. And once we can deactivate it, hopefully the patient will be more comfortable to reveal his entire problem to us. So then how do we go forward in dealing with the projection? So the psychiatrist says, what thought would they have about you? Exploring what kind of thoughts this patient has about judgment. The patient says that I have OCD and some mental problem. And all of us who are practicing for many years, we know that this is a common thing that the patient worries about, that people will see his compulsions, they will judge him, he will not get married. And so this really dominates the theme. And, I remember a patient who would call me and identify himself. Hello, madam, I want an appointment. I am OCD Srinivas. So it was like, he kind of identified as though he is OCD and not that OCD is a problem that he suffers from. So how do we work with this? So the psychiatrist says it's interesting. you have a thought. Now we are pointing out the agency that this is not a thought that others have, but this is the patient's own thought that you have a mental problem. But when you have this thought of what others might think, what do? Now we are trying to see what does he really do because of these projections. Patient says, I avoid people and I avoid get-togethers. Now this is telling how his social anxiety is coming into play, how he's becoming a recluse, because what is coming up is projections. Now projections are happening to all of us all the time. I mean, I'm talking to you right now and I'm wondering whether I'm saying the right stuff, what everybody would be thinking. It's normal to have projections, but if it stops you from really leading your life, that's a serious problem. So the psychiatrist says, since you are here, you must be wondering what I must be thinking too. Now, we are not going to be an exception. You know, how much of a kind we are, how much of a nice we are. We're not going to be an exception because if the patient projects, he's going to project on us. So unless we clear up how he sees us, he won't build a trusting relationship with us. So patient says, I think you'll think I am crazy. The psychiatrist says, so even before I have come to know your problems, you have thought that I'm judging you. This will help deactivate the projection because the psychiatrist helps him see that he's not judging him, but the thought in the patient's mind is judging him. Patient says, yes, why wouldn't you? You would think I'm an OCD patient. Again, the patient is not convinced as he sees himself as the problem. It's enmeshed. I am OCD. Now, if the patient thinks he is OCD, every time you say, what's the problem? He thinks I am the problem. And if he thinks he's the problem, the outcome will be he'll get depressed. So we have to help the patient enmesh himself from his problem and see himself as different from his problem. The psychiatrist says, I did not say that. In fact, I would say that you are suffering from OCD. We help him see this is you and that is your OCD. Shift awareness to OCD being a problem instead of he being the problem. Would you agree with me that OCD is a very difficult problem to live with? Patient says, but it still makes me an OCD patient. Now, he resists empathizing with himself for some strange reason. He doesn't feel sorry that he's suffering. Now, we're curious, why? Psychiatrist says, yes, it does. But would you agree that it leads to suffering? OCD leads to suffering, shifting his focus to his suffering. Now, patient is a bit quiet and reflective. Psychiatrist says, that's a lot of suffering, to suffer from OCD. Help him see that he suffers from OCD and he's not, he's not the problem. Patient becomes teary. People don't understand. Now he's getting a flicker of understanding. Now we see some emotions coming up. In a way, it's telling us the patient has become a little more empathetic towards himself. He says, like my parents, they laugh it off as if it is silly. And now we can see why he's afraid of judgments and why he has not learned self-compassion, because the people he's growing up with don't take his problems seriously, and it's a serious problem. And they don't show compassion, they in fact laugh. Psychiatrist says, yes, but you and I know that OCD is no laughing matter. It's a serious problem. Help him clearly differentiate himself from his problem of OCD. Would you say we look at it together with the seriousness it deserves? In this way, inviting partnership. Patient sighs. Now, sighing is usually a very good sign. The patient starts sighing, it means something is shifting in the patient. Psychiatrist says, can you tell me more about your thoughts, fears, behaviors, impulses, and fantasies which go with the problem so that I can understand the problem? Here we continue to differentiate the problem from the patient. So when we ask for his other thoughts, we ask him, what are your problem thoughts rather than what are your thoughts? This way, we keep clear of, in a way, criticizing the patient as though he's a problem. Patient says there are some thoughts and he trails off. The psychiatrist says, I'm sure there are thoughts which intrude and disturb you, and then these thoughts are alien to you. So again, help him see that these are intrusive thoughts, they're automatic thoughts, they're alien thoughts. Patient says, I have thoughts of violence, and so I know I'm a bad person. Again, he mixes his thoughts with his personality, and then there's kind of this fusion, and he starts feeling depressed. The psychiatrist says, you have violent thoughts which disturb you, showing that it is a problem, it is alien to him. Again, he says, but I think them. So you see that there's a kind of very great fusion. The patient has started identifying with his problem. Psychiatrists say, they come to your mind, showing him automaticity, and you suffer. Patient says, I'm a bad person, looking depressed. Now, we inquire more. Why? I have violent thoughts. So that makes him feel depressed. He finds it hard to differentiate himself from his thoughts, and this leads to guilt. The psychiatrist says, sure, and now he helps him see that his thoughts do not define him. Those are your thoughts, but are you really a violent person? Helping him differentiate himself from his thoughts. Patient says, no, never. He starts sighing. That means, again, something is shifted. It's a good sign. More relieved. Actually, I'm scared of violence. Since all my life, I saw and feared a violent father who would be drunk and abusive. The psychiatrist says, so though you suffer from these violent thoughts, you are different from your father as you don't act on them. This identification with the aggressor, with his father, is now shifting. He can see he's not like his father. He's not a violent man. He only has violent thoughts, but he never acts on them. And now patient can see, I'm not a violent person. Sorry. I have some other thoughts, and that means he's more ready to be opening up to you about his other thoughts, other fears, other anxieties and compulsions. Shall we explore the thoughts which are problematic for you? And that way, the patient can give us much more information which we can use to help him and reduce his problems. So one of the problems we can watch out for in the initial interview is that projections are in place which lead to his social anxiety. And if he identifies with his problem, it's likely to lead to depression. So that is all that I had. Thank you so much.
Thank you, Dr. Sona.
Thank you,
So
Dr.
nice of you. And now we have Dr. Naresh. He'll be taking us through the newer perspectives in the management, especially of drug-resistant OCD. Please.
Job, and he has been a guide to many of us younger psychiatrists. Okay, you're doing it. Okay. I thought I need to do it. Anyway. At the outset, let me thank the organizers of the ANICPS 2022 for giving us this opportunity to present our symposium on OCD, various aspects of OCD. Dr. Rajivi has spoken very well about the symptomatology and the phenomenology of OCD, and Dr. Amla has given us the in-depth neurobiology of the OCD. And going to the other extreme end, Dr. Sonakakar has spoken wonderfully about the case which she had discussed, about the psychotherapy, psychodynamic psychotherapy which she has done. And I'll be speaking about resistant OCD. We are not yet ready, and I would like to thank again the audience, the members of IPS who are here. The hall is nearly full actually. So comparing the symposiums of other rooms which I have attended, I think this is the maximum attendance we had the symposium, that too on the last day of the last session actually. Thank you very much. Thank the audience. Very true. Okay. So this is not me and this is not my presentation. I think obsessive compulsive disorder, as we know, as more of neurobiological disorder, but speaking about OCD, recent evidences over the last period of couple of years, it has shown that it is more or less a systemic illness. So what do I mean by systemic illnesses? It has more of immune mechanisms and inflammatory mechanisms that are responsible for the symptomatology. But what we are trying to describe at the brain and the psychiatric level is we are treating the symptoms. And likewise, when we talk about comorbidities with OCD, it is not just psychiatric comorbidities, but medical comorbidities as well. So what does it mean now is that they have a common underlying genetic basis as well. So if a person has diabetes with certain genes, he may be prone to develop obsessive compulsive symptoms as well. And the person with obsessive compulsive symptoms, so we are not discussing in terms of a disorder per se, is that they may have more propensity to develop diabetes, hypothyroid, or even hypertension. So all these are interlinked diseases with underlying common things. So they can present as OCD symptoms first, but then later develop diabetes. So it means that the OCD symptom itself is a symptom of diabetes as well, as we recognize. And sometimes if the person develops diabetes a certain type, then that can be a symptom itself of OCD. So we are at that stage where we are trying to, what is called as, we are not categorical. Categorical means he should have only OCD and nothing else, right? So we are gone with those days that we are trying to think in terms of, say, boxed kind of a thinking. We are now thinking more broader into more genetic kind of diseases that we are evolving into. And probably, as we know as genes now, they may have multiple roles itself. So each gene can have effect on several intracellular processes or cellular intracellular pathways that can present in a different way in different organs. Though we are giving serotonin molecule, or though we are giving, say, sertraline molecule, we don't think that it is acting only on the brain. It is acting on several other parts as well. And probably it can help in control of diabetes to some extent. Like we use metformin molecule, which is useful for many other diseases as well because of the underlying intracellular processes which it can affect, right? So am I ready? It's not visible here. Right. I hope the chairperson is very kind enough to give me some more time because it's not due to technical issues. Thank you, sir. Right. Coming? Not yet.
Can you change the slides from there while being prompted by Dr. Naresh?
Yeah. Yeah, that's fine. Anything is fine. Okay. Can I change it then? I can't change it. No? Okay. Okay. let me try in a different style. Right. Thank you everyone for having patience. Yeah, these are the various papers which I have taken, and the various. Can you have the previous slide? Yeah. So my references are from these big players in, not isolated players, they are academicians, researchers from across the world. Dr. Y. Janardhan Reddy, Dr. Shyam Sundar, Dr. Rajshekar as well. And Naomi Feinberg, that she has done terrific work in OCD, the Palanti and Johar as well, among others. And I have taken some of the parts from IPS guidelines on OCD and International Collegium Working Group for the OCDS. You can have next slide. And these are the various, this is one of the recent studies which is there, which is published in International Clinical Psychopharmacology. The next one. And this is just the outline which I would like to talk about the brief introduction, the first line treatments, management of treatment-resistant OCD, role of psychopharmacology in health-related, quality of life, evaluation of clinical response and relapse, and how long should the treatment continue. Next slide. Right. So these are the various anxiety group of disorders. There's a brief, but I think it's not necessary. So what we are necessary is that we know that OCD is a type of anxiety group of disorder, belongs to anxiety group of disorders among others, and the prevalence is 0.8. Right. Next time. And the comorbidity is a rule. I think in the first slide, Dr. Rajivi has pointed out that psychiatric comorbidity is between 70%. Right. And these are the various comorbidities that we have to look for. So again, when we talk about comorbidities, just think that the underlying genetics are different. I mean, some of the disorders have same underlying genes. So it means that they are on a spectrum of illnesses. We are not looking at categorical illnesses. Next slide. And these are the various neurological disorders that can have the OCD symptoms as well. Next slide. And we need to know again that OCD genes are already there by the time they are formed, and it is there in the fetus as well. It is a neurodevelopment. It is there from the first day of birth. So it is a neurodevelopmental disorder. It's a continuous disorder. It's a persistent disorder. Only the symptoms may be episodic, but underlying disease process is going on. Intracellular processes are going on. Right. So that's what we need to think. There is no episodic treatment. You can stop after 6 months. You can stop after 9 months. No, we are treating the underlying disease, not the symptoms. Right. So that is what we need to remember. And if you are not treating the disease, underlying disease, that can lead to complications, including comorbidities, including medical and psychiatric comorbidities as well. So we are worsening that illness. Suppose we are treating diabetes. Suppose the glucose level is normal and we are stopping it. What it means is the underlying disease is going on, and that can lead to even renal failures or say nephropathy, ophthalmopathy, and all kinds of retinopathies and all that. So we need to treat the OCD treatment. So it is persistent treatment. So remember that. The next one, and it's a next slide. I can change it. Okay, good. Where should I show this? Kahan dikhana? Change karna. Show the okay screen itself. Right. Okay, and it's a chronic disorder. So that we need to remember that. So just keep these two things in mind. If we are able to detect OCD from the first day of birth, whatever the symptomatology that can be present, or if we can able to detect by some other signs, better start the treatment as early as possible, because we are trying to prevent long-term effects, long-term quality of life. Right. And we need to know the differences between response versus relapse and the realistic goal for treatment as well. So we know that our medications are not 100% what is called, because OCD is a complex illness, right? It involves various parts of the brain. It involves various genes. It involves various symptomatology or phenomenology. It involves various genes. There cannot be a single medication of choice. It has to be a polypharmacy. It has to be a medication that acts on multiple aspects of OCD. So always remember this as well. And OCD is a chronic disorder on the basis of current evidence. Can I go back? Yeah, okay. On the basis of current evidence, long-term treatment with SSRIs is indicated to protect against relapse for most cases, and treatment should not be discontinued. Clinicians need to inform their patients about the risk of relapse and what happens if they don't get treated for long term, right? And what happens if they stop the medication. We need to educate them so that the decisions about maintenance treatments can be agreed upon. And yes, we know the YBOX scale. So less than 7 is subclinical, 8 to 15 is mild, 6 to 23 is moderate, and 32 to 40 is extreme. There's a 1 second gap, I think. What I press. Anyway, right. So based on YBOX scale, I mean, definitions of response for OCD and various other, we need to remember response, partial response, relapse, remission, and recovery. So all these are very important. And you may have missed 1 hour here. You may be thinking, why did I miss? There is no recurrence. Because recurrences, they have to come back to baseline. There's no baseline. Right? So we need to remember that. And right. So according to say, I mean, the international guidelines, which I tell you, the Feinberg, the treatment resistance is equal to non-response to 2 trials of 12 weeks of SSRI at therapeutic dose. Every word that I'll discussed here, I'll tell you what is the problem with it, like, right? So we are trying to discuss about the treatment resistance, and finally remember this statement. And resistance OCD, the predictors of non-response, we need to always think in terms of other illnesses, other longer term. I mean, in adults, say the predictors of non-response are long illness duration, early age of onset, chronic course, compulsive rituals, comorbid tics, comorbid personality disorders, previous SSRI treatment, subclinical depression, and hoarding as well. And in children, we need to look in terms of comorbid ADHD, comorbid tics, oppositional defiant disorder, and comorbid autism as well. And the resistant OCD is a pharmacological algorithm. What exactly we do according to, say, the guidelines as per the first line treatment is SSRI, maximum dose, tolerating dose to 12 weeks. And after 12 weeks, if they don't respond, review the diagnosis, switch to SSRI or switch SSRI or clomipramine. Again, re-go for the maximum dose for 12 weeks. Again, increase dose beyond formulary limits, add a second generation antipsychotic, add haloperidol, intravenous SSRI or clomipramine, and combine clomipramine and SSRIs. Otherwise, after this trial, novel agents. So this is the pharmacological algorithm. And usually the first line treatment in OCDs, we know are the SSRIs, higher doses, 12 weeks duration, adjunctive medication, CBT or ERP, that's what is the guidelines say, and combine 1 and 2 as well. But still we have up to 40% fail to respond, and relapse is common. Now again, which SSRI? So we have several studies, meta-analytical studies, network analysis, this is called. And we have fluvoxamine, sertraline, fluoxetine, right? There's evidence for most of these things apart from the CBT as well, clomipramine. Right. There are studies for escitalopram too. So these are the pharmacology of OCD, the common drugs, efficacy versus tolerability. We need to, what is called weigh by patient to patient. The evidence for antipsychotics which are there, evidence for NMDA, glutamate receptor molecules, the memantine. And again, definition of treatment resistant according to IPS is no satisfactory response to adequate trials for at least 2 SSRIs over 12 weeks. Treatment refractory or intractable. The greater degree of treatment resistance, failure to respond to a variety of anti-OCD treatment strategies, including combination of agents, as well as behavior therapy, and responder is decrease of 25% score on YBOX scale from baseline. And they have given various, sorry. Yeah. So again, reasons for treatment resistances, we know this inadequate drug trials are there, and comorbid conditions are associated with lower treatment response, and other disorders, comorbid disorders, and late onset of treatment. So these are the things that we need to have in mind. And usually the dose. So the studies, RCT studies of fixed doses of SSRIs, most of the RCTs have done with single SSRIs, and they have gone up to the doses like we have said here. The fluoxetine maximum is 60 milligrams, sertraline 200 milligrams, paroxetine 60 milligrams, citalopram 60, escitalopram again is 20 milligrams, and fluoxamine we have studies up to 300 milligrams. Right, and higher dose SSRI monotherapy for resistant OCDs. These are the various doses. There was a study again conducted, and I'll move forward. There was again, this is another study, high dose SSRIs in OCD, and doses were not much. So the maximum dose which they have, so what is called gone through these studies were clomipramine 250, escitalopram 20, fluoxetine 80 to 120. Fluvoxamine 300 to 450 milligrams, paroxetine 60 to 100 milligrams, and sertraline 200 to 400 milligrams. And these are the various studies and responses. The clinical response on these medications, fluvoxamine has the highest treatment response of around 63%, and the remaining are around 35 to 50% response rates on higher maximum doses. Right. So what do we mean by maximum tolerable doses? There are American Psychiatric Association guidelines as well as Indian Psychiatric Association guidelines which state that apart from the doses that they can use, there's something called as maximum tolerable dose. If the patient is, so I think many of us miss that, and many of us don't have confidence to go beyond the prescribed guidelines doses. Right. So this is a very important word, the maximum tolerable dose. So what it means is that you can go beyond whatever is prescribed as long as tell the patient that you are going beyond this dose of prescribed guidelines, but you are able to tolerate this. That is one, and you are partially responding to the medication. So why give up the medication now when you're partially responding to that medication to that dose? So increase the dose and let us see what happens, right? And the switching of SSRIs in OCD. Right. So common treatment strategies according to IPS guidelines for resistant is combined to SSRIs, but the advantage is difficult to explain because of the various receptor profiles. And let me tell you that no two SSRIs are the same, right? Only escitalopram and now say what is called vertioxetine are the only true SSRIs, but the remaining have different action on different receptors as well, right? And then we have combined SSRI with an SSRI, but there's no significant difference according to studies. SSRI with adjunctive agent. So there are other agents that can be tried with an SSRI, and SSRI with cognitive and behavior therapy or ERP. There is evidence, but still not sufficient. And what about combining two SSRIs in resistant OCD? So there were a couple of studies, two open label studies, fluoxamine plus escitalopram and fluoxetine plus citalopram. They showed good clinical improvement. Addition of another SSRI increases the active S enantiomer of citalopram compared with its R enantiomer, leading to greater reuptake. So that is the advantage which the study has found. So combining clomipramine plus SSRI, there's potential interaction with hepatic microsomes, and ECG monitoring is usually recommended. Escitalopram and sertraline are less likely to interact with clomipramine. And RCTs in resistant OCD adjunctive treatments, they do have aripiprazole, haloperidol, risperidone, olanzapine, and quetiapine have some evidence of adding these molecules, and apparently ineffective molecules, according to the studies, are lithium, topiramate, buspirone. All these have been tried, but they were ineffective according to studies. And then the question is, how long to remain on treatment? After every visit, the patient asks, और कितना दिन लेना है? और कितना दिन लेना है? आप 5 साल से इलाज कर रहे हैं, इसका इलाज ही नहीं हो रहा है, right? So that kind of dialogue I keep repeating. I said that your quality of life is much improved, right? There was a CRPF candidate. He was afraid to carry a gun, but now he's carrying gun, right? So there are so many teachers who are able to do their jobs. Nurse was afraid of blood, who had these recurrent thoughts, or especially OCD thoughts, and she's able to do her job. Well, otherwise, she was on long leave from the government hospital where she was working. So there are so many examples where the quality of life has improved, right? So many success stories are we come to hear about. So the 5-year course of OCD, the predictors of remission and relapse in adults, basically, a couple of studies, the 5-year follow-up, 22% had partial remission and 16 or 17% had full remission. And good predictors were obsessions regarding harm, lower OCD severity and shorter duration, and bad predictors were primary hoarding disorder or personality disorder. And 59% of the patients who remitted subsequently relapsed. So, and in adolescents also we have similar studies, but the 3 years follow-up studies were done. And the conclusions were remission is more likely among youth versus adults in OCD, and treatment early in the course of illness and before substantial impact on functioning predicts a better response. And antipsychotic augmentation also was done. And again, do SSRIs improve health quality related disability and quality of life? Several studies have shown, yes, they do improve the quality of life. So that is more important as well. And this is a couple of studies. And this is the case series which I'm trying to present. You can see, I don't know if the print is not good. There are a couple of patients, right, wherein the dose is increased gradually, and there is what is called 90% improvement in the symptoms of the cases which are, is a software professional, right? The fluvoxamine dose, you can see here is 350 in the morning, 350 in the night. So that is 700 milligrams of fluvoxamine. Right, I have a couple of patients who are more around 900 to 1200 milligrams of fluvoxamine as well. And the quality of life which they, the magic word here is maximum tolerable dose. You discuss with the patient and increase the dose gradually. Right, discuss with the patient that you are trying this for your own benefit and the quality of life is very good, extremely good. But he should be partially responding to the medication till that dose. If he's not responding, there's no point in increasing beyond 300 milligrams. Right. And there's another patient, and he's gone into medical school actually. So he's on, say, 600 milligrams of, say, fluvoxamine, 75 milligrams of, he's on 300 milligrams of venlafaxine as well, and clomipramine as well. And again, you're doing this because you're in what is called in discussion with the patient. You need to explain him what you're doing, why you're doing this as well, and tolerating those doses. Right, he was an intermediate student, that is 11th and 12th. He has cleared his NEET exam and now he's on the way to become a doctor as well. Otherwise, he has attempted 3 times before the NEET, he could not succeed. Right. And I think the down patient is one more patient, the previous one. Yeah. So here the dose combining fluvoxamine is 600 milligrams, sertraline is again 600 milligrams in this down corner patient. And this is another patient who is on aripiprazole. So there's a small case series which I have done over the last 3 months. Actually I was preparing for January. So it was done in September, October, November. So 3 months, it's an open label in my own hospital. Right, from September, October, November, 96 patients of OCD were seen, 64 were male, 32 were female, 28 patients were on higher doses than prescribed guidelines, 17 patients were on combination SSRIs, 4 were on SSRIs plus antipsychotics, and of the 28, 16 had Vibox near complete remission since greater than 1 year, and 8 had up to, what is called 12 of the 12 patients remaining, 8 had only mild symptoms, and 2 had moderate and 2 had severe patients. So what it means is despite those higher doses, 2 did not respond. So I need to think what should we do next, like after, despite having higher doses. Right, in summary of resistant OCD, OCD is a neurodevelopmental disorder, OCD is a chronic disorder, comorbidity is a rule, 40% are difficult patients or treatment resistant OCD, 30% require mega doses combination of SSRIs, antipsychotics subject to the maximum tolerable doses, and treatment resistance is dose and duration dependent, and long-term treatment with SSRIs prevents relapse. So the magic statement is maximum tolerable dose plus symptom alleviation as measured by Y-box plus quality of life of the patient. So we need to see, we are giving SSRI high dose, and suppose he is not having the quality of life because of the side effects. So we need to do something else, right? So always keep the patient on your hand, always keep the patient agreeable to your terms, and say mutually you can increase to alleviate the disease. Thank you very much.
Hello. I think Dr. Naresh and the whole team deserve a standing ovation.
Thank you very much, sir.
Presented
Dr. Amala and Rajiv, you can come down. No, I thank Dr. Rupenderji, the senior most psychiatrist who has come here personally to visit Vizag after a long time. We are having a physical conference, and his energy and stamina stands out. And I thank him to be the chairperson of our session. Thank you, sir.
I would like to ask the chairperson to felicitate our speakers. Dr. Rajiv. Dr. Amala. Dr. Naresh.
Presenter of any psychiatric topic, and besides psychiatry, he can speak
I would like to ask Dr. Naresh to felicitate our chair. Okay.
Hello.
Yes, hello.
Should we start the session now? It's already late.
I know. Just 2 minutes. We are waiting for the chairperson to come. She's just on her way. She'll be here in 2 minutes.
Who is the other chairperson with me?
Dr. Malika is the chairperson.
And I am also chairperson of this, Dr. Behere. Hello.
So Dr. Malika will be chairing with you.
Okay. So we'll wait.
Yeah, she's coming in like 1 minute. So we'll
Okay.
start as soon as she's here.
Hello, Dr. Prakash sir. Am I audible to you?
Hello?
Am I audible to you, sir?
Yeah.
Very good afternoon, sir. Very
Good afternoon.
It's nice to see you after a very long time.
I am from UK now. I'm sitting here in, it is early morning at 7:30.
Okay, you're now in UK.
Yeah, I just give a couple of months, you know. So I'll come back around Diwali.
I've been reading your name and your face here and there in ANICPS and other conferences for quite some time now.
Good afternoon, sir. I'm hearable. I'm Dr. Gurvinder, sir.
Yeah, you're audible.
Yes, sir. Thank you.
We would like to start the session. Dr. Malika is here, so she'll be chairing the session for tonight. I would like to invite her on stage.
Good afternoon, everyone. Good afternoon.
Yes, ma'am. Good afternoon.
Good afternoon.
Well,
Hello.
Any organizing person is there because it is late. Should we start the session?
yes, sir.
Yes,
We are
sir.
ready.
Yes, sir. We are waiting on screen for you to appear, sir.
Okay.
Dr. Prakash, should we start?
I think so. Is anybody from organizing committee is there? Because
we
you
are
don't have any
waiting for-
introduction or anything, you know.
Yes, sir. We are just waiting for you to come on screen here, sir, to start.
I'm not coming on the screen.
No, sir. We can't see you on the screen.
Do one thing. I'll just leave and join again. Okay, give me 1 minute.
Yes, sir. Yes, sir.
Is our screen visible to everyone?
No, sir.
You're sharing now, sir. That disk wala, that all we can see, the computer part.
Is my screen visible now?
No, sir. It is only desktop is showing.
Acha.
Yes, sir. We can see you now, sir.
Now I am visible now.
Yes.
Good.
Hope it's visible. Our screen is
Yes,
visible.
yes, it's visible. It's visible.
Yeah, everybody is visible. Yeah.
Yeah.
Good afternoon, everyone. We'll start the session. I request my co-chairperson, Dr. Prakash, to proceed with the introduction of the speakers, and we'll go for the session, sir.
But surprisingly, I don't have any introduction of anybody, you know. I just got the link for this. So what I suggest is, because we are slightly late, so we'll give 15 minutes to each speaker. So it will be 45 minutes and 15 minutes we will keep for the discussion. And the best thing is that when the speaker will come, they should just tell where they are working and they can start the session, because I don't have anything about the, I know a couple of them personally, that is a different thing. So the, and Satyajit Ray is the most famous director from West Bengal and all over the world. People know, and he has done extremely well. And I think he got some special Oscar, and the Oscar team came in West Bengal, Calcutta, and they have given to him. And there are so many movies in Indian cinema as well about the mental health and mental illness.
And I don't know much about his movies. Most of his movies are Bengali and extremely well directed, a very popular person. I've seen a couple of his Hindi movie. There are some of the Hindi movies from the Indian cinemas like Barfi and Tare Zameen Par, an old film, movie Khamoshi. And even, one of the authors written a book on the mental illness depicted in the Indian movies. The book is published. So what I suggest that I will request now the first speaker, Dr. Deepali Gul, who is going to speak on creative work of Sri Satyajit Ray, a psychiatrist's perspective.
Yes.
So now everything is yours, and please start.
Okay, sir.
And my co-chair, I request that, what I suggest that at the end of the, at the end of the session, when it is over, then we'll keep question answer. So let all the speakers finish.
Okay.
Okay. Yeah, please start.
Sir, can you please put it on full screen, sir? Presentation.
So Satyajit Ray, an ambassador of mental health. So once Andrew Robinson, who wrote his biography, he said,
Sorry. First, you tell about yourself, because we don't have any introduction to anybody. Just
Okay.
one minute you tell about where are you working.
I'm Dr. Deepali from Jalandhar, Punjab. I'm working as an associate professor in medical college.
Okay, go ahead now. Yeah.
Yeah. So
Ma'am,
Satyajit
can
Ray.
you please present the presentation in full screen?
Sorry?
Presentation, ma'am. The slides are not on full screen. The slides.
Okay. Okay.
Give me a minute. Is that good enough, ma'am?
Yes, Dr. Deepali.
Yeah. So Satyajit Ray, an ambassador of mental health. So once Andrew Robinson said, I think I understand human psychology. So Satyajit Ray once told Andrew Robinson his biography. So you can see in this picture, Satyajit Ray, a multifaceted genius. And Satyajit Ray as a filmmaker, as Sir said, Ray made his directorial debut in 1955 with Pather Panchali and directed 36 films comprising 29 feature films, 5 documentaries and 2 short films. So these were the movies, Pather Panchali, the first movie, Aparijito and Apur Sansar, which were very famous. So this is basically a list of the movies directed by Sir. So just a list. So why we have chosen this? Satyajit Ray's movies and mental health. It is an overlooked aspect. His most celebrated work, Pather Panchali, has interesting though hidden narrative of mental health. Even his movies in black and white share a modern and emerging dimension of mental health, of the care, of the need to go beyond the limits of psychiatric disorders. Satyajit Ray, the filmmaker. So, a short film with the running time of only 12 minutes would be the other film reviewed by my colleague later. What binds these movies together is that they talk of mental health in great depth without actually depicting a specific disorder. So the writer flew the swift. Professor Professor Shanku, the scientist. So I'll tell you about this. Satyajit Ray, the writer and ambassador of mental health. Recently, a lot of people have become aware of Ray's literary works since the release of the Netflix anthology Ray, which adapts 4 Ray short stories for the screen. Mental health in Satyajit Ray's literary work. Napur Chandra Viswas, a frequent character in the Shanku books. So I've shown the picture of Shanku books. Napur Babu is written as a psychic with the ability to get flashes of the past and future, but his capabilities emerge from being an extreme impact. Barin Bhomik, from the short story Barin Bhomik Ir Bayram, is a kleptomaniac who has been through therapy for years to get cured. And in Bipan Chaudhary, our Smriti Bharom, the lead character suffers from a curious case of memory loss and embarks on a journey to find out what caused it and what is in that his mind is pushing him to remember. And moreover, in Friends, a 37-year-old man explores a childhood trauma and tries to deal with its roots. This is how its contribution to the mental health. So mental health and race literally works. Another brilliant example is the Feluda story, Dr. Munshia Diary. The story revolves around the murder of Dr. Munshi, a leading psychiatrist, and people in his household. And out of these household members is a patient who has persecutional mania, the irrational fear of feeling that you are the object or target of collective hostility and persecution. And this story was published in Sandesh. Sandesh is a magazine in 1990. So you can see another aspect of Sir Ray, the graphic designer. Ray created originally fonts for the English as well as Bengali scripts. He created 4 fonts for the English script: Ray Roman, Ray Bizarre, Daffins, and Holiday script. So this was the design made by Sir Ray. For the younger generation, this inspired one to follow one's inner talents. So this is basically depicting Durga Mata, and this is the design made by Sir Ray. Now, moving on to the next presentation. Thank you.
So good afternoon, everyone. I'm Dr. Gulbahar Sidhu, consultant psychiatrist from Jalandhar, Punjab, and my job is assigned to me is the word. I'm supposed to review the word of movies made by the great maestro. Dr. Dipali just gave an overview of the creative works of the great man. So, talking of his movies, Satyajit Ray directed 29 full-length feature films and 2 short films, as just told. All his works are in Bengali, except one full-length feature film, Shatranj Ke Khiladi, which was made in 3 languages, Hindi, Urdu, and English. And one of his short films, named 2, does not have a spoken word. It's a silent movie, and we'll just discuss how it speaks so many words even without uttering actual words. Now, before I move on for a review, I feel it appropriate to make an honest confession that we have not been able to review all the movies made by the great filmmaker. And the reason is not because of the volume of his works, but because of the sheer depth of his creations, the multiple layers of emotions and multiple layers of narrative that each of the movies contains. So I had to see each movie quite a few times again and again to get the full gist because I was assigned the task of reviewing it as a mental health professional. So the movies which will be the focus of my presentation include the landmark movie Pather Panchali, Aparajita, Apur Sansar, and Charulata. And besides that, last but definitely not the least, this short film called Two, one of the Satyajit Ray's hidden gems. That's what the critics prefer to say, and that's a rare unanimity you hear among the critics. That kind of a movie is this. So first we'll have a look at Pather Panchali, the most iconic, the most celebrated works of great Satyajit Ray. It's a story of a downtrodden, very poor family, Bengali family, having the father, he's a writer by profession, and they have two children, an older daughter named Durga and a younger son named Appu. It is Appu's life story which goes on in the trilogy, which we'll just talk about a little while later. So the movie brings to the fore, without wasting time on the plot and the story, the movie brings to the fore a new way of looking at mental health issues that plague our society. I mean, I saw the movies the first time, second time. The one thing which struck me is this, that mental health issues pervade every nook and corner of our lives, both longitudinally and within the span of a moment. And Satyajit Ray had the greatness to cover it in both ways. He covered it longitudinally when he made three movies on the life story of this boy called Appu. And this is the first of the three. And when we talk of a moment, it's the whole movie has so many hidden nuances of mental health within each and every moment that this great director has captured. The other thing which struck my mind was that talking of mental health need not be talked of within the framework of the standardized diagnostic frameworks of ICD-11 or DSM-5, etc. It is in that sense, we need to understand the overall life situation of a person as well as the cultural background of the patient. There may not be a specific disorder evident in individuals around us, just as in these movies. Yet, they do have their own unique mental health issues that we, as members of the society and as mental health professionals, need to be sensitive about. For example, when we talk of this movie, Pather Panchali, where there's this old grandmother who is frequently she's made to she's a focus of the anger of all other younger members of the family because she's not able to do much physically. She's not earning, and that is one of the major factors when it comes to such a downtrodden family. Yet, and the then sensitivity and the starkness with which Satyajit Ray has captured the indignation suffered by the grandmother, that itself is underlines this fact that all the individuals around us, even if they don't have a specific disorder, they do have mental health issues. And Satyajit Ray did a great job by capturing all of them in stark reality in a very objective way. And the other thing about this movie, the unique topography of a child's mindscape. It's been beautifully captured here of being unconcerned about the goings on around within the four walls of the home and also around our neighborhood. And this is beautifully captured by the following clip. I'll be just sharing this clip if I can. Is this clip visible to everyone? So this is Appu having an enjoyable time, unconcerned, unconcerned about what is going on. And the unique topography continuing with this child mindscape. Satyajit Ray has very brilliantly captured the impulsiveness and the guilt that we all have gone through in our childhood, the rebelliousness of the childhood. It is exemplified by these two children, Durga and Appu. And who can forget, when we talk of guilt, who can forget the last scene of this iconic movie where Appu discovers the necklace which was stolen by Durga and she denied it all along. And after she dies, Appu discovers that necklace in her belongings and he decides to throw it in the village pond. So this kind of narrative I have not come across in any movie that I have seen till now. And there's another one brilliant shot which I would like to portray now. There's again a childscape, how the grandmother narrates.
আমার মন্দিরে খেয়ে জাগে রে কমল ফুল আর কমল জাগে তারপরে আবার দুপুরের সময় আবার আপুসি এলো মানুষের গন্ধ পাবো আমার মন্দিরে খেয়ে জাগে রে
So this is a wonderful storytelling by the grandmother to his grandchild. And talking of two, a unique insight. At last, this story of two boys, one rich and the other poor. So they decide to show their belongings to each other. This is what the story is all about. And this movie was made at the time of Vietnam War. And many critics point out that the rich boy is symbolic of the United States and the poor boy is symbolic of Vietnam and other developing nations. And this duel between the two players, the two children, reaches the conclusion when rich kid gives in to the obstinacy of the poor kid, and the closing shot of the film frames him in an isolated, crestfallen state, possibly reflecting on his actions. And the closing shot, the ultimate closing shot, is when the poor boy continues to play the flute, thus showcasing the emotional resilience and the will to carry on against all odds. And there's been a criticism very widely made of Satyajit Ray that his movies glorify poverty. Now, this has been one of the loudest criticisms of his movies, but portraying poverty in stark detail has a hidden mental health narrative as well. This is what struck me. Mental health in an unequal world. You know, this is the theme of this year's World Mental Health Day. And each character in the movie here has its own mental health issues to contend with. Even the poorest of the poor have reasons to be sad, worried, anxious. Even the poorest of the poor have reasons to be optimistic and happy. The following clip, which I'm going to show in the next slide, underscores this point that the poorest of the poor have their own reasons to be optimistic as well.
আমার বাগানটা হাত করে নিলে চোখের সামনে সে এখন বললে হারান্দা বেঁচে থাকতে নাকি 300 টাকা ধার নিয়েছিল ওদের কাছ থেকে বাগানটা নিয়ে সেটা শোধ করে নিলে বাগান থাকলে কি আর সংসারের জন্য ভাবতে হবে আম জাম নারকেল সব দরের গোড়া থেকে ছুরি ছুরি কুড়িয়ে নিয়ে যাচ্ছে আর দুটো একটা পেয়ারা পানলে ক্যাট ক্যাট করে কথা শোনাচ্ছে এদের আমার লাগছে কোথায় এরা করবে সুদের কারবার আমি থাকবো লেখাপড়া নিয়ে কি তোমার লেখাপড়ার কথা শুনি এই অত পাড়াগায় আমার মতলবটাই শোনো না আমি কি লিখছি তোমায় বলি সব নতুন নতুন পদ নতুন নতুন পালা আরে একবার রুটি গেলি অধিকারী দল সব পিল করে ছুটে আসবে বুঝলে না তারপর চাই যে সব নতুন জিনিস কিন্তু পাবে কোথায় নতুন জিনিস কি গাছের ফল দেখলাম তো সব আজকালকার নতুন লিখিয়েদের সব পুরনো ভাঙিয়ে যাচ্ছে সেই থোর বড়ি খাড়া আর খাড়া বড়ি থোর আরে সেই সব যদি চলছে তো নিশ্চিন্তপুরের হরিহর রায়ের নতুন খাঁটি জিনিস চলবে না কি বলো হ্যাঁ নিশ্চয়
So, talking of, let me just clarify to the audience here that I'm a Punjabi, but I was able to follow this clip because I could read the subtitles. So this, the father talks of the better times ahead. He's a dramatist by profession. He tells that things will get better. Don't you get worried about it. He tells his wife that the moment my plays start running around in the villages, our economic situation will improve. Talking of this hidden crown, which I was telling, the short film with a total running time of 12 minutes. So this short film was made in the context of Vietnam War, and it's a revelation when it comes to the portrayal of mental health issues. The childhood joys of both a rich and a poor child are remarkably similar, as is shown here. And I'm not able to show you the clip of this movie, not because I couldn't download it, but the movie is so well knit that you break it into clips and the whole magic is lost. And I don't have the time to show all the movie, 10 minutes of the movie here. Satyajit Ray's movies also talk of resilience, the resilience of Sarbojaya, the mother of Appu. even in the most difficult situations. And here, this particular clip shows this wonderful resilience, and the resilience of Appu too. Because after his sister dies, look at the face expression of Appu. So, on the whole, what the message which I wanted to convey is that Satyajit Ray's movies are an excellent teaching material for postgraduate trainees or young psychiatrists, in the sense that young budding mental health professionals need to be sensitized about psychiatry in everyday life. That is mental health beyond the boundaries of psychiatric disorders and the mental health issues that plague the marginalized sections of our society. These are the three aspects which are very well portrayed by the great filmmaker. And just to sign off, this is one clip which is hauntingly beautiful from the movie Pather Panchali, and this is where I conclude. It shows us the onset of rainy season, which symbolizes the change in the mental health scape of this family of Appu. I think no movie has captured the onset of the rain in such a beautiful way. So, after this beautiful visual, I'd like to pass it on to Dr. Gurvinder Pal Singh, our third speaker for this symposium, who will talk of the literary works of Satyajit Ray and the mental health perspective there. Thank you so much.
I am audible, sir?
Yes, you're audible.
I'm really grateful to the organizer, respected chairperson, co-chairperson, Dr. Dipali Gul, Dr. Gulmar. They have made my work very, very easy. But I'm going to talk is just the repetition they have told. And is very, very, I'm really grateful to Dr. Gulbahar. He has given me this opportunity to go through the various articles of Satyajit Ray, his books, and really very, very fascinated by the Dr. Gulmore movies. So I will also just briefly talk about what Dr. Dipali Gul has told and just summarize it, taking time into consideration. This is a very famous line by a famous Japanese director, Akira Kurosawa. Not to have seen the cinema of Ray mean existing in the world without seeing the sun or the moon. So when I just collected this quote and go through the various movies and literature, I said that Japanese director was absolutely right. The year 2021 marked the birth centenary of renowned Bengali film director who writes his own stories and screenplays. I was just describing, he was a poet, author, philosopher, human faces of a genius, as told by a other speaker also. He was a social reformer, amateur astrologer, multi-talented, illustrator, perfectionist. He involved in minute details of his novels, stories, or movies, whatever you see. He was a polymath, composer, music composer also. Designer, as Dr. Dipali Gul has described. He was the only Indian filmmaker to receive an honorary Oscar for lifetime achievement in 1991. He also received Bharat Ratna also. As Dr. Gulmohar and Dr. Dipali, mostly his team were around the mental health. And Dr. Gulmohar was talking about the PG resident also. Yesterday, I talked to my PG resident also, but they were not very entertained. I told them when I was doing MD psychiatry, we were having a music club type like that. We are having a movie club, and used to have our teacher used to show some beautiful mind-like picture. So this is absolutely whatever Dr. Gulmohar is saying is very, very important to PG. So mental health, consumerism, dynamics of socioeconomic found in the race complex works. As Dr. Gulmohar has Patr Panchali in 1951, he has a command authority in Bengali literature. He wrote several short novels and stories. Race stories and novels do pressure reader we think about. As Dr. Gulmohar was showing the clips of the movies, so they were giving us to think about those. His art fiction were targeted to the young readers, particularly teenagers. This remained about various true about mental illness and issues. His Bengali language film were in sharp contrast to the escapist and formula confections of music, dance, romance, and violence of the vast Hindi language film industry in Mumbai. So it was a very contrast. He received some criticism also, as Dr. Gulmohar was saying, particular poverty also, but that is a reality, sir. So he's a totally different type of music and movies, sir. In most of the various two famous characters were there. Feluda, the Sleuth, Professor Shonku, the Society, Dr. Dipali Gul has told about it. And this list is very, very exhaustive. Dr. Dipali Gul has showed there is original title and the English title. And on them, some movies has been made. For example, in 1971, Sonar Kela. And another is, so list is very exhaustive. You see, so many things are there. So he has also told about Professor Shonku. So see the article, Professor Shonku's Deeds, Bravo Professor Shonku, Shonku in Deep Peril, none other than Professor Shonku, Shonku Alinal, Shonku Once, Heads of Professor Shonku, complete Shonku collection. So one very, very interesting this. So if there is, you see, there are 35 story based on Feluda stories. So this is a fictional Kolkata-based private investigator. So as I already told you, he made it into two films. First was in 1974, Sonar Kela, The Golden Fortress, and the other was, second one is The Elephant God in 1978. So very, very interesting. 35 Feluda stories were there. As already Dr. Dipali Gul has, Professor Shonku is in this is a fictional scientist and inventor appearing in a series of science. Another are horror or spooky stories in Karne Kuro, and Bengali science fiction story in Benkubar Bandhu also. So I was just going through, then I try to make, but is the crux of the stories. He penned many stories, not based on any famous character. If you see this, there is no any famous character. Whatever it is the collection of the 12 stories published were mostly urban type, unassuming until the last line or last paragraph. You go on reading it, where suddenly a new revelation left the reader amazed. Another very trivial event change the course of one's life. So this is very, very important. Small event, brief events, they change the course of one's life in this story. So has chilling horror stories also. The language of the story was straightforward and lucid. Also, he translated some short story, mostly adventure story from English, and a collection of story named Brazilian Calobag, and translated Ray Medrovi's third expedition, and from Martin Chronicle as Mongol One Shergo, Mars is Heaven. So when I gone through movie of these two, I could not stop that I should also make one slide. So it was a 12-minute short film story of two boys, one living in building, other in a small hut. The two boys dual using collection of toys, each possesses as a bit to outclass each. Rich boys expensive toys, defeating the poor boys kites, flutes, and handmade wares. Poor boy returns to his hut with his flute under an open sky. Rich boy stays confined to his flat alone with battery-run robot for company. The robot walks unguided right into the tower he built, crashing it like a house of cards. So Dr. Gulmohar has told more about this. So this is a very, very interesting type of movie he has produced. Another is very storytelling medium about poverty that Gulmore has. So poverty, you'll find the content is inequality, corruption, colonialism, caste-based segregation. Most of these are around the childhood experiences. Changing world affected the middle class. So Ray chose storytelling as his medium to dissect them in a language readers and views of all ages. So very interesting was that life is neither white or black, right or wrong. So patience and tolerance is very important to if we want to reach to any avenue. So civilization needs to be revisited. So these are the various important medium he has chosen. How Satyajit Ray introduced the world to unheard of mental illness. Dr. Dipali Gul has already quoted this biographer first line that I think I understand human psychology. In another, further into that, he showed that I must have been observing a great deal in my childhood about people because of being a loner, in the sense that I had no brothers or sister, and I was alone much of the time with my thoughts and with my little preoccupation. So this interview second part is very interesting. He had no brothers or sister, he was loner, and he was most of the time with his own thoughts. So his understanding of human psychology and nature is beautifully reflected in the nuanced relationship he explored in his monumental, critically acclaimed movies. He also explored the same relation analysis of human psychology through his books and short stories. So what is the mental perspective race story already discussed? So this is very this real people deal within real life. So he introduced the word to many unheard of these issues. So this is very important. So another is destigmatize the field. So this is very important, especially in society like ours, where it is still too taboo despite advances. So this is a very important medium for destigma, and Ray's literally works certainly do that about the mental issues, various illnesses, disorders, treatment, and this destigmatize the field can be done, and he has done a lot of work. So this is very for PGs and our mental health. So these movies are stories, novels are very important in this destigma fields. So another was various characters in the Shanku books, his ability to get flashes of the past and future, but his capability emerging from being an extreme empath and kleptomanic, Dr. Dipali Gul has already told about it. Another about the memory loss and childhood trauma that Dipali has pointed it out, and this is very important, and how is again the childhood trauma. He explored these memory loss, how the journeys goes on, what caused it, what is in that his mind is pushing him to remember. So these are very interesting stories and novels. Another which has also been pointed out is the insight theory. What is insight? Ray wrote about it and its symptoms of a patient in 1990, provided his reader with an insight into a mental issue that many still may not be aware of. So this is very interesting, which was published in Sandesh in 1990, and this is around a leading psychiatrist, Dr. Munshi, and people in his household. And one of these household members is a patient who has persecution mania, the irrational fear or feeling that you are an object or target of collective hostility and persecution. Persecution mania is now better known as persecution complex, and the understanding of this type of psychosis evolved over the years. So this very important insight of particular is very important, narrated by these various articles. Now briefly about this summary. And continue standing time. The popularity also is still at peak. He was a human species of genius. Everything is clinical relevance, particularly in psychiatry, mental health, mental disorders, as Dr. Gulmore also pointed out. It's very important, PGs. So whatever I have learned is a very important. So many clinical phenomena, signs and symptoms are narrated in this. So this is a very important destigma campaign. We want to start it. We are thinking about it. So these are very important for our specialty, destigmatization of the various mental health disorder. So all is rotates around the memory loss and childhood trauma, loneliness, and it is a very novel medium for research. I will just say that more research, if given into this, more workshop like this and more like this symposium, they will definitely help our mental health issues. And he remains an inspiration for our generation, sheer simplicity. He has depth of understanding of content. Basically, he was a all-rounder, and I have got a lot of inspiration for reading his novels, books, and seeing and he's really a source of inspiration. Gives so much energy to do something for mental health because everything is rotating around mental health. I started with the famous quote of a famous director. Now I am also ending it with the American film director Elia Kazan. He also wrote, if he were in Hollywood, he would have proved a tough challenge for all of us. So this was the famous quote of an American film director. With these, I thanks the organizer, chairperson, and others for giving me this opportunity. Thank you. Thank you so much, sir.
Thank you, Dr. Gurvinder. And we are perfectly in time, and there are not many audience I was seeing the participants. Just to introduce myself, who do not know me, my name is Dr. Prakash Baire, and currently I am holding the post of Emeritus Professor in Wardha, which is in Maharashtra near Nagpur. I was the former Vice Chancellor of D.Y. Patil University, Kolhapur, and I was awardee of BC Rai National Award on my former suicide work in Vidarbha. So this is briefly about me. Now I am very thankful to Dipali, Gurvinder, and Gulbahar to give the detail, about Satyajit Ray, his the work on mental health. We never thought about it, and I never realized that he was a graphic designer as well. Dipali has nicely, summarized all the movies, like Dr. Munshi's Art Diary, and she showed the design of Durga by Satyajit Ray. And Gulbahar has given, clips of the movies, and a movie named Two and Pathar Panchali. Pathar Panchali is very famous and everybody knows this name. And Guruvinder, you have nicely given the crux of the stories and memory loss and childhood trauma, Farudaj's story. So people who do not know that Satyajit Ray has done work related to mental health as well, and you can take out something about it in teaching. Like when we are in PGI Chandigarh, Gurvinder was saying that, there is a movie club, and either there was a book club as well, and you have to read some book and we have to discuss. Similarly, we have to see a movie, then we have to discuss. So now things are changing. The whole education system is fast changing. The interest which you have taken in your time, the current student may not take it. Because there is a weekend, so nobody wants to come to weekend to attend the movie club or the book club or anything. So this is excellent. Any question organized? Any question in the chat box? Like Indian cinema, there are movies depicting negative aspects as well, like ECT, in very bad test they have shown it. Many of the mental illness in the mental hospital they show is the laughing stuff. So this is not very good. But Satyajit Ray's work is very serious and very effective. But unfortunately, because we don't know Bengali, although there is a subtitle, but I have not seen many of the movies of Satyajit Ray. But it is internationally very popular. All over the world, they know about him as compared to Bollywood. Because if there is no question, I didn't see any question there. So I think I will thankful to every speaker who has given an excellent narrative of the Satyajit Ray's work. So I will thank you very much, and I will hand over it to now organizer.
Yes.
Is anybody
Thank
there?
you. Congratulations to Dr. Dipali, Dr. Gurinder, and Gulbahar for that excellent presentations. As you have pointed out, thanks to Netflix, we have been able to watch some of the works on big screen now. Satyajit Ray, and I would also like to take the name of Rabindranath Tagore, both Bengali writers and filmmaker, way ahead of their times. It's surprising how everything they wrote, every stories and the movies of Satyajit Ray especially, they're pertinent to all situations, all times, relevant even now. As you said, they deal with the nonsense of the feeling. As everyone has pointed out, and especially Sir Dr. Prakash has pointed out, there are many movies in many languages dealing with psychotic personalities, borderline personalities, criminals with schizophrenias, and all those things. But normal people, normal defense mechanisms, normal things, coping strategies, their techniques for resilience, how to bring them up, how to nurture them to, in a normal setting is what this legendary filmmaker mostly concentrated on. Congratulations, and I'm happy and also surprised to see that three Punjabi people together presented this. Mostly it is done by Bengalis many times, so I congratulate once again for that also. Thank you, everyone. Thank you, sir.
Thank you, ma'am. Thank you. Thank you, sir.
On behalf of the chair, on the behalf of the speaker, I would like to ask Dr. Vijayashree to felicitate Dr. Malika, our chairperson. Thank you so much, everyone. We are done with this session.
Thank you. Thank you.
Thanks. Thank you.
Good afternoon, everyone. I would like to start the session on telepsychiatry and invite Dr. Vijayashree and Dr. Manasiram on stage to chair the session.
So good afternoon, everyone. So the topic now is telepsychiatry, a path-breaking way forward. I would like to invite Dr. Suresh Badamat sir to give away his talk.
Good afternoon, everyone. Before I start, I would like to place a disclaimer telling that in the ANICPS booklet, they have mentioned industry-sponsored talk, but unfortunately, nobody had contacted, and it is not a industry-sponsored. It is academician who wanted to discuss about the issue. So no conflict of interest. So that means it is not an industry-sponsored talk. So that's the clear wording. Before that, one more thing I would like to talk about is telepsychiatry, how it became a public health and how we have grown. So this can be understood by the history, the way the NIMANS, the telemedicine started and how currently it is present, which we have got the approval for National Telemental Health Program. So understanding about this, how this was recently the finance minister gave about the tele national mental health. So that was again our team, Dr. Naveen, Dr. Manjunath, and we presented it, and then it was accepted and it was discussed in the finance budget. So let's understand how the growth occurred. In 2007, the telemedicine came to NIMANS. Basically, before that also it was there, but it took it a major shape in 2007 when I took over as a telemedicine chief. And then by another 5 or 6 years, it became eco model was also taken from the US. And then there was a NDA came in, that is NIMANS Digital Academy came in. So NIMANS Digital Academy took the training part, telemedicine continued giving the teleservices. So during that period, the community psychiatry was also under the revolution, basically in the evolution mode in NIMANS. So in 2016, we were running something around 14 camps, that is extension clinic. So we realized that doing extension clinic was not empowering the community. Basically what is happening was 30 years of providing community services through extension camp. The local doctors and the healthcare workers said that, oh, NIMANS people are coming, just refer them. So none of them used to treat them. So every extension camp used to have around 300 and 400 patients. So it was a more of burden rather than empowering the local community. It was a kind of helicopter services. So then we decided how we can empower the local doctors. So then we started using telemedicine. And instead of going 1 day a month, we said, whenever the patient is there in the district hospital, or it may be in the Taluk hospital, please discuss with us. We will teach you how to train them, how to treat them. So in this process, after seeing 7 or 8 depression cases, they started treating by themselves. During this period, our Dr. Manjunath, one of my colleague, he was assistant professor, he was very new, he was innovative, and he started discussing about coming up with a schedule, basically to give it to the primary healthcare doctor, and we can train him over the telemedicine. so that the PHC doctors learn. In this process, we realized some couple of important things which has happened. One is when we do DMHP training, it is only for 5 days. It is a hit and run training program. You do training for 3 or 5 days and you vanish, or we vanish, and the PHC doctor doesn't know what to do. Because this is not, DMHP is not like a polio program or a malaria program or a tuberculosis program. They are all one disease, clear-cut diagnosis, clear-cut treatment, 1 or 2 treatment, or maybe 3 medicine treatment as for tuberculosis. But in DMHP, you have a basket of illness. All ICD, you have to train them. You have to tell them how to start medicine, how to continue medicine, how long to continue medicine. Unless we handhold them, none of the DMHP training program became successful. Here we started realizing, by providing telepsychiatric support, that is handholding of the PHC doctor for a period of 2 to 3 years, their practice started changing. Otherwise, you teach them acute psychosis now, by few days, they will forget. That was the model which was earlier, and it is backed by a science clearly saying forgetting curve. That was given by, again, Ebbingus. He clearly said in 1870s, telling that whenever a person learns, there is something forgetting occurs. How does the forgetting occurs? You people have visited many seminars. The day when you listen for 1 hour, you will remember 60% for 1 hour. Now you're listening to my lecture. After 1 hour, maximum you will remember is 60%. By the end of 1 day, 40%. By the end of 1 week, it will be 30%. By end of 1 month, it will be hardly 22%. That means the forgetting curve is very, very fast. It decays unless there is a either practicing, he starts using that knowledge, or he revises it. So in DMHP, nothing used to occur. In telemedicine, that changed. You see one depression case along with the doctor gives the prescription on that. On the other hand, by another 1 week, he sees a second depression, third depression case. By fourth case, he becomes well versed how to treat depression. That means you are doing adult learning process from pedagogy, where you do a classroom training, versus the andragogy, where you teach them by training. This methodology started working very well. And then the PHC doctor who were not interested, telling that, sir, koi bhi patients nahi aate who are psychiatrically ill in our PHC. They started telling, sir, I was missing around 30 to 40% of my patients who are having depression, substance use, somatization disorder, psychosis. So then they realized that we were making a blunder and it is going to help. So in this process of telepsychiatry over a period of time, that change in the pattern occurred and community psychiatry got integrated with telepsychiatry, that is telemedicine. So that, along with the COVID, which was not supposed to happen, which happened, gave a major thrust, if you ask me. It is the escape velocity. When the rocket escapes from the orbit of the Earth, basically from the Earth's gravitational field, it requires a boost. So COVID was a boost, and suddenly telepsychiatry took off. So now we continue training program even in COVID times, and we realized we can do teletraining. It's not Zoom meeting. Here we are talking about the doctor sitting on the other end, seeing patient. We are collaborating with him, and he sees his patient, gives the prescription, does the psychoeducation, and he sends. So in this process, he is learning, and we are empowering the doctor on the other side. So it is almost like a medical college training of a PG student, but in a virtual mode. So that made a major difference. And slowly over a period of time, we are realizing, even the Ministry of Health and Family Welfare realized, yes, we can monitor the national health programs, even DMHP. Now the programs are having virtual program. They will discuss with us. We have solutions, discussion. Every state we discuss about those things. And now the communication became very fast. So if you are going to see in another 4 or 5 years, this telemedicine, or we call it as virtual talk or virtual training, will give you a major impetus with regard to all national programs, not only district mental health program or national mental health program. And even the users also can give feedback. And a person who is sitting in Delhi can see any patient in Taluk and how the DMHP is working. So in this process, how the telepsychiatry has taken a major turn, it is not just only seeing telemedicine patient, it is training the doctor who is treating the patient, training the ASHA workers, training the nurse, all can be done not in a classroom setting. It can be done one-to-one training of the person. So in this process, we are able to bring a public health perspective in telepsychiatry. And in next 5 to 10 years, there will be major revolution with regard to this. So with this, I will now invite my next colleague to speak on how the training programs takes off. Thank you very much.
So I invite Dr. N. Manjunatha to give his lecture.
Thank you. Thank you very much. As Dr. Suresh already said, disclaimer, we have no conflict of interest in this seminar and it's not sponsored by any industry. Next comes, I'm talking about teleconsultations. And a teleconsultation is a simple meaning is a remote medical consultation between physician and patients, family, or between two physicians using technology platform. This is the simplest form of teleconsultations. And aim of my presentations are essential and non-essential component of teleconsultation, models of the teleconsultation which we have used at NIMAS in our own experiences, and simplest way to conduct teleconsultations. See, a lot of doctors are having their own doubts in their mind, how to do teleconsultation, what to do, what kind of thing. So there is a very simple way to do teleconsultation also without much headache. And let us understand what are the essential and non-essential component of the teleconsultation. Please remember the teleconsultation, the term it's been used, and especially technology people, when it comes and talk to you people, you feel some kind of threatening kind of feeling. Absolutely, you don't need. If you understand what are the essential, non-essential, how to manage kind of things. So essential thing is a mode of communications. So there are 2-3 mode communications we have. Text mode means messages. Audio mode, which we have been using mobile for a very long time. Landline we have used. That is another mode of communications. And these days is a video consultation video. And even this seminar has been video streamed. Same thing, this is the one mode of communication. So you choose which is the best mode on which you can give consultations. And among which video consultation the best in view of adequate inspection of the patient in physical examination. One of the notion doctor doesn't think that we cannot do physical examination in video consultation, but that is a wrong notion. You can do lot more things in inspection, visual, including tremor and all. Even my first video consultation, I could diagnose EPS patient, given a THP, followed up after 3 days and see what has happened. So there is what we have designed a concept called a WIPE. WIPE means virtual bracket for inspection, physical examinations. It's been published. And next coming to non-essential component, and that can be called as add-on component or value added. And I would think in more times it's an orthodox component of the telemedicines. Orthodox is really orthodox, and which comes with money. And which comes with you have to depend on many other people, technology-oriented people. So here, electronic medical records, which is a very popular non-essential component of the teleconsultation. And here, a lot of other issues comes, which I think we can discuss. And coming appointment pathway, online appointment taking, fixing, and those kind of things can be managed. And coming to third-party integration for prescription pathway, you write prescription, it may go to pharmacist can dispense all these things, complete pathway. As I said, it is an orthodox way of component of the telemedicine. Coming to investigation pathway, you order online consultation. That is, then it may go to respective lab, and report may go to patients and it may come to you. Also, there is a big pathway. So it is, as I said, it is a technological orthodox. And coming to imaging, you can ask for CT or MRI online, all these things goes to radiology department and the report comes back, can also happen. Payment gateway. You can pay online everything kind of thing. And another thing is it's not very popular, but it clinical decision support system, and it is one of the things. It has been integrated in a prescription module where You just put fluoxetine FLU, it comes so many brand name and dosage, all this kind of situation. And you can say that the patient is taking some other medication, say that the other medication, you see what are the drug interaction. So all these things are available at the point of contact, point of writing the prescription. So that CDSS is one of the popular thing. It's been used in many places. It may not be very popular in India, but outside is yes. Then coming artificial intelligence wise, language, multiple language can be titrated, especially for a public education purpose, and charts, all these things are available. So here crux is that what is the essential component of teleconsultation? It's only is component of the communications. You choose either text or audio or video. So if you know that is essential component, all other things are is not absolutely needed for doctors. And then coming to models of teleconsultations, please remember unidirectional and bidirectional teleconsultation. Unidirectional can be email. Patient send a query in an email and you can respond later sometime. It is only one directional in that way. Bidirectional is audio. You are talking on a live, both people can talk and video can happen. Then coming to synchronous and asynchronous, this what I am talking now, it is like going on a live stream. It is a synchronous, and asynchronous, maybe you record it and put it later. So that will become asynchronous. Third is very important for doctors, as it is standalone versus integrated teleconsultation. Standalone means is some component of teleconsultation you choose, which is as per your requirement. Other thing you don't need. And other things are in the market, there are available integrated teleconsultation modules are available, like Procto or some other thing. Everything is integrated there. But you can have only, I say that I will only use video consultation, other thing I don't want. So you can choose as a standalone teleconsultation model. Coming to next, whether it is a self-managed or aggregator managed teleconsultation. So whether you want to manage everything on using video consultation, or you want help from some other aggregator who are having full integrated packages which they charge you. And of course, when they charge you, you will charge to patients. And not only that, and there are so many other things in prop-ups. So whether you will prefer self-managed or aggregator managed, you need to decide. Then comes a 2-point or multi-point consultation. Here, why I added it here is, see, you can talk to patient. When patient comes, and generally in India, patient comes with family. But in teleconsultation, another beauty is that family can sit at workplace, patient can be in home, and you can have at the same time consultation. So that kind of flexibility is given. Next, third, sixth one is direct care, direct consultation. You are seeing patient directly, or you can see the patient through their family doctors or somebody with a collaborative care. And now you can use a supervisory care. Means I have MBBS students and he is sitting with the patient. You can supervise his work and you may train him, that kind of supervisory care. Then comes hub and spoke model of teleconsultation. Is more of technological word. It may not be relevant for doctors. And simplest way to conduct teleconsultation, I always say we should find out simplest way. We need not depend on anybody, especially solo practitioner in a small clinic he is running and he doesn't want to depend on other people. You should manage, it should be self-managed. Like you people these days talk to patient family member in video call. It is a self-managed. Same thing can be done in a consultation purpose. Standalone live video consultation is the best. It's like video call, you are calling family member, you just call up to patient and see them and finish the consultation. And maybe that can be used with our regular medical record, like paper and pen based medical record, which is called physical health record. And I'm also saying without any integration with non-essential component of the teleconsultation. You don't need EMR. You don't need prescription pathway. You don't need payment pathway. So here, why I said is that prescription means there are a lot of other issues props up. If you want to avoid, you just go with only standalone live video consultation, which can be managed by your own. Or maybe your assistant can manage, some reception can manage. Thank you very much. And I would request Dr. Naveen Kumar is professor of psychiatry, can just talk with additional with real data which we have worked and some component of training, teletraining component. Thank you.
Welcome, Dr. Naveen, sir.
Here it has come. Yeah. Yeah. So thank you for having us here. In this talk, I'm going to concentrate on the kind of initiatives that we have taken at NIMHANS in basically all three spheres, that is clinical services, teaching, and research. So this slide, it's already almost very old, and why telepsychiatry is required, the public health nature of the problems of psychiatry and the treatment gap, we all know. And of course, there is a huge disproportion of available services, inequitably distributed. So integration is the only way forward if we have to aim at reducing the gap. So that's the basic aim. So as Professor Suresh was mentioning, telemedicine started in 2000, telemedicine center started functioning in 2007. We started getting calls from the district hospitals, and NIMHANS was a nodal center for neuropsychiatric disorders. So actually the telepsychiatry doctor to doctor consultation, non-specialist to specialist consultation, we were offering services to many departments, including pathology, radiology, psychiatry, neurology, surgery. It went on increasing till 2014, and gradually it came down. In the simultaneously, a lot of innovations started occurring in telemedicine too. Coming to the clinical services, live online face-to-face consultations, known as the tele aftercare consultations, was one service that was started, which saw a huge jump during the COVID time. These are actually consultations for patients who have got admitted to NIMHANS hospital, and they go, especially those who come from outside the state. So we are happy to discuss these things. And during COVID, audio-based telephone calls, over 15,000 were done, and about 1,500 benefited with free drugs. Many patients across the states were served in collaboration with the district mental health program and their teams. Outreach clinical services like telepsychiatric extended evaluation clinics, that is another thing that we have started, wherein after the patients get screened, detailed evaluation is not possible on the same day. For a certain number of patients, we give appointments on a later date, and detailed evaluation is being conducted using teletechniques. During COVID, at the behest of the ministry, NIMHANS coordinated the National Psychosocial Helpline for psychosocial distress. And it is even now a 24/7 helpline. Around 600 frontline volunteers serving in the government sector, the psychiatrists, clinical psychologists, social workers, and nurses, and of course many residents and students across the country. They acted as frontline volunteers, and this was actually appreciated by one and all, including the government and even the judiciary. Actually, more than 5 lakh patients have been serviced during using this one. And telecounseling for the quarantine day travelers is another initiative that we took. Addressing mental health concerns of migrant workers, particularly during the first wave of COVID, that was a major problem, and NIMHANS actually played a part in lending its hand to alleviate that distress. So these things were about clinical service delivery. As regards capacity building, we have programs for various cadres of people, starting from the lay counselors to undergraduate, primary care undergraduate students, primary care doctors, and PGs and practicing psychiatrists as well. One initiative I'd like to mention here is the Indians Initiative in association with the South Zone of the IPS. It is an online teaching initiative comprising of weekly classes for DNB and MD students and private practitioners. This we ran for about 1 year, and it actually became a huge success, and now we are in the process of planning to expand this initiative further. And as I was telling about undergraduates, we also coordinate what is known as the National Medical Colleges Network. It's interlinking of various medical colleges, government colleges across the country, and psychiatry lectures for UGs and postgraduates sometimes is being coordinated from here. As Suresh sir was also talking about NIMHANS Digital Academy, This is an academy started at the behest of the ministry again in 2018. It has basically two arms: the virtual network, the virtual knowledge network arm, and the telemedicine arm. From the VKN arm, which is coordinated by our colleague Dr. Prabhat Chand, basically 4 diplomas are being issued, which is these are online diplomas, and they are blended in nature for non-specialist doctors, psychologists, social workers, and nurses. This is the picture of our spokes who are accredited with the diplomas from the VKN arm of the NDA. This is the number. I think this is about the data is about 6 months old, so these numbers may have very well maybe much more. Coming to a telemedicine center, the telemedicine center is coordinating specific demands from the state. I'd like to mention few initiatives like the primary care psychiatry program that has already been mentioned. Here, one diploma as well as one certificate course is being run by this, basically an online. It's an hybrid model wherein a component of both online as well as offline learning is occurring. A glimpse of what happens during one very crux of this training is the tele-on consultation training, wherein the doctor in the PHC sits and while the patient is being evaluated, is being monitored by the telepsychiatrist, as can be seen in the picture. So this has already got a mention from Suresh sir, and this is one pioneering model that we have piloted in Karnataka State, the Karnataka State Telementoring and Monitoring Program. A pilot was done in Mandya and it was extended to the entire state. Coming to the state of Uttarakhand, 2 batches of 25 doctors, they have been provided with diploma in primary care psychiatry over a period of 2 years, and they are all serving in the district hospitals, and they are actually doing the DMHP work. Just to mention an impact of training these doctors, they were able to identify approximately 11% of outpatients to have one or the other psychiatric problems. They actually identified them and treated, which is so an MOU with AIIMS Rishikesh also has been executed, and the 3rd batch of diplomas AIIMS Rishikesh now is spearheading. Coming to Bihar, we are working with the state of Bihar for the past 4 years. About 50 doctors have been trained in 1-year program, and they are spread across the state of Bihar and are catering to the DMHP work. This is just a score, a slide to show the pre and post increase in the knowledge, attitude and assessment practice score. And of course, you can see here the substantial increase in the number of patients accessing facility and using this facility after getting trained by these digital courses. So this is just a glimpse of the recent award ceremony that was held for a group of doctors as well as nurses graduated in 21. I think it was in March 2021. The same thing is happening with Chhattisgarh and another state with very less number of psychiatrists and other mental health professionals working in the government sector. So here also various levels of doctors have been are being helped and trained. Some of them are working at the district level, some of them are working at the PHC's level. Here also an impact slide to show the impact. From the past 2 years, we have this unique program called as the Chhattisgarh Community Mental Health Care Telementoring Program, wherein doctors from the PHCs, Chhattisgarh has about 1,500 PHCs, and all of the medical officers and assistant medical officers at the PHC are being trained to identify and treat problems with mental illnesses, that may present in the community. So the summary of the champ: more than 1,500 hours of training are delivered, and many patients from many the doctors have seen and catered to many patients after this program. And you can see this all kinds of problems are covered, including tobacco-related problems, depression, anxiety, somatization, mixed anxiety and depression, severe mental disorders, and even alcohol problems. Of course, we are there to help them out, whenever they require. This is a skill development program for other kind of mental health professionals who are running the DMHP services, including psychologists, nurses, and the PSWs using teletechnology. This is only for the DMHP of Karnataka. Then again, this also we are running online training of lay counselors, persons in the general community who want to do mental health work. And we are in touch with a couple of NGOs, interested volunteers. We screen them and we train them using digital methods in lay counseling. So 9 batches have been completed till now for the past 2 years. And of course, we are still in the process of evaluating what these people are doing. But they are all happy, and at least some of them are providing services in the community in their own way. During the COVID, you could see the number of sessions, mental health education sessions that were conducted. There was a phenomenal increase in that. And of course, multiple departments at the institute took part in these things. There are various departments related to psychiatry and allied sciences. Of course, this is a collaborative activity with both governmental as well as non-governmental agencies, without which it's not possible. Also has a role in policy making. This is the EMANAS, or the Karnataka Mental Health Care Management System, which NIMHANS spearheaded along with the IIITB and the government of Karnataka. This is to basically facilitate e-governance aspects, the implementation aspects of the Mental Health Care Act. And that is one initiative. And of course, the guidelines related to telepsychiatry practice of psychology, clinical psychology and social work, as well as yoga yoga practice guidelines. All these things were also NIMHANS contributed towards that. And of course, we believe the health and wellness centers are the future of public healthcare delivery system of India. And NIMHANS got itself involved with coming up with guidelines for the health and wellness centers, the various cadres of health and wellness centers. And of course, digital learning and training is an integral part of these things. So also NIMHANS is identified as the center of excellence for climate change and mental health. Of course, there are 17 centers of excellence under the national program on climate change and human health. And NIMHANS is one COE, and there are a lot of things that need to be done with regards to the mental health aspects of climate change. And of course, digital things will be part and parcel of this. I'll just, I'm coming to the end of my presentation with some pictures of some research that we have done. The evaluation of 2 different kinds of training. One is hybrid, another one is only online, offline component, and what is its impact, and what are the problems and challenges at the ground level, if we partake digital training, say, for example, the depth of penetration of the internet, the digital literacy of the grassroots level workers, these have been identified and we have talked about it. Impact evaluation, a couple of papers have come, particularly from the Uttarakhand data, now in the process of analyzing the Chhattisgarh data. Telemedicine services, of course, the aftercare clinic that I was talking about, tele-neuro-rehabilitation, tele-neurology, and this, the Bihar program I talked about, and as well as a summary of both the clinical services as well as the training that has occurred in the past 5 years. All these things have got a mention in journals, academic journals, and the role of ASHAs during the pandemic and the use of digital technology, in this kind of a work. So this is where I'm going to end by acknowledging the NIMHANS administration, our department, our colleagues, other departments, and the state governments, NGOs, corporates, and patients and families. Thank you.
Thank you, Dr. Naveen. Now I would like to invite Dr. Pankaj Kumar to give his lecture.
Yeah, I would also like to reiterate 2 points. One is, of course, this is not an industry-sponsored symposia. The other one is, I think many things are a mistake here. For example, Dr. Pankaj Kumar is not a psychiatrist in Delhi. He, sir, is an additional professor of psychiatry at the All India Institute of Medical Sciences, Patna, and he's the HOD of the department. In fact, this Pankaj is our own student. I think he's a practicing psychiatrist in Delhi. So, and our designations are also wrong. Dr. Manjunatha, he's additional professor now, and I am a professor of psychiatry. So I don't know how these mistakes crept in. So, but that is the side of it. Yes, sir, please.
Thank you, Dr. Naveen, sir, for clarifying the things we are discussing. Again, the same disclaimer, no need to repeat. And good afternoon. So most of the things which is the heart of this particular symposium has already been covered. I'll be talking about briefly the issues of opportunities and challenges, taking the platform of the works which has already been done in our country. NIMHANS has been the pioneer in this field, but I would like to highlight some works from the other also areas who has been done in this field and how we can take it further and what are the challenges. So yes, it's a very good opportune time to discuss about this particular topic because we all know we have come through a very, very extraordinary, abnormal experience of the COVID pandemic. And there are certain key learnings we have learned from this pandemic and which has very good implications, path-breaking implications, and unravel the potentials of this particular telemedicine that includes telepsychiatry. So the most important message was that the need and the requirement now has been felt by the people in the community as well as by the healthcare workers, health professionals. So the perceived need has been felt due to the experience of the COVID pandemic by everybody. And second important message, yes, we can reach the unreached. Even in the time where it is physically difficult, this teleconsultation or telepsychiatry can be a best method to reach the unreached. And also lots of the programs which NIMHANS team has mentioned and some other programs, they have established that all these programs are feasible to be done, established, and they are also effective in terms of various outcome evaluations also what has been presented. And all these programs have been found to be suitable in local context. Take the example of NIMHANS and certain other examples from other states. So all these, because these are the basic confusion or the limitation people used to think, which has now been proven wrong. So these are the path-breaking potential from which we can build upon the development of telepsychiatry. So as I said, I would like to talk about some other telepsychiatry model. Most important one, I remember a SCARF. SCARF has been an organization, NGO working in Chennai, and they have also started telepsychiatry practice in way back, I think before tsunami, under tsunami, they had done the immediate psychological first aid to the people through telepsychiatry consultation. And based on their experience and their effectiveness of that, they started this telepsychiatric services in the community of Puddu Kodai in 2004 only. And they have established the model that they have established a base in the periphery where that basic setup of teleconsultant can be done and a collaboration with the NGO who will be there at the base, will be running the base. And they will be people from that community. They will be conducting the awareness in that community also, as well as they'll be providing teleconsultation through the specialist, through the telepsychiatric methods. So, and after that, there will be free medication distribution to all those people. So one good collaborator, non-professional collaborator who is there in the community and well versed in the community, that can be used and that can be very cost effective to provide services to the masses in the periphery at the end. And it can go beyond service to the awareness raising, stigma, decreasing the stigma. So all components can be tackled by this particular model. So this has also found to be very effective. Another model based on the success of that, they started the mobile telepsychiatry clinic model. Mobile telepsychiatry is their bus. They have customized the bus and converted into a very good studio. Here you can see that there in the bus, there is a facility for teleconsultation, and these bus go to the various places. And there the teleconsultation is done, as well as the medications are distributed there, as well as various kind of awareness clips, videos, awareness films. All these things are displayed by a huge monitor on the bus in that particular community. And psychosocial aspects of intervention like awareness raising, psychoeducation of the people and their families, all these are conducted. So taking up further from the fixed teleconsultation model to the mobile-based model for the better penetration and better coverage of the population, reaching up to the end of the population where the normal services are difficult to reach. This is another PCI in Shakta Malhotra in 2014. They have prepared a package, software package. This package predominantly they had prepared for the purpose of developing a codified medical knowledge as well as clinical decision support system package, software package, in which they had all kind of, you can see the sections in that package. So anybody who is minimally trained, particularly the peripheral doctor, they can easily, with minimum training, use this package by entering the information under the various sections. It includes registration, complaints, screening questions are there section, then diagnostic tool that gives you the diagnosis also. And after that, clinical decision support system package, which takes you to the what kind of decision is required to be paid. And they can do prescription based on that health. So this was also good. And they have prepared adult version and child version. The sensitivity, specificity, and pilot testing was also done, and it was found to be very good, especially for child version. And it was quite acceptable. Adult version, there was a limitation with the sensitivity of the diagnosis of the various kind of category. But of course, this model also gave us, has worked at least, and can be developed in a bigger way at the various places, keeping in mind the local prevalent conditions, local needs. All these can be incorporated into such kind of software, and that can be used by the periphery non-mental health professionals. Of course, NIMHANS models already has been discussed as hub and spoke model. I will not go into the detail, but there is certain other Ginyari model. It is in Bilaspur district, Chhattisgarh. So Jan Sahyog Samiti, they are conducted in a Bilaspur in a remote village. So they have put a very periphery, they have a paramedical persons stationed in the periphery. And there is one, this computer programmer or data entry operator. And through that, those paramedical person is trained. So they collect the patients, and through teleconsultation, the people experts at the distance place, they are providing the teleconsultation to the patients, as well as medications are also being dispensed there. And at the same time, data entry operator is putting up all the documents simultaneously. They are called the program coordinator. So once you are talking to the patient on the screen, also you will get all the investigation reports, all the previous medical documents, that is also visible simultaneously. So you have very easily, you can get to know the detailed history, and the diagnosis validity is very, very high. So this is also working since 2004, and 6-7 years report was published, which was quite encouraging. Maharashtra, so it can be a rural model for telepsychiatry, reaching to the periphery without the help of without the use of mental health experts. Maharashtra telemedicine project, they are urban model where the PSC doctors, it's a asynchronous model, this Maharashtra model. PSC doctor takes all the reports, takes all the history part, record it, and it is sent to the expert at the distant place through email and through other. And that expert later on at some time at a fixed schedule will go through those things and they will provide their own feedback. And based on that, PSC doctor then dispense prescription to the patient and the medications are distributed. So that is another urban model Maharashtra has been doing, and it has also shown the encouraging results in the preliminary phases. Now it's more than 7-8 years they have been doing it. So these are the small other models also, apart from the NIMHANS model, which people are trying at different places to use. So these are the important to understand and to upscale it. E-Manas already has been talked in detail, so I'll not go to, because healthcare management system, which is a huge barrier in our country, more so barrier in a mental health field. So E-Manas is definitely the very good solution, and the Karnataka has done it very well. They are in the process of upgrading it. Suicide prevention, also digital module of suicide prevention. This is a comprehensive portal which creates awareness, prevention of suicide. There is promotion of well-being documents, and the modules are also there. They are doing the gatekeeper training program also through telemethods. So all these are the important other initiative in the different critical area of public health concern. So now I'm coming to the challenges. So challenges most of the time discussed many times. So it's almost the same. The most important what we talk about, the digital health literacy in our population, which is a major challenge. And but gradually, of course, this COVID time has made us a better. All the people have a better literacy in terms of digital use of digital technology in healthcare. Service provider skepticism has been a challenge. It is gradually decreasing over the time, and the more and more it will be used, particularly the concern related to the lack of that impact of the physical consultation vis-a-vis a teleconsultation. That is a major skepticism which clinicians do carry, but over the experience, and there are multiple studies who have done the controlled study, and they have shown for the common mental disorder, it is the effectiveness of the teleconsultation is equal to the in-person consultation. There are lots of literature and research work done. So those kind of skepticism is also decreasing now, and barriers to cultural competence is another issue, because in our country there is lots of cultural diversity even after the few distance. So large distance teleconsultation will have this kind of cultural barrier, because you require to have good acquaintance with the language of that people, language, cultural background, and social background. So cultural competence is also considered and perceived as a privacy and security of data is the major concern by all the stakeholders, including the patient or users as well as service provider, and their concern and apprehension related to that. All the acts and guidelines are now gradually improving upon all these areas. Our telehealth etiquettes and code of conduct. This is a process which people will learn gradually, because in telehealth, if someone is sitting at home sitting and you are from the space, so that the boundary of the therapeutic relationship and the boundary of the professional contact, that is sometimes a problem, which clinician need to handle and which clinician are ready to handle. So that is another. And most important thing is what to do in crisis. A person on teleconsultation goes into crisis situation, how to handle it. And the issue secondary to that is the liability, litigation, and malpractices. This is also another very apprehension and fear about, because of not having a very clear guideline or ambiguity, or still not having very much enough safeguards related to these aspects. Though after the guidelines government has this propagated, after that things are still better. But reimbursement and indemnity for the teleconsultation is still not here, which needs to be taken into consideration, and probably it is in the process, I think, and sometimes soon it will be done. Technology related barriers have mostly been removed now, because in India has also reached to the every corner of the country. So those barriers like lack of speed, lack of bandwidth, all these barriers which used to hamper the quality of the teleconsultation, that has now significantly getting decreased. A special population is a challenge so far as telepsychiatric consultation is concerned, particularly the geriatric population, because the person's level of cognitions, level of language, level of expression, and non-verbal communication, all these are a very important challenge for clinicians, for geriatric patient, as well as for children population, because assessment has to be multidimensional, and it's very difficult to do that. So child and geriatric population, and addiction, because addiction requires a lots of intensive assessment process and multiple kind of assessment process. So these are the three special population where teleconsultation is still having some issues, and it appears as a challenge. So generally clinicians tend to avoid consultation for a special population through teleconsultation. And we have talked about all these things, so no need to repeat. I'll just cut it short. So at the end, where the future of psychiatry goes, so far as telepsychiatry, so far as our country is concerned, most of the things our previous speakers have clearly elaborated. Things beyond that, I would like to include AI and machine learning, which Dr. Manjunath has also expressed. AI and machine-based learning solution will be a very, very path-breaking to develop personalized healthcare delivery system. And this is going to be the next future of the healthcare system, and telepsychiatry will have a significant role into that. App-based, developing apps to provide solutions, and the real-time solutions with real-time monitoring of the patients, with real-time consultation. There are many benefits out of this AI and machine learning based solution through technology. So that is, and second is wellness apps, like preventive and promotive mental health and wellness applications of technology to develop many kind of good customized wellness apps. I think Nimans is also working on one wellness Gurukul kind of apps, which will have lots of preventive and promotive type. And also based on the taking the model of e-manner, if we can create a national level registry of digital mental health care, it is going to change the landscape of the mental health, particularly the primary mental health care system of this country, because it will lead us to get the real-time periodic monitoring and changing epidemiological trends in the burden of the mental health distribution, and what are the area where the outcome is not happening. All this can be very easily monitored, and which will help us to keep changing, keep modifying, keep upscaling our primary care mental health care program. So these are the most basic important future of telepsychiatry, which I can see, apart from whatever work in the health and education, training and capacity building. All this has already been said by our previous speaker. So to conclude, I think telepsychiatry can be path-breaking to overcome the various inadequacy existing in the delivery of existing in the delivery of equitable mental health services, which is a very important need of this country. But we need to develop suitable and pragmatic policies, programs, rules, protocols, and regulations to develop the telepsychiatry in our country and to efficiently incorporate telepsychiatry in the existing landscape of mental health care in our country. Thank you. Thank you very much.
Thank you, Dr. Pankaj. We had a wonderful lecture on the most hot topic which is required these days. Thank you all speakers, Dr. Suresh, Dr. Banjanada, and Dr. Naveen, and Dr. Pankaj. So now like over to audience. Do you like any questions?
I have one question. Actually, in this COVID time, we had done a lot of telepsychiatry without having much knowledge. But one thing is that sitting in the OP from 9 to 2 and seeing a lot of patients is okay. But half an hour listening to the patient in the cell phone, I could feel the burnout. And it's very difficult to end the call with the patient. So how to overcome this? But it's easy in the OP, sitting in front of the patient is much easier, sir. The cell phone, it is very difficult.
No, in that case, if you want to enjoy the discussion with the patient, why don't you go to video consultation, then audio. Audio is really boring, yeah. It's like auditor hallucination kind of thing. So go to video, and at least you will see his face, and the live interaction will keep going, and human emotions you can see and feel it. But in audio, that you will not be there. So among three mode, I suggested video consultation is best for all history taking, even physical examination kind of thing. It is almost like a real life physical consultation kind of thing. It matches that way. So hope you are okay with it.
Okay, sir. Thank you, sir.
Sir, like can teleconsultation be given to those who are in other country? And one more doubt is we have a patient in India and later if they move to abroad, then how we are going to handle?
See, I don't know why this question again and again comes. Maybe because that can be teletechnology. We see our friends in video in US or UK. Why can't we give consultation? Say, please remember, every country it is like a to be honest, medical consultation is a revenue model for country. If you want to see the patient from UK or US other country, don't you think the country lose the money? Then why will they allow you? That is one way. And it's not just seeing the patient who is in other country. Consultation is not, it doesn't matter much. But the question comes in a prescription. So will your prescription will be honored by other country? If that is not an issue, then anybody can see. Only issue is not a teleconsultation. Question comes, your prescription is valid in that country or not? And please, my understanding is that, do you like if UK or US psychiatrists see our patient here? Do you like personally? We don't like, to be honest, right? So same thing happens to other countries. So we should respect each other country's integrity, and even law doesn't allow that way. Until and unless government of India have some kind of MOU with country only for this teleconsultation purpose or specific reason, that is okay. Otherwise, I think we should avoid telling that if you really want to help patients, one other thing is that once your patient moves to that, maybe 1 or 2 consultation with the patient, you should ask patient to arrange a local psychiatrist to just see the patient along with that psychiatrist for once or twice, then he hand it over to that person. That is the best way of professionalism, rather than you say that once my patient, lifelong my patient. That I think that attitude should go away. It's a time for that.
So therapies also shouldn't be done.
Yeah, you continue, you ask them to take over outside people. Okay, therapy is, there is no prescription much.
Yeah.
It is both of you, but legally, definitely, if something arises, then you have to face the brunt that way. In generally, it may not come any problem if you do therapy. But who knows, if patient file case or something like that, then we don't know what happens that day. Thank you.
Thank you, sir.
Anything else?
I would like to ask the chairperson to felicitate our speakers. Dr. Suresh Padamat. Dr. N. Manju. Dr. N. Manjunatha. Dr. Dr. Naveen Kumar. Dr. Pankaj Kumar. I would like to ask the speaker to felicitate the chairperson. Dr. Vijesh. And Dr. Manasa. So I'd like to invite Dr. Arvinda to chair our next session. Yeah.
So for the next session, we have two speakers, Dr. Professor Roshan R. Jain and Dr. Professor Vinod Kumar. So I think may I invite Dr. Roshan to come and speak the first topic. This is the symposium on SNRIs as add-on to existing antidepressant therapy. What's the right choice? Yeah. Dr. Vinod, please come.
Thank you for attending the seminar, and thank you. First of all, as a quick disclaimer that this is an industry sponsored by Pfizer. We'd like to thank Madhusudan and the team to invite and organize this simple talk. And it really talks about antidepressant therapy in the treatment of one of the most commonest problem during the difficult times that we had in the last 2 years. Pandemic has created a new opportunity for mental health services across the world, especially in India, where we've seen that the mental health crisis is far, far bigger than the overall healthcare crisis. And it has done, of all the damages done to our people, our health, and unfortunate loss of life, I think it's done enormous destigmatizing work for mental health services across India and across the world. People are now no longer anxious or scared of talking about mental health issues. They're opening up, they're speaking up. Many are coming forward to seek help, and many are ready to take treatment to get well much quicker. So what we're going to do is that this talk is now divided in two parts. I'm going to set the ground and do the first half, and hopefully the same talk will be continued by Dr. Kumar to finish off about the various antidepressant therapy. Now, me and Vinod have had distinct advantages of working in two countries over the last 25 years, most of which has been in UK for nearly 15 years. And now for the last 10 years, we're practicing in Bangalore, and we work in the private sector. So some of you have, I think, heard the earlier talk from the NIMANS colleagues who are doing commendable work on telepsychiatry and telemental health. And I think they have taken the opportunity to engage all those who would not come forward to seek help, to engage them to telepsychiatry module. So this is a disclaimer which I mentioned earlier. Is it not coming? Yeah. Right. So as we all know, the depression is one of the third commonest disease worldwide in terms of global burden of diseases, and it is rapidly rising. Just last year, it has risen to number 2, and in 2030, I think it's going to rise to number 1 as per the WHO and other data that has been provided. So it's going to be a huge burden across the world, not just in terms of quality of life, but also in terms of productivity, in terms of morbidity and mortality. So any amount of lectures and seminars on depression and the treatment is going to be insufficient, and it is already overtaking other common health problems. As you see, unipolar depression is going to, by 2030, be above ischemic heart disease. And one would wonder whether ischemic heart disease is going to overtake us, but I suspect not. And the prevalence of depression is generally about 15% after adjusting for age. Many studies have suggested that it's much higher in the Indian context. Some studies have reported that it's as much as 30% in overall mental health problems, much higher than any other developing or developed nations. WHO data has suggested this leading cause of disability, depression, is 50% higher for females. Many mental health problems are higher in females, whereas behavioral problems and other are higher in males. 63% experience severe quality life impairment, and which has significant negative impact on social functioning, psychosocial disability, and increased severity of symptoms. We know that between 2 to 9% of people commit suicide, those who have depression, especially those who are untreated and unrecognized. And the risk of suicide can be as much as 25%, 25 times greater in general population. So those who are perhaps suffering from problems and not been identified. So a significant increase. COVID-19, as I mentioned earlier, has led to a significant increase, and those percentages are 31% of adults surviving COVID-19. So those who had COVID-19, there's a 30% chances of developing new episodes of anxiety and depression, which is quite high. And this is not accounting into those who already have mental health issues, so not accounting for those just relapsing with existing mental health problems. British Lung Foundation has surveyed over 1,000 patients and found anxiety depression is the top 5 reported symptoms in long COVID, which is patients reporting ongoing symptoms of COVID, includes tiredness, exhaustion, pain, and so on, and anxiety, depression, insomnia. So quite high. Look at prevalence studies in India. You've seen 25% participants were moderate to severely anxious. Now, these are very specific studies reported 25%. There have been studies reported in US where they said that nearly 1 in 2 are reporting anxiety and depression. So that might be even more higher than that. Healthcare professionals were thought to be immune and expected to be immune to health issues, including mental health problems. And that is never been the case. We are more susceptible. In fact, we were more exposed to the perils of COVID virus, and consequently, a higher number of healthcare professionals, doctors, nurses, and frontline workers have suffered from all kind of mental health issues, especially those in front line with emergency department, pulmonology, ICU, and so on. So healthcare professionals in India, the depressive symptoms requiring further evaluation is rated at 11.4%. So etiology of major depressive disorder is quite complex, and there's quite a complex interaction between the genes, the environment, the psychosocial factors and stresses, and the neurotransmitters. The several neurotransmitters are involved in regulating mood. Therefore, antidepressants are designed to target different neurotransmitters, because different parts of the presentations, the behavior and mood symptoms are led by different neurotransmitters. For example, norepinephrine is looking at a loss of interest and enthusiasm and motivation, whereas serotonin causes a lot of impulse control problems and aggressive issues and so on. And dopamine leads to drive and pleasure issues. So different neurotransmitters regulating different aspects of depression itself. If you look at the categorical approach to depression, which is how we address a diagnosis, we simply look at two or three principal features for depression. One is depressed mood, which is continuous and consistent, with loss of appetite and loss of energy and apathy. Now, when we look at the response to treatment, these are the first things we look at. Not just improvement in mood, we look at return of interest in daily activities that were previously pleasurable. So when people are beginning to get a pleasure out of what they previously did, then we think that the depressive symptoms are better. Now, they are regulated by different neurotransmitters. So norepinephrine particularly leads to these symptoms like loss of appetite and apathy, whereas other neurotransmitters like weight loss and apathy, appetite changes is led by 5-HT and norepinephrine, and so on. Fatigue particularly is led by the changes in or inadequate availability of norepinephrine, and so on. If you look at the evolution of pharmacotherapies, as many of you know already, that from the 60s, we've been looking at broad spectrum antidepressants like tricyclic antidepressants, clomipramine, nortriptyline, amitriptyline, which is very extensively used even by our medical colleagues, especially in elderly at very low doses. But these are the most commonly studied antidepressants. And as we moved from 60s to 70s and 80s, we moved on to SSRIs, which is still in treatment and practice guidelines, especially in the US and UK. SSRIs are the first line antidepressants, but increasingly SNRI are becoming also first line, where certain category of patients require addressing more of those loss of appetite, loss of apathy, loss of interest, lethargy, and somatic symptoms. And it is also increasingly recognized that the SNRI-based medicines are an effective add-on to an SSRI. And although we know that in Indian context, many of them are using a combination of two SSRIs, which is completely advised against in terms because of serotonin syndrome. Many occasions we are ending up changing the two SSRIs to SNRI and SSRI. And as we move from 90s to 2000, we moved on to other more effective drugs like mirtazapine, venlafaxine, and so on. Venlafaxine is one of the antidepressants which is now very widely prescribed, despite the well-known side effect of having high blood pressure and the need to monitor blood pressure at least weekly or monthly. And in UK, I think when we prescribe venlafaxine, we are advising patients to have their blood pressure checked regularly. Other newer SNRIs which came in 2010s onwards, like duloxetine and desvenlafaxine, don't require these sort of monitoring. Particularly desvenlafaxine is now more commonly used in India, although it's not licensed in the UK still, but it doesn't have the side effect of hypertension, for example, and it is quite effective in those with more somatic symptoms, which is one of the ways of expression of depression, or one of the reasons for consultation in India, where people have more somatic expression of their problems, and this is how they come forward. Or in fact, many of them are referred to psychiatrists because of the wide varying somatic symptoms that patients present with. So, and most recently, we are looking at now emergence of other antidepressants like vilazodone, levomilnacipran, although I'm not using that very much, but vortioxetine is a promising drug in terms of minimal side effects that SSRIs have promoted and having no drowsiness. So CANMET guidelines have very clearly from 2016 have supported the use of SSRIs and SNRI as a first line in terms of doses, and mirtazapine paroxetine and the existing SSRIs. The treatment goals of depression has also changed over the time. Typically, we used to look at a resolution of symptoms, and we understand that depression is a relapsing and remitting condition. And we look at the person experiencing an episode of depression followed by response to medicine, then having another relapse, and then looking at remission where there is no symptoms, and then they experience another relapse and recovery. So being a relapsing and remitting medicine, we need a continuation of antidepressant for prolonged period to help people into a full stage of recovery and to prevent or reduce the chances of recurrence. Just going back, so treatment is usually typically done in these fashion. You look at the acute stage, the continuation stage, and the maintenance stage. So in many cases, we are looking at a long-term treatment with antidepressants where there has been more than one relapses or recurrences. But typically, most people require 4 to 6 months of treatment, even if it's the first episode of depression. With terms of evolution of treatment goals for patients with major depressive disorder, as I mentioned earlier, from the 70s and 80s, we were looking mainly at symptom reduction and reducing suffering. But over time in 90s, we started to look at that response has to be has to be beyond symptom recovery and to have an effective remission to the point of normalizations in 2000, where not just that they have to respond to medicines, but to return to a reasonable level of functioning, or what we call as normalization. And the concepts evolved from that to make it to a functional remission, which simply means that there is not just a remission of symptoms and recovery, but a full return to previous level of functioning. In the early 2010s onwards, we are now looking at quality of life, because we know that it has a significant impact on individual functioning. But now we're looking at more at cognitive remission to have a significant positive impact on the cognitive and executive aspects of depression, which has been now the principal focus of all antidepressant therapies. So there's a need for early optimized treatment. Evidence suggests that the delay in treatment of major depressive disorder, especially long duration of episode and long duration of untreated illness, is associated with very poor outcome, longer time for remission, prolonged suffering, and associated poorer functional outcomes. So the functional outcome is not just going to be delayed, but their functional recovery is going to be impaired. So by utilizing the individual measurement-based care, early improvements or lack of improvement can be used to assess the effectiveness of treatment to make decisions for dose alterations, for switching antidepressants, and for adding adjunct therapies. So early optimized treatment for MDD may improve outcomes for individual patients and increase the number of patients who are able to return to full functioning. The need for functional recovery is MDD is associated with major physical, social, cognitive, and functional impairment, both at workplace, in their home environment, and reduction of productivity at work. So functional recovery has to be a key goal for major depression, and it's important when you're considering remission. So a variety of scales are available to assess the functional outcomes, and not just in the research setting, but also in the clinical settings, to look at not just how much people are better, but mathematically quantify how much they have returned to the previous level of functioning. Now there's a growing evidence that various antidepressants can improve functional outcomes, and which my colleague is going to talk about later on in terms of the SSRI and SNRI modules. So assessing treatment and treating patients for early functional recovery may contribute to optimized outcome for patient, which is what they come forward for. So this is a simple graph which looks at the importance of early optimized treatment, and the foundations of treatment has to be tolerability, whether the medicine is tolerable, whether they are going to adhere, because we know that over 75% of people are non-compliant with not just psychiatric medicine, but any medicines. And also we need to look at the efficacy, and efficacy also depends on the tolerability and the side effects and how adherent they are. So if people are adherent, then the medicine is going to be more efficacious. So functional recovery, the ultimate goal of the therapy, as CANMET said, that the aim of an acute treatment is to eliminate symptoms and restore psychosocial functioning. And the aim of maintenance treatment is to ensure a return of baseline function and quality of life and to prevent symptom recurrence. API, well, quite simply and as defined it as intervention, should be aimed at maximizing patient level of functioning. So it's not necessarily previous level of functioning, but maximizing patient level of functioning in those with severe illnesses and severe episodes of depression. So functional recovery simply is restoration of social, work, family functioning, and improving quality of life. So the extent of functional impairment of major depressive disorder is simply presented in the graph here. And patients with depression have higher rate of impairment, as you see in the yellow part, as compared to those with no depression. The key factor identified in outpatients with depression is very important in determining remission from depression. So we're not going to go through the slide completely. So tools for assessing functional outcome, as I mentioned, for normalization of functioning requires consideration of cognition and memory and motivation and energy. So it's not just about feeling better, but also being able to be attentive and to have improved memory and ability to retain information, and which can be a big factor, especially in the Indian context, because we are, I think, quite memory obsessed country, and many of the consultations are also driven not just by somatic symptoms, but also by an inability to attend to things and to remember things and being forgetful. So we need to be attending those symptoms in a more effective manner, much more than getting them feel better. So validated scales for assessing functional outcomes are, the medical outcome study. So NDCOT, work productivity scale, so work and social adjustment scale, and so on. So although I must be honest that we don't use this on a regular basis in clinical settings, but they are used more in terms of assessing the efficacy of the medicines and assessing the efficacy of a treatment intervention. So targeting more than one mechanism to achieve, so to reduce, to achieve a better response, so to reduce positive effect and to increase the negative effects on the mood, it depends on which neurotransmitters are targeted in a more effective manner. So on a road to recovery, we look at, first we look at the response to medicines, and then we look at remission, and then we have sustained remission, which is very important to get people well, but also to help them to stay well. And then we look at the full functionality of functional recovery for people to return to or to maximize their functioning to the previous levels. Thank you so much. And Dr. Kumar will continue with the rest of the talk, and I think we'll take any questions at the end of that. Thank you.
Hi, afternoon all. So I'll just let everybody take a breather for a few minutes. It's nice to see such a large audience. Thank you all for coming. It's like the fag end of the day today, and then I think everybody's heading back home, right? After a bit. I'll keep it very short and brief. It's none of what I'm going to say is rocket science, but it's just emphasizing some points and probably add some of my clinical experience and anecdotes over the last 10 years in the Indian context. Shall I start off, guys? You're all set? So, I mean, I'm just going to talk about the simple kind of way of making a case for, the steps kind of module, if you like, or it was proposed a long time ago by Prescon. It kind of makes a lot of clinical sense to me. So when we're choosing a molecule for a very common and disabling kind of issue, we need to look at the steps kind of profile of a molecule. So as clinicians, we all tend to have our favorites, and we kind of go with what we see. I'm just going to make a case for desvenlafaxine as being a very good alternative. So thinking about the steps kind of mnemonic, first thing, I think as doctors, we have this sort of notion, at least I have this at the top of my head, that I'll do no harm. I want to help, but I'll do no harm. So safety is very important, always, obviously. So considering safety, one of the key kind of factors to consider are the kind of interaction potential because of the metabolic pathway. So 25% of all medications prescribed worldwide are metabolized by the CYP2D6 pathway. And co-administration can lead to drug-drug interactions, can lead to increased side effects or, decreased effectiveness, of course, depending on the situation. Now, this is the difference essentially between venlafaxine and desvenlafaxine. I think it's one of the big issues which kind of sets it apart. And some of my UK colleagues here, would know that venlafaxine is the kind of go-to drug in the end, and we all push it to 300 milligrams and so on. But it comes with its own problems in terms of side effects and interaction difficulties, right? So with desvenlafaxine, you see none of that. And we can very happily choose it as a kind of go-to drug, even when there are like a lot of different kind of medical issues, older age clients, even I'm very happy to prescribe because of this point, really. So essentially, the only antidepressant which is not metabolized and not inhibitory to the CYP2D6 pathway. Now thinking about the tolerability of the medication. So, I mean, we all know that, it's very important, particularly people like us in private practice, we don't want to give unacceptable side effects to our clients, because they're gonna not come back or go to your kind of colleagues and so on, and you don't want to, cause unnecessary side effects anyway. So, this is one of the commonest reasons for discontinuation of antidepressant. It's a struggle, we all have in terms of adherence. So people don't like the side effects. They don't, they started feeling better, they stop it and stuff like that. So if you think about the discontinuation rates, I think they're very, very similar to placebo when it comes to desvenlafaxine. So, that's kind of heartening to know. I think relatively better than other molecules, which we all tend to use very commonly clinically. So what are the commonly experienced adverse symptoms which we kind of encounter in our clinical work? So obviously nausea, dizziness, the hyperhidrosis. So I think I particularly warn my clients about nausea upon initiation and hyperhidrosis a lot in our kind of hot temperate country. But then I think that's very useful, because when you tell them that this might happen, and this will happen in up to 10% of the people, not necessarily, but if it happens, don't get alarmed, and I'm there. And if you persist, it'll settle down and so on. So that kind of takes care of the common sort of adverse reactions upon initiation. And it's like I said, it's very mild to moderate nausea, and it typically decreases in less than a week, honestly. Okay, so thinking about the efficacy. So is anybody here not convinced that, I think I through my training and through my experience, so always had this notion that venlafaxine at a very good dose is the gold standard of all the antidepressants we have. And sometimes, you see the data that if a molecule is even like 50% as good, is getting USFDA approval and other approvals and so on. So in my mind as a clinician, I always had this notion, and I think that still holds good. But what is beautiful about desvenlafaxine is that it takes away the kind of bits which were unhelpful with venlafaxine. So yeah, so that's where it kind of, and the efficacy of venlafaxine, desvenlafaxine is proven beyond a doubt. In many studies over the years and clinically, it's pretty apparent that it's a very effective antidepressant that we have. So this is a crucial difference, if you ask me. And this has been a big kind of, one of those clinical failures of a molecule. So if you see an average script with venlafaxine, you would see that people are prescribing 75, sometimes 150, because of the kind of side effect worries and so on, and titration problems. So, venlafaxine, it actually only becomes an SNRI when you cross 150 and go to 225, right? So with desvenlafaxine, that's the amazing kind of practical advantage. That at 50, it's effectively an SNRI at 50 mg, and I think 80% of the people just need that. No titration required. Simplicity of prescription, is brilliant. I mean, that's been my experience clinically as well. Yeah. So yeah, in terms of, I think we made these points. So it's pretty good. The main thing is, obviously the difference in the metabolism thing, which really sets it apart. Remission rates are, if you look at the meta-analysis here, they are better with SNRIs. So it's 5.7% higher. If you look at all these studies, the weighted average of it. And so if you use it as a kind of maintenance medication, it decreases the probability of relapse by more than 50%, compared to placebo. Like the same point that remissions is way better and equivalent to a good dose of venlafaxine. And more of the same. So I've already kind of made the point of simplicity. Like I said earlier, that's it. 50, start maintenance, no messing about. And I think 9 out of 10 clients of mine over the years, I kind of hit the bullseye when you go for this, rather than anything else. So it has been my practice for a while now, at least in the last decade. It's very helpful. So again, to summarize, the steps kind of making a case for using more of desvenlafaxine in, at least in MDD, it is safe. It's very well tolerated. I think apart from nausea and hyperhidrosis, which is not uncommon, compared to other molecules, it is efficacious. We know that, and it has also been sort of recommended as first line for MDD in CANMET and other guidelines. So the cost factor is a no-brainer in India, because it's on par with most of the other antidepressants. In fact, similar, to be honest. And the simplicity case I just made. So I think that's all I had to say. Unless people have any questions for Roshan or me or Sadeep.
Thank you, Dr. Vinod. It's a wonderful presentation. So any question from the audience? Just one question from my side, Dr. Vinod. Now in Indian market, some companies are coming up with 25 milligram of doses of desvenlafaxine.
Yeah.
Do you think it is at all required?
I think it's a useful thing. I think my experience, like Roshan said earlier, 15 years we were in UK, and then in the last decade we've been here, and the kind of transcontinental experience is as a general rule, are genetically or whatever, I don't know, our people just need lower doses of medications. So for instance, people in the UK, we didn't even know that mirtazapine was available at 7.5. It's a kind of Indian thing, and we know that as we go east, the kind of sensitivity to psychotropics, it kind of decreases or increases, if you like. So in that context, I think it's a useful strategy, because sometimes 50 is a bit too much. People find the kind of, I don't know, the increase of anxiety or the nausea too much. And they'll be like, doc, no, I can't take this one, right? So, and I kind of, by intuition now know, like when you see hundreds of clients, and this one's gonna have a problem because she's not gonna tolerate the nausea or whatever else that comes in the initial phase, the first week. So, using 25 to ease them into the molecule and then going up to 50, it works like magic. Effectively negates the kind of discontinuation phenomenon if there is any, So I think in that context, it's very useful.
I think, as Vinod said, the intolerance to medicine or medicine doses is one of the welcome intolerance in India. And in UK, people are taking more and more antidepressants. Venlafaxine is commonly used at 300 and 375 milligram in community. Mirtazapine, for example,
almost every patient that I practice in UK, even now I do, they take 45 milligrams. Most take 30 and other take 45 milligrams. In India, we are giving starting dose of very rarely 15, often 7.5. And elderly, we are using half of 7.5. So the request for lower doses of medicine is ever rising, which is good in a way, because the symptom remission are achieved at a lower dose for constitution, for genetic factors, for various reasons. And we need to look into that. So that's an interesting aspect, but reduction of doses of desvenlafaxine or any other medicine available in smaller doses is probably useful in discontinuation of medicine. So instead of people taking on alternate days, they take half the starting dose and then ease off. So people withdrawal symptoms with antidepressant is a big problem with people, which also drives, well, a single patient will drive away many other patients who would require medicines but won't take it because they say that I had terrible time, never ever go on medicines.
Yeah, no, I totally agree. I think so. Both initiation and sort of discontinuation clinically planned. Kind of, you've been well now for a couple of years, so we can look at stopping it. So I think going down to 25 for a couple of weeks and then knocking it off makes it much easier. So in that regard, it's very helpful.
What's your experience about taking care of this anhedonia part of depression in few patients?
Anhedonia part. Okay. So I think, see, I always felt that compared to SNRIs, I think more so duloxetine rather than desvenlafaxine had this activating effect. In fact, almost like a stimulant kind of an effect. With duloxetine, one of my problems was that a lot of people would struggle with sleep at night. Strangely, so they would just not feel the need for sleep, so much. So it's kind of activating, and we all know that if somebody's got a very strong family history of bipolarity or a kind of vulnerability to that, then stronger antidepressants can switch them as well. So I think we need to be careful on that front for sure. I've had a couple of experiences of that nature. I think a very thorough, detailed family history and a very long and detailed kind of mood history is very important as well at times, So it's got that activating effect, and anhedonia usually doesn't seem to be a problem once the kind of response and remission comes in.
If the
yeah, there's somebody in the audience.
Please introduce yourself.
Yeah, so it's very interesting you asked that. So I was in UK when duloxetine, it was kind of the brand name there was Cymbalta, right? And it was launched with the big fanfare and all the rest of it. And the entire kind of marketing pitch, if you like, that it is more useful in somatic kind of symptoms and all the rest of it, And I had this very basic kind of psychopharmacological question, like what's the bloody difference? I mean, it's it's an SNRI like venlafaxine. Why would it be more helpful in somatic symptoms? But somehow that marketing pitch is obviously had its impact across the world. I mean, neurologists, physicians, orthopedicians, everybody's going for duloxetine like is like pregabalin, and they give very low doses, like obviously 20 in most parts of India now. You get 20, 30 easily. Nobody stocks 60 because nobody write or prescribe 60, and that's the starting and maintenance therapeutic dose of the duloxetine. So if you're asking me personally, I don't think there's any difference. Honestly, so because a lot of these somatic symptoms, unless they have organic basis, they're kind of linked to your mood state, right? So once you treat the kind of depressive background, whether it's with desvenlafaxine or duloxetine, then the experience of the somatic symptoms is going to improve anyway. So chronic pain, chronic low back pain. So neurologists and, like I said, even physiotherapists are prescribing, so they've got this notion that, we'll give pregabalin, we'll give duloxetine, and they'll feel better. Of course, they'll feel better, because it's a kind of complex relationship, right, between chronic pain and depression and so on. So that's my kind of take on it.
Thank you, sir. So another thing, what is your view about that combination of desvenlafaxine with clonazepam and only desvenlafaxine?
See, okay. Thank you so much. Sorry, what's your name again?
Dr. Sujata.
Dr. Sujata, I mean, I take any opportunity to make this point. You know, I am like a total anti-benzodiazepines in India kind of guy. I'll tell you why. Because the problem is we have no control over the kind of sale of benzodiazepines and procurement of it. So, you know, my famous not famous favorite quote is that, you know, do not expose a neurotic Indian to benzodiazepines. It's asking for trouble. You know, it's like, you know, alcohol in a pill. Who wouldn't like it? You know, and it's accessible. See, if you're in a kind of country like UK or US, so say if I write, I don't know, 10 tablets of clonazepam, you know, for 10 days only to the prime minister, the chances are he can't get more without a valid prescription. Here, I mean, you know, and I know that you can just go to the friendly neighborhood pharmacist and he give you a box load for his sale for the day, right? It's a nightmare situation, if you ask me. So I think it's best avoided. And if you have to use it, then use it. I don't know, for 5 days, you know. Obviously, so we all have a tendency to kind of cover the initial exacerbation of anxiety symptoms with benzodiazepines. Not really always required, honestly speaking, you know, but do it if you've got a sensible patient in front of you and you kind of warn them against the kind of nature of dependency and tolerance and so on, you know, then do it short term, 5 days, if that.
Thank you, sir.
Yes, sir.
I'll just add something to what you asked. I think just to answer your questions, I think one of the things that doesn't happen in UK, which happens in India often, and government banned about 300 some plus drugs, where there are multiple drugs in a tablet. And using antidepressants and benzodiazepines in one tablet is something that I don't practice at all, because we can't control effect of each of the drug. Two, the discontinuation becomes a challenge. And three, most of the patients that we see in India are not informed about what the content of each of the tablets, medicines, each of the tablets, and which of them is addictive. So if you were to give combination, then give separate tablets, not together, and clearly advise and inform that the second one is addictive. Because the benzodiazepine abuse is huge in India.
It's
For many reasons we not say.
mind-boggling, yeah. So,
And the patient attrition rates are very high. So people get, they come very late for consultations. They're quite unwell, and you see a 20% shift in their symptoms. They disappear, and they come back a year later and say that I've been taking the benzodiazepines that you gave me throughout the year, and every tablet I skip, I feel very, very unwell. And consequently, that reinforces the illness model in patients to say that, you know, this depression is not going to go away and I'm not being treated properly, and they consequently take more and more medicines. Avoid benzos if possible. Give them separate tablets. Discontinue as soon as possible, because
no, but
the
Roshan,
vulnerability to abuse is huge.
Roshan, so just to add to what you were saying, I would go to the next level as well. Honestly, one of the common myths and misconceptions in the Indian population about psychiatrists and psychiatric medication is that इनके पास मत जाओ, नींद की दवाई दे देंगे, है ना? So, you know, that notion, which is a common kind of folklore, you know how big a tragedy that is. So if you look at the suicide rates in this country, you know, the preventable kind of, you know, depressive we can help. But a common man has this notion that you go see a psychiatrist and you put you on addictive sleeping tablets, and that's what happens in reality, right? And then what? I mean, you know, then half of the people who actually need to see us and take the right treatment, they don't come. It's crazy stuff. I mean, you know, a few lakh people extra are dying every year for no reason. But this sort of myths that are around, and because of lack of kind of awareness, and see, so doctors are very busy, right? So if you're working in a medical college, OPD, or, you know, in a big institution, you're seeing like 50, 100 patients in a day. I mean, how much are you going to explain, right? It's all about your prescription. I feel really passionate about this whole benzo situation in our country, you know, and I take no opportunity, you know, whenever I'm given to not to talk about it. I think we need to be very mindful. Just because we have no control over its continued sale, you write it for 5 days, but they'll just keep getting it, you know, it's a problem. Sorry, sir.
Mine is a very, very simple, basic question. When I was looking at the presentation, I just was a little skeptical about not including escitalopram, because now we talk about citalopram, but it's an old generation.
Yeah.
And escitalopram, do we actually need that much of adrenergic effect in when we are talking per se about depression? because what I have studied is more of serotonergic
Yeah,
action,
yeah,
robust or serotonergic action than
Yeah.
adrenergic action, until unless we are looking at some somatic symptoms or bodily symptoms, right? So do we have an head-on comparison with that? And
I
what's your
think-
take on?
I think there are studies there, but I'm not specifically aware of the two, right? So in theory anyway, so the slides which Roshan put in initially, Roshan, about the kind of different neurotransmitters for different symptoms, it kind of, I mean, that's very basic medical student kind of level of knowledge there. So I think targeting norepinephrine reuptake is useful for sure. So your question is that SSRIs are enough, you're saying? Yeah. Yeah.
And our population responds to a lower dose, as you said. So mostly it doesn't kick off to that level before it starts acting, and mostly people are treating with an SNRI as an SSRI.
No,
When we talk about
agreed.
venlafaxine.
So again,
so what my question was only that we have a head-on with escitalopram, because we know that it's a fast onset of action.
I'll have to look it up. I'm not aware of it myself. But yeah, if I do find, then I'll share it with you.
Right.
And if anybody else is aware, then, but I think, is there anything you're aware of?
I think theoretically, I think there are many studies looked at the comparison. Most of the studies would look at the broad spectrum antidepressants like amitriptyline and so on, which are also quite efficacious in somatic symptoms. And as you asked earlier, the somatic profile of patients presenting with depression is quite high in India, and the functional somatic symptoms, especially during the waking state. So the symptom resolutions of the somatic pains has to be quite effective in Indian context, and there has to be also a non-sedating element to it, because if the moment patients are sedated, then they're not going to take the medicine. And just putting points together, what Vinod was saying earlier is that the duloxetine and desvenlafaxine, so they have better profile in terms of treating somatic symptoms or somatizing depression compared to other antidepressants, and lesser sexual side effects. So in the Indian context, I think it works out quite well. And as Vinod said, that desvenlafaxine is an SNRI at a low dose, so maximum for that would be 200, but 50 is sufficient in most patients. So at low dose, it's an effective SNRI compared to venlafaxine, and most of them would not go to 225, at least in the Indian context. So many are only taking 75. So if you're prescribing that, then you're just using an SSRI. So you could might as well use something else. I hope that answers the question.
Thank you, both the speakers, Dr. Roshan and Dr. Vinod. It's a wonderful interaction. So now may close the session. Over to the organizers.
I would like to ask the chairperson to felicitate our speakers, Dr. Vinod. And Dr. Roshan. Just if you both can felicitate the chair.
From South Rajasthan.
So we'll start with the session. So for our chairperson, we have Dr. Darpan and Dr. Roshan chairing the session for today. Dr. Roshan, Dr. Roshan and Darpan, you both can invite the speakers.
Right. Thank you for attending the very interesting seminar on the last day of I think one of the last presentations. And I think it's very important and very interesting topic, especially in a worldwide plus Indian context. Non-suicidal self-injury and suicidal behavior. Brief intervention module for suicide prevention. So we're going to have a series of talk by very eminent psychiatrists from India, many from Rajasthan, are going to talk about various aspects like epidemiology of suicidal behavior and suicide, risk factors for suicide and non-suicidal self-injury, and so on. And I'm sure they'll be able to clarify the terminology of this non-suicidal behavior in the English or Western concept. They call it deliberate self-harm, where there is no notion added to say why the person has engaged in any form of self-harm without any context. So that has always been a confusing aspect worldwide, to say which is suicidal behavior, which is a non-suicidal behavior. And we're going to get some clarification on these very aspects by the eminent psychiatrists. My esteemed colleague, Dr. Darpan Kaur, is going to introduce our first speaker and give the background. Thank you.
Thank you so much, Dr. Roshan Jain. And it's my privilege to co-chair the session with Dr. Jain from Bangalore, who's one of the leading psychiatrists at Apollo Bangalore. And it's also a very nice honor to introduce Dr. Anita Gautam. Her talk is going to be on epidemiology of suicidal behavior and suicide. And as you can see that she's the chairperson of the Young Psychiatrist Committee of IPS. She's organized numerous programs for the IPS Young Psychiatrist Committee. She's also a member of Media and Mental Health of IPS committee has been a convener of the Perinatal Psychiatry Subcommittee. She was awarded with the Indla Ramasubba Award IEPP, and her name is also included in the Indian Book of Record and Golden Book of World Records for participating in more than 100 talk shows on different aspects of mental health, psychiatry, and creating awareness in the community. She's also been honored with the Nari Samman Award by the Rajasthan Commission of Women and the Vivekanand Gaurav Samman in 2010 and Mahila Siromati Samman Award. So I think there are so many awards which she has received as a woman psychiatrist, Women's Honor Award, and the list I think goes on. Trailblazer Woman Award, Woman of the Future Award. So I think it's a very great honor to have you with us, Dr. Anita Gautam. And she's a very, very active person who's worked for so much awareness in psychiatry or she's given her opinions on so many sensitive issues related to women, gender, sexuality, children. So it's great that they're conducting this symposium, and welcome, Dr. Anita, over to you. Thank you. We look
Thank you,
forward.
Darpan. Thank you for such lovely introduction. Good evening, everybody. My topic is suicide epidemiologic perspective. Why we need a different speaker for such topic? Because if we look at the epidemiology, then only we get the information about what is the trend, what are the group risk factors, group, and how can we set certain things to help those who commit suicide. So suicide is a serious global public health issue, and it is among the top 20 leading cause of death worldwide. In fact, more deaths due to suicide than to malaria, breast cancer, even war and homicide. And doing so provide essential information for understanding what is the scope of the problem and what interventions can be made to meet the need for this specific population and to adjust the trends. The timely registration, the main problem is timely registration and regular monitoring of the suicide. It is must needed in order to identify specific group at risk for suicide. But the problem is 59 out of 194 countries, only they have the good quality morbidity registration data. If we see the data given by the WHO, more than 7 lakh people die due to suicide every year. And that means one person every 40 seconds. And there are indications that for one complete suicide, there are more than 20 other suicide attempts. So how big this problem is? A prior suicide attempt is the single most important risk factor for suicide in general population. And in fact, suicide is the fourth leading cause of death in young population, 15 to 19 years old, as per data 2019. And suicide account for 1.3% of all deaths worldwide, making it 17th leading cause of death. And ingestion of pesticides, hanging, and firearms are among the most common methods. Suicide does not occur only in high income countries, but it is a global phenomena. And in fact, 77% of global suicide, they occur in low and middle income countries. The global age standardized suicide rate was higher in male, 12.6 per 1 lakh, than the female, 5.4 per 1 lakh. That means the globally, the rate is 2.3, in the male suicide rate is 2.3 times higher in male. While the ratio is little over 3 in high income countries, it was little bit lower in low and middle income countries. That in low income countries 2.9, lower middle income countries 1.8, but upper middle income countries 2.6. More than half of the global suicide, they occurred in before the age of 50 years. That means our young working population. Most adolescents who died by suicide, about 88%, were from low and middle income countries, where nearly 90% of the world's adolescents live. Now, this is the chart which shows that the global top 4 causes of the death among 15 to 29 years old. So if we see the both sexes, then it is first cause is road injury, second is tuberculosis, third is interpersonal violence, and then suicide. In female, first is tuberculosis, second is maternal condition, third is suicide, and then it comes HIV. And for the males, road injury, interpersonal violence, then tuberculosis, and then fourth is suicide. Now, according to WHO, it also recognized suicide as a public health priority. The reduction of suicide mortality has been prioritized by the World Health Organization as a global target, and it is included as an indicator in the United Nations Sustainable Development Goals under Target 3.4, as well as in WHO's 13th National Program of Work and in WHO Mental Health Action Plan. A comprehensive and coordinated response to suicide prevention is critical to ensure that the tragedy of suicide does not continue to cost lives, and it affects many millions through the loss of loved ones and or suicide attempts. The first WHO World Suicide Report under the name Preventing Suicide, a Global Imperative, was published in 2014, and the aim was to increase the awareness of the public health significance of suicide and suicide attempts, and to make suicide prevention a high priority on the global public health agenda. Now, the methods of suicide. Yes, 20% of the global suicide was due to pesticide self-poisoning because of obviously rural agriculture area. It is an easy approach. Other common methods are hanging and firearms. Knowledge of the most commonly used suicide method is important to devise prevention strategies, which have shown to be effective, such as restrictions of access to mean of society. Who are at the risk? While the link between suicide and mental disorder, in particular depression and alcohol use disorders, is well established in high income countries. But many suicide, they actually happen impulsively in moments of crisis, with a breakdown in the ability to deal with life stresses such as financial problems, especially in the COVID area, relationship breakup, or chronic pain and illnesses. In addition, experiencing conflict, disaster, violence, abuse, or loss, and a sense of isolation are strongly associated with suicidal behavior. Suicide rates are also high among vulnerable groups, like this, who experience discrimination, such as refugees, migrants, indigenous pupils, LGBTI society, and prisoners. By far, the strongest risk factor for suicide is a previous suicide attempt. Now, this is a chart which shows that if we divide according to religion, we see that the Muslim community, the very low rates of the suicide because they have that faith that if you commit suicide, you cannot go to Jannat. Suicide in India. With 18% of the world population living in India, 42% of the population, they have age between 15 to 39 years. And addressing suicide in India is actually, it make a global difference in the burden of suicide. Data on suicide is collected from National Crime Report Bureau, Ministry of Home Affairs, and based on the police report records. Suicide attempt is no more a punishable offense under the IPC section 309. So it makes a little bit things better. That's in rural areas. Obviously, they are underreported because then the data are only collected from the public police records. And there is a lot of stigma attached to the suicide. And family don't want their loved one to be sent to for postmortem. So lots of things are there, and we have to work on this is removal of this stigma. So at least we have the actual data. WHO data shows that a total of 1,53,000 suicides were reported in our country during 2020, and that shows the increase of 10% in comparison to 2019. So 2020, the rate of suicide rate is 11.3%. What is rate of suicide? Rate of suicide means incidences of suicide per 1 lakh of population. So this figure shows suicide rates among India, state-wise, there's a distribution. And the area shows in pink, Bihar, Nagaland, and Manipur. They have very low suicide rate, pink shows, and very high, the areas in yellow, Chhattisgarh, Telangana, and Kerala. And Sikkim also, they have very high suicide rate. But as for total suicide, number of persons who committed suicide, it is very low in area pink. I think there's only Nagaland and Manipur. And yes, this Ladakh. And very high who committed, number of people who committed suicide, that Madhya Pradesh, Maharashtra, Karnataka, and Tamil Nadu, West Bengal. This is a pie diagram which shows the major percentage share of the suicide in states during 2020. So obviously it shows that Maharashtra, it has 13%, Tamil Nadu 11%, Madhya Pradesh 9.5%, West Bengal 8%. Now this is this diagram, it shows suicide victims by sex and age group during 2019. So this shows that in the geriatric population above 60 years, male population committed more suicide. Obviously, we have seen earlier that the suicide rate is higher in male, but the attempt suicide, they are more common in female. So same, this pattern is same in all age group, but especially below 18 years, they are almost equal. Male and female ratio is almost equal. So distribution of suicide victims by social status, married, unmarried, widow. In this also, male committed suicide, the rate is more and higher in male as comparison to female. The percentage share of suicide victims by educational status, and this pie diagram clearly shows those who are professionals, those who have higher degrees, they commit the suicide rate is lower in that group. And yes, those no education and the illiterate pupil, or they only have the primary level of educations, they commit more suicide. Maybe the reason those who are professional, they have a more social stability or more financial stability. So maybe a social support is more for those persons. Now the percentage distribution of suicide victims by the profession. In fact, a scenario before Corona 2019, this percentage share was the farmer or person who was involved in the farming sector and the homemakers, housewives. But now during COVID 2019, 2020 and 2020, scenario changed completely. Now the daily wage workers who work on the daily wages, they committed suicide more. The rate is higher in those daily wages. And then after that, housewife, then self-employed. Obviously, we know the reason that the small business, they actually they completely finished during this Corona period. So, and then the person engaged in the farming sector, only 7.4%. Professionals, although their salary is cut, but still there is a little bit income to their families. So their share is little, and the maximum share of suicide is by the daily wages, the workers. And percentage share of various causes of suicide. Maximum cause, family problems. There was an increase in the domestic violence. There was increase in aggression. There was no tolerance. And yes, all those how to feed my family, how to, there are a lot of problems. And yes, negative thoughts and depression, all those things, goes on hype during corona. So family problem was the main cause of the suicide during this corona period. And second was the illness, and third was drug abuse, alcohol addiction, marriage related issues, love affairs, and bankruptcy, failure in examination, unemployment, professional career problems, property disputes. They are the small other reasons for the suicide. Amid its fight against the pandemic in 2020, India lost more people to suicide than COVID-19. It was shocking. As per the latest reports by NCRB, the country reported more than 1.53 lakh suicide last year, but the death because of corona was 1.49. So it was really shocking that we did not, the death because of the corona was low and the death because of suicide was higher. While illness was the most attributed cause behind suicide, daily wage workers made up the largest share of the total suicide. A total of 37,666 daily wage workers died by suicide in 2020. They impacted most by the COVID-19 lockdown. They not only lost their source of income in big cities where they were living, but also faced hardship in meeting their families back home, as all modes of transports were halted because of the lockdown. At least 12,526 students died by suicide, accounting for over 8% of total deaths. And 10,677 people engaged in the farming sector also ended their own life. A number of celebrities, yes, we have seen a different scenario during 2020. A number of celebrities, more like actor Sushant Singh, Sameer Sharma, Preksha Mehta, Sejal Sharma, they also committed suicide. And then when they committed suicide, there is a question arise in the society. Why a person who gets so much of money, so much of fame, so much of name, why he committed suicide? If he commits suicide, then where are we standing? So it is, suicide does not affect only a low income area or group. It affect all people. And that's why we have to look how we can deal it, how we can prevent it. And for that topic, or for that questions, I leave this session for Dr. Manasvi and Dr. Hemend. Thank you.
Thank you, Dr. Anita Gautam, for very excellent lecture. And now moving to the second presentation is on risk factors of suicide and non-suicidal self-injury by Dr. Manasvi Gautam. And I have a very nice privilege as the chairperson to introduce Dr. Manasvi. He is the director and consultant psychiatrist at Gautam Hospital and Research Center, Jaipur. He is the chairperson of the Media and Mental Health Committee. He's also been the chairperson of Young Psychiatrists Committee from 2018 to 20. He's the honorary assistant general secretary of IPS. He had been from 2015-2018, and from 2010 to 2012 he was the general secretary IGMH. He's also the co-chair publication committee IPS in 2010 to 11. Currently, he's way back in 2010, he was the chairman of the scientific committee of ANSIPS and has been the organizing committee of Young Psychiatrist Program of the IPS in 2018 and 2019. He has a lot of invited speaker programs on various TV channels, and he's won 3 national awards and 1 state award in psychiatry. He has 15 national publications and principal investigator in 10 international ICH GCP research studies, and he started first memory clinic in Rajasthan. So with so many novel initiatives to his credit, we welcome Dr. Manasvi Gautam, and we look forward to listening to his lecture. Thank you.
Thank you so much, Chairperson, for your kind introduction. Good evening, everybody. I'll be keeping my topic to understanding non-suicidal self-harm injury and suicidal behavior. So the scope of my presentation would be, I'll be talking about briefly, I'll be touching on the historical perspective, etiology, the risk factors, the protective factors, the stages, and the warning signs. Later on, Dr. Hemendra would be talking about the management aspect. So how do we actually define non-suicidal self-harm injury? It's the intentional destruction of one's own body tissue without suicidal intent and for purposes not socially sanctioned. The terms which usually we hear in this is suicidal self-injury, suicidality, and suicidal behavior. So suicidality itself is the occurrence of suicidal thoughts or ideations or suicidal behavior. And this suicidal behavior includes the acts of self-harm with a fatal or non-fatal outcome. So what are the biological attributes of non-suicidal self-harm injury? People with NSSI may have chronic low levels of endogenous opioids. It has been seen that low level of opioids may result from a history of abuse, trauma, or neglect, or may be biologically endured through the other processes. These people via NSSI restore their endorphins at normal level, which results in a feeling of pleasure and relief from negative emotion. And probably that is the reason why repeated activation of opioid systems may lead to a tolerance effect, which makes them less sensitive to pain while self-injuring over time and again. So we understand that there are initiating factors and maintaining factors. Initiating factors are those which are the inherent factors, usually which we have seen earlier in other models also, as which we call as the trait factors. So representation of NSSI, which are the nature and the functions. So emotional, there is a high emotional sensitivity, long emotional duration of trouble, and attentional deployment. Then representation of self, the self schemas. NSSI related cognitions are formed, outcome expectancies, self-efficacy expectancies, which lead to perceived emotionally volatile situations. These can lead to emotional response, various emotional responses. So perceived emotional volatile situation either directly go into NSSI to avoid the situations, or emotional responses can lead to NSSI to avoid the emotions. And in certain people where there is a decreased emotional awareness, decreased distress tolerance, decreased alternate ear strategies, and expressive suppression, it leads to modulation response. So this is how they put it in the cognitive emotional model of NSSI. Now, NSSI and suicide, how they are related, we see that the presence and frequency of the past NSSI was strongly associated with suicide attempts. Also, those with a history of NSSI had made more lethal suicide attempts than those without a history of NSSI. Frequency of non-suicidal self-harm injury exhibits a stronger relationship with suicidal behavior than depression, borderline personality disorder, anxiety, or impulsivity. So suicide, killing oneself, an act with a fatal outcome that is deliberately initiated and performed in the knowledge or expectation of a fatal outcome. It has been existing since ages, extensively written, glorified by various writers, romanticized, and condemned by people at large. So the denial of right to the honor of a normal burial, if a permission to commit suicide not legitimately sought for from the state, as we'll see BC in Athens, acceptable method to deal with military defeats in Greece, Rome, and China. As we have already seen in Dr. Anita's presentation, the graph which showed that least seen in the Muslim population because of the religion. But sometimes we see that in Jainism, they condemn suicide, but there are high regards of Santara, an altruistic form of a suicide. In Hinduism, again, it's condemned, but at the same time, when we say Salekhana, which is an best sacrifice offered, sacrifice offering oneself for the cause, it is given a high repute. There are anecdotes from mythology like Maharishi Dadichi, a big saint, he gave away his bones for a noble cause. And then Sati and George, there were like previous customs where females used to, for their own savior of dignity, used to do suicides or mass suicides. So sociological factors, we know that there are these four kind of suicides: egoistic, altruistic, anomic, and fatalistic. Egoistic, having very low social integration, where a person has very high ego and has very low attachment with and bonding with families and others. Altruistic, social integration too high, where the cause and the society comes above self. Anomic, social regulations too low, and fatalistic, social regulations too high, as seen in prisons and people under slaves conditions. So there have been various psychological explanations, Freud saying mourning and melancholia, Karl Marx through its conflict critical theory, Menninger's theory, suicide as an inverted homicide, then Joyner's interpersonal theory of suicide, Kleinert and Meyer social learning theory. There have been various theories which have postulated various ways how they felt there are the causations. Now looking at the biological markers, serotonergic system, low concentration of 5-hydroxyindole acetic acid, metabolite of the serotonin, are seen. Noradrenergic system, according to the stress diathesis level, higher the amount of tolerance towards stress, higher would be the required threshold. And if somebody has got low stress tolerance, low threshold will be there, and that chances would be higher in those people. HPA axis, we have seen that dexamethasone suppression test, non-suppressors, they are there. Then reduced cholesterol level, basically seen less in those people with having less cholesterol because of medication, rather than those people who have gone into hunger as a way of starvation and then decrease in the serum cholesterol levels. Then genetic factors, polymorphism in TPA gene and family history of suicide is usually present. Social risk factors, social deprivation and social fragmentation, poor economic condition, as we just saw, and employment, one of the most leading cause, 23% of the death because of that. Childhood adversity, interpersonal losses and conflicts, family conflicts, recent migration and relocations, financial difficulties, loneliness. Then physical illnesses, chronic and severe physical illnesses, many debilitating illnesses have a great toll over this. Cancer, twice increase in the suicide rate. Epilepsy, 5 times increase in the suicidal rate. Chronic pain, HIV and AIDS. Majority suicide victims have one or more psychiatric disorders. When we look at the mental illnesses as a reason, 22% of the suicide in the first year of a psychiatric illness. Risk of suicide is high following discharges. 25% of the post-discharge suicides in the first 3 months, most of the in first 2 weeks post-discharge. Major depression, 20-fold increase. Late life depression, 35-fold increase. Bipolar affective disorder, 15-fold increase. Personality disorder, 7-fold increase. Schizophrenia lifetime risk, 10%. So people having previously attempted suicide, they have a risk of high fold of as much as 38 times, and a greatest risk suicide after an act of deliberate self-harm in the first 3 years, especially in the first 6 months. 1% of the DSH kill themselves in the next year, and 15% of those having deliberate self-harm eventually kill themselves in their lifetime. Psychological hopelessness, impulsivity, dichotomous thinking, poor problem solving skills. Substance misuse again is a big factor. Opioid abusers, risk of suicide 14 folds. Prescription drug abusers, usually those who are abusing benzodiazepines more per se, 20-fold increase. Cannabis users, 4-fold increase. Alcoholism, 15% risk of suicide. mostly in older males, currently drinking people, having depressive symptoms, and poor physical health, unemployed with little or no social support. So the dysregulation of the neurotransmitter serotonin has been linked to depression, suicidal behavior, and substance abuse. Lower level of 5-hydroxy 5-HIA, a principal metabolite of serotonin, have been associated with increased suicide and suicidal behavior. Longer periods of use leads to cognitive changes and behavioral control is impaired, subsequently leading to an increase in the impulsive and aggressive behaviors. Drugs use distorts judgment, weakens impulses control, and interrupts neurotransmitter pathways. Physiological and metabolic stresses resulting from use of substances can also lead to neurotoxic damages and severe medical consequences. Addiction induces negative emotional states. As we can see in this interpersonal model of suicidal behavior, where thwarted belongingness, that I am not have unmet need of being belonged to. I am alone, and the desire of suicide comes between the perceived burdensomeness that I am a burden to the family, and there is no one who looks forward to meet me. There is a crossover and capability of suicide where there is an easy access to the means. That has a lethal combo where there are the maximum suicide attempts. So as we have discussed earlier, there are traits and the state which are responsible. Traits are there through the genetic and early life events and multiple stressors. They lead to the suicidal behavior. Now, what are the protective factors? Strong social support, family through community, matured skills of coping, problem solving, conflict resolution, non-violent handling of disputes, and personal socio-cultural and religious beliefs that support self-preservation and disapprove suicidal thoughts. Restricted access to means of suicide, seeking help, and easy access to quality care for mental and physical illnesses. So, intervention, ideation, intention plan, then threatening behavior, if not intervened, attempt into fatality. Warning signs like trouble coping with recent losses, death, divorce, relocation, breakups, etc., feeling of hopelessness and despair, making final agreements, writing a will, eulogy, taking care of details, completing pending issues, giving away prized possessions, exploring means for suicide, procuration, preoccupation with death, such as death or dark themes in writing, art, music, lyrics, sudden change in personality, attitude, appearance, chemical use, or behavior at school or workplace, and verbal cues like I can't go anymore, I wish I was never born, I wish I were dead, I won't need this anymore. So these kind of verbal cues and others like no one has to worry for me anymore, everyone would be better off if I were dead, nobody cares if I am alive or dead. So these kind of things are those verbal cues which sensitize us and they trigger up that we are looking at an impending suicide. Thank you for your patient listening. Over to Hemendra.
Thank you so much, Dr. Manasri, for a very excellent talk. Our next speaker is Dr. Hemendra Singh, and he will be covering two topics in his presentation, suicide risk assessment and management, and need for brief suicide prevention module. Dr. Swati Chandramouli is unable to come for this presentation, and Dr. Hemendra Singh will be covering some aspects of her presentation as well. So we welcome you, Dr. Hemendra Singh, and he's the Assistant Professor of Psychiatry Hospital, Bangalore, and he shall conduct his talk on suicide risk assessment and management. Dr. Hemendra Singh has been working in the field of, he's done his post-graduation from the prestigious NIMHANS, and he's been working through his PG days on a lot of work on suicide prevention. And he also has lots of relevant articles, awareness, and research work and publications on the theme of suicide and suicide prevention. So we welcome you for this talk, Dr. Hemendra. Look forward to your lecture. Thank you.
Thank you, madam. And very good evening to one and all. I think epidemiological data and very big overview given by sir about neurobiology. It made my job simple. So I'm not going into this data. Coming to COVID time, there are published few studies, and based on 12 cross-sectional 8 case series and other studies, mainly these studies come from low and middle income countries. So higher level of suicidal behavior during pandemic time, anxiety related to COVID, insomnia, loneliness, worsening of pre-existing mental illness, people recovering from COVID, and women were in their third trimester of pregnancy. And COVID itself and related suicidal behavior consequences. This is published study in archives of suicide research, where they have found psychiatric disorders went untreated due to fear of visiting clinics during the COVID crisis, decrease in hospitalization and referrals to psychiatric emergency room, increase in consumption of alcohol, economic hardship, unemployment, illness and grief from loss of relatives and friends, difficulties due to prolonged isolation, distress in family relationship due to being closed in together for many weeks without relief, overall uncertainty and anxiety about the future. So these were the consequences which were attributed for suicidal behavior during COVID pandemic. And impact, if you see in vulnerable people, COVID-19 related like uncertainty about future, isolation and economic problems, put these vulnerable people to manifest like a depressive disorder or anxiety, use of alcohol to cope with existing problems, or exacerbation of existing psychiatric illnesses, which in turn lead to suicide. So if you see during pandemic time, rather than having face-to-face consultations, we have developed alternatives like online sessions. But if you see overall facts about suicide, 90% of suicide individual who die by suicide suffer from one or more mental disorders. Approximately half of them sought healthcare services before they died. Risk of suicide is high 3 months after discharge, and with the highest number of suicides within the first week after leaving the hospital. 70% of patients who leave the emergency department after suicide attempt never attend their first follow-up appointment. Why this is important? This gives us clue to develop preventive measures to prevent reattempts. If one considers treatment effectiveness of major mental disorders to be 50% and assume that 50% of people who correctly diagnosed and successfully treated, one could expect a reduction in suicide rate of around 20%. So invariably, the assessment of a suicidal patient would always include an evaluation of underlying psychiatric illnesses, because 90% of suicides are due to unrecognized psychiatric illnesses. So basically, risk assessment, we have to assess presence of psychiatric illnesses. I'm not going into neurobiology, but why it is important, it will come in management. Stress, just stress is not merely important, there must be some diastasis. So dysregulated HPA axis and along with lococellulose based norepinephrine, dysregulation is attributed for diastasis, which is biological traits which are determined by genetical factors. Whether serotonergic abnormalities which are seen in suicide victims are related to stress diathesis or it is an independent finding, because we have seen post-mortem studies where upregulation of post-synaptic receptors, mainly 5H2 ventrolateral prefrontal cortex. Coming to suicide risk assessment, and many times there is a myth, like asking about suicide to a client or subject can increase the suicide risk, or we are giving some clue, go and attempt. So there are dozen of published paper in last 2 decades, and they have found asking patient or research subject about suicide ideation does not have any iatrogenic effect. In contrast, talking about suicide may in fact reduce rather than increase suicidal ideations. So this is very important asking. So Pisani and Silver Morton, they have proposed risk assessment and formulation. Risk assessment is not a kind of static, it's a dynamic, because morning patient may be having suicidal ideations, but afternoon patient is not having suicidal ideations. By that evening, there are many seasons. Patient may be having active suicidal ideations. So it's a dynamic assessment of risk factors and what are contributing or maintaining factors. Risk formulation, it gives idea how protective factors are neutralizing the risk factors and what are the warning signs which are putting person on short-term risk. So that we call risk formulation, where we see risk status in comparison with population, and with premorbid personality, we see as risk state, and what are available resources and what are changes we are anticipating after discharge. Like person is having online marital discord or some other maintaining factors, we have to incorporate those also in management of suicide. So how to assess risk? As madam said, the best predictor of future suicidal behavior is the past behavior. So suicidal ideation is both a chronic or acute risk factor for suicide. And directly ask for suicidal ideations, don't hesitate. And if there is no suicidal ideations, I think risk assessment end there only. If suicidal ideations are there, ask for intent plan. They have taken, precautions against discovery or carrying such means, or they have written some suicide notes, previous attempts, and the worst point, suicidal ideation at the worst point in patient's life is a better predictor of suicide than patient would be having current suicidal ideations. So based on that, you can plan your management, where to treat these patients. If no such plan, only passive death wishes or access to mean is limited, vague intention, more risk protective factors than risk factors, you can evaluate or moderate risk based on vague plan or some intention, some risk factors, more protective identified protective factors. You can just see 24 hours emergency room monitoring, or sometimes they need continuous ward care. You have to keep them in ICU or ward care based on severity of presentation, where they have a specific plan, active death wishes, multiple risk factors. So immediate evaluation is required for hospitalization. But many times, though you have admitted patient, but they don't tell that I am suicidal. Probably they are suicidal. why this denial among these patients? Probably that time they are not thinking about suicide. We use many languages, like I am in Bangalore, and in Bangalore, many languages are there. So unclear wording of questions, poor comprehension of questions. Primary psychiatric illness may be distorting the cognitions, fear of, because of stigma and taboo, loss of job, relationship, negative judgment, fear of making clinician anxious, and belief that I can't be helped, believe that that thinking of suicide is a sign of weakness. So there are many reasons that deny having suicidal ideations. Coming to management, basically treating the diastasis, as we mentioned, underlying biological changes. So here we have somatic modality of treatment for psychiatric illnesses, and many interventions are proved to be anti-suicidal. So antidepressants, we should be careful initial period of prescribing antidepressant, because these drugs can increase psychomotor activities. However, cognitions are still there, so they can access to means. So we should be little careful. Lithium, because NSSI model of emotional pain, where opioids like buprenorphine is under evaluation to treat such behavior. Even ketamine, short-term use, even people are using for maintenance therapy also, giving ketamine, but it lasts for a few days to 1 week, that effect. Mainly lithium, mood stabilizer. Clozapine also found to be anti-suicidal agent. Other drugs and ECT, of course, there are comparison, there are trials, ECT and other available therapeutic modalities. Psychotherapies are there, as we know, overactivation of orbitofrontal cortex and decision making, that low level of activation of dorsolateral prefrontal cortex involved in problem solving. They will be having less number of choices in making solving problems because of increased impulsivity due to orbitofrontal cortex. So we have to train them by problem solving skills. There are existing therapies, very effective. And this is what we call suicide mode, which is having 4 integrated system, where vulnerable person, because of triggering factors, can go into suicide mode, where patient would be having maladaptive behavior to cope with emotional pain, such as indulging in substances, NSSI, or rehearsal behavior, physiological arousal, or cognitions related to suicide, or emotion. Mainly we have seen shame, guilt, very prominent among these suicidal patients. Coming to prevention, there are published studies during COVID time. However, prevention could be primary, secondary, and tertiary. Primary, which is universal, where we have to work on decrease the modified risk factors, such as over-counter use of selling of drugs, more restrictive policies for substances. Selective approach, basically treatment of psychiatric illnesses, screening and proper management of psychiatric illnesses, and some interventions for frontline healthcare professionals during COVID, vulnerable population, and tertiary interventions are required for survivors of suicide. So this is international COVID-19 suicide prevention research collaboration. They have published in Lancet selective indicated intervention and universal interventions. Coming to brief intervention, like during COVID, there are even published studies where suicide prevention by telephonic contacts was found an effective and acceptable mean to reach out to patients. Rather than not having any assessment, better to have some assessment. And multi-site international study for suicide prevention, which is Supremis, conducted by WHO in late 20s by 5 continents of WHO, where Chennai was one of the centers. And they just use one session to see efficacy in suicide prevention, and they found positive effect in subsequent suicide rates. So based on that, we have developed a 3-session module during COVID time, and I am briefly touching on outline of these 3 sessions. First session basically appreciate patient for their willingness to participate in therapy and educate them about the process. A narrative interview is being used to know the story behind their present attempt. And we taught them mindfulness meditation, and we planned some individualized, some resilience building activities. And homework was assigned to practice mindfulness. Second session, review of first, then exploring cognitions, thoughts and emotions, suicide-related emotions, teaching them problem-solving skills and restructuring their emotions, and assigning homework to record dysfunctional thoughts. And third session was very important, where we have designed warning signs, safety cards, and we have involved family members to psychoeducate them regarding warning signs and safety cards. And homework was assigned practice mindfulness, cognitive restructuring, and problem solving. So this was the template for safety card. And if you get suicidal ideations, what to do that time: practice mindfulness, breathing, pause for a minute, relook at thought and emotions, reach out to a loved one, call somebody right away, family member. So we have written on A4 size paper, cut into 4 pieces, whom to call and what were individual warning signs. And this was the coping card, like maladaptive thoughts, what feeling behind your thoughts, and how to restructure more adaptive way these thoughts, like things never change, feeling comes like hopeless, and like more adaptive you can restructure, like things are not static, this too shall pass, just like season passes. So we have applied suicide cognition scale, and you see after intervention we have seen 40 suicide attempters and significant change in cognitions related to suicidal behavior. So these were cognitions, and we found a significant change. And we did telephonic follow-up over 6 months, initially weekly, then once in 2 weeks, then once in a month, and significant change was there after end of our intervention. So as we know, focusing on protective factors such as connectedness with family and friends was as effective or more effective than trying to reduce risk factors, because we don't know how many risk factors are there, and we can't give more weightage to this risk factor or that risk factor. So better to focus on protective factors. And take home message, the causes of suicide are complex. Prevention needs coordinated efforts by healthcare and other public and private agencies. And during COVID time, physical distancing is there, but emotional closeness is must rather than just social distancing. So thank you very much for your kind listening.
Thank you very much, Dr. Hemendra Singh. You have taken excellent session and given a very nice take-home message and very good points. So the lecture is well taken, and this overall the symposium that you all have collaborated, I think it's done very excellently. And so I'd like to take questions. We take questions from the audience. If there's anyone who would like to ask any question. Perhaps Dr. Anita and Dr. Manasvi, you can also come on the dais and
but human nursing, your lecture was rather more inclusive, all right. But earlier they used to say the important is to offer meaning in life. Logotherapy was very much emphasized. There was no mention of it, and I think so. I think that gives the person more assertiveness. I think meaning in life, offering that, and that person. I think it has been very more inclusive, and it is sort of it's good. All right.
Thank you, sir.
you want to respond to the comment?
Meaning, sir
You
wants
want
to
to add on
comment,
anything to
life
it?
should have some meaning.
Yes, yes.
So we are deeply rooted on Earth planet and enjoying ANICPS. And this is the meaning roaming around. We should not lose this connectedness. There is no other meaning in life. To earn money, they have their meaning. People are friendly, they have their meaning. If you lost that, you are shattered. Like waste, but all people love each other because we are working as mental health professionals. Even person who is driving auto, he is also loving someone. That's why he is doing hard work. So meaning is what? Love. Behind all hardship, there is love somewhere. So we should not lose that connectedness. I don't know meaning of it's a yeah, that's we have to.
You have very nicely put up, sir. The thing is that social connectedness, social integration, as well as that sense of belongingness, then the motivation to go on, and in turn having that self-appraise that whatever I'm doing is meaningful and helpful to me, my growth, my family, and my entire society as a whole. That gets integrated, usually it connects with all the aspects, and then the chances of a person going into a debacle automatically goes down.
And person losing meaning in life is warning sign for suicide. No meaning in life, definitely that person is about to leave this world.
Anyone else would like to ask any question? Okay, so
I would like to ask Dr. Darpan to felicitate our.
okay, so we'll close the session. Thank you so much.
No, no.
It's great listening to all
Not-
of you all.
Can you felicitate her? Yeah. Dr. Anita Gautam. Dr. Manasvi Gautam. Dr. Himendra Singh.
Yeah, I'll click it.
Next section you are having.
अरे ये हो गया start?
We'll start with the next session. I would like to invite Dr. Manasrama on stage to chair our next session.
So good evening, everyone. Now we have a session on prenatal genetic counseling for psychiatric disorders. So the speakers are Dr. Sujata Sahu and Satyakam Mahopatra and Dr. Tikina Behra. Now I would like to invite Dr. Sujata Sahu to give her lecture.
Start. Good evening, everyone. This might be the last sessions of this conference, and everybody is looking like very stuff. And so I'm just describing in very short. Myself, Dr. Sujata. So I am currently working as a senior resident in Department of Psychiatry from SC Medical College. And today's our topic of discussion is prenatal genetic counseling for psychiatric disorders. Okay, next. These are the content of my presentations. Then coming to the introduction part, for genetics in psychiatry is not like that easy, like in Mendelian rules, like the laws of dominance, laws of inheritance, and laws of segregation, laws of penetrations. But in psychiatry, the disease have that heterogeneous etiology. Like one gene is responsible for various disease, and a one disease is determined by various genetic predispositions. And along with the genetic predisposition, environmental effect plays an important role for the manifestation of the disease. Like when the patients are taking cannabis and develop psychosis, they are genetically vulnerable for developing that psychosis. So the environment have a significant impact on their genetic predispositions. Coming to that genetic counseling proper, this is a communication process like that in AEC model, like education communications model. This is a two-way communications model between a counselor and a party, which understand and adapt to medical, psychological, and familial implication of genetics, like how the disease is going to be affected in the family in the coming generations. And according to the Peter described, this is a dynamic psycho-educational process centered on genetic informations. Okay. And there are various evidences shows that there is a clinical need for genetic counseling. So what is the goal of our genetic counseling? First of all, we have to concrete all the information. We have to collect all the required informations, and we reassure the parties, we reassure the family members what could be the possibilities of genetic effect on their or the disease in the family, and about the psychoeducate about the laws of inheritance and how the genes are going to be affected, how the genotypic and the phenotypic character and the traits are going to be manifested in their coming generation, right? And most importantly, to provide them to support the family, to support how how to deal with all this kind of genetics disorder and all that. Okay, next. So there are the certain indications where genetic counseling is quite preferred when there is knowing the chance of fetus to develop the disease. In our general clinical practice, everybody comes in our general OPD. They ask, doctor, my wife is suffering from bipolar disorder, whether my child is going to have the disorder or not. In that case, when the queries in the patient's mind or family member's mind was there, but due to know whether this is going to be happening in a successive generations or not, then genetic counseling is preferred, indicated. Okay. When either a parents or close relative have any kind of psychiatric disorder, like that, like in schizophrenia, psychiatric disorder, like mood disorder, bipolar affective disorder, depressions, OCD runs in family, and there is a high genetic vulnerability in the successive family members. So there, the genetic counseling is indicated. And obtaining a prenatal genetic testing. And if a standard prenatal screening test yield an abnormal results, like genetic testing like karyotyping, polymorphism, and like various other DNA, RNA slicing and all that, and that amniocentesis, chorecentesis, that proper genetic testing, before proper genetic testing, genetic counseling is a must. And use of psychotropic in pregnancy, like use of antipsychotic, antidepressant in pregnancy, and that might be affect in the fetus, like in that prenatal period and all. So these are the various conditions where genetic counseling are indicated. So till today, what are the background of genetic counseling in our psychiatry? When there are studies which are done in Kuwait and years, like families are very much interested what the service can offer. Like they're very much interested for that genetic counseling part. And sometimes it seems that the family member quite overestimate the chances of disease, like that might be influencing that childbearing decisions. Like if a mother or parents are having any kind of psychiatric illness, the child is might be going to have in that psychiatric illness, like schizophrenia, OCD, bipolar affective disorder and all. And despite all this cognitive and affective burden that not routinely prefer in our day-to-day practice, that is the stigma in genetic counseling, that is the hurdle to come across. Okay. There are some initial pilot studies by Austin, observational study by Costin and Hipman, the qualitative work, and the randomized control studies were done when they conclude that the psychiatric genetic counseling provide a collective evidence of positive outcome for patients with psychiatric disorder and their family members. So the psychiatry, practicing genetic counseling is a must need now in current scenario. These are the importance for genetic counseling to provide a family support and support to a family, whether to marry, whether to have a child or not, whether to plan a pregnancy or not, whether when the maternal age is very high, when the maternal age or paternal age is very high, and there is a family history of psychiatric illness. So this is the basic importance or requirements of genetic counseling. And proactively managing psychiatric illness, like if you know the disease predisposition earlier, we can plan the management or treatment very early, and we have that early intervention and decision making, like how to deal with that all this outcome of the disease. And the source of informations, like getting all kind of information, like what is a gene, what is the allele, what is the psychotype, what is the genotypic expression, what is the phenotypic expression, what is polymorphism, and what is like pleiotrophy of the gene. All these kind of genetic information are included in the genetic counseling. A genetic counselor are very much trained to provide, to explain all this kind of information to the family member in a simplified way. Okay. Next. To conclude, there is a qualitative and quantitative outcome of psychiatric genetic counseling. This outcome are results of genetic counselors, how he is using tools and strategy to describe here to successfully work to find the line of helping people understand that mental illness is not their fault, but these are the things that can do protect their mental health going towards. And this can be practiced in adult psychiatry, as there is many much more evidence in child psychiatry, like diseases like autism spectrum disorder, intellectual disability disorder have proven evidence of genetic testing. Okay, but there is less evidence in adult psychiatry like schizophrenia and bipolar and OCD. Okay, in clinical genetic service that prioritize the underserved area of medicine of practicing genetics and psychiatric disorder. So for future perspective view, and for there is a need for genetic counseling to be included our day-to-day clinical practice. These are my references. Thank you.
Thank you, Dr. Sujata. Now I welcome Dr. Tikina Behra to give her lecture on managing issues.
Thank you, ma'am. Good evening. Myself, Dr. Tikina Behra, Senior Resident, Department of Psychiatry, Balangir Medical College, Odisha. Today, I'll be presenting the steps in prenatal genetic counseling and managing issues related to maternal psychiatric disorders. Coming to the definition, the process of helping people to understand and adapt to the medical, psychological, and familial implication of genetic contribution of disease. Genetic counseling is not only limited to the genetic contribution of the disease, but it also considers the environmental component related to the disease. The genetic counseling part integrates three factors like interpretation of family and medical history. It is to assess the chance of disease occurrence and recurrence, education about the inheritance, testing, management of the disease, prevention. If the disease occurs, then different level of prevention, the resource and research of the disease. Then the counseling to promote the informed choice and adaptation to the risk or the condition of the disease. Establishing psychiatric illness as a topic that need to be addressed, as in genetic counseling, psychiatric disorders are not that much included nowadays, up to these days. So psychiatric disorders rarely constitute the primary reason for referral to the genetic counseling sessions. In order to deliver optimal patient care, clinicians must be equipped to identify the patients who could benefit from prenatal genetic counseling. So it should be in a manner that it is not dependent on the patient's spontaneous self-identification of the interest, that I have psychiatric illness or my family members have psychiatric illness. So I have to go to the genetic counselor, they don't know. So it can occur by routinely asking this should be decreased by routinely asking all the patients coming to for genetic counseling about a personal or family history of psychiatric illness, exploring the spontaneous associated concerns, and clinicians can create an opportunity for the patient to open up. Different steps for the genetic counseling, mostly in psychiatric illness. First step is initial contracting. Here, contracting around the reasons and motivation for the visit at a level beyond the superficial is crucial. Like patient has psychiatric illness, patient's family members has psychiatric illness. He is concerned about that her child is going to affect by the psychiatric illness or not. Inside the client, there is a deep fear, there is a guilt and other emotional components which should be dealt with. The use of the scales with patients during contracting allows them to communicate their needs or identify areas in which they are experiencing distress. The contracting process helps to ensure that the patient's articulated needs are met as a result of probing by the counselor that facilitates insight into deeper related issues of concern. Then how to approach a client who has come for a genetic counseling for psychiatric illness. First is broad screening questions for eliciting a psychiatric family history. We have to know whether the patient has come for which concern, whether she has a family history of psychiatric illness and she is concerned that her child is going to be affected, or herself, one of her family member is having psychiatric illness and she is concerned that whether I am going to suffer from the same or other psychiatric illness. We have to question different issues about her family members, like different symptoms of psychiatric illness, like whether any of your family members have ever have some nervous breakdown or have any suicide attempt, received any ECT, have any symptoms of paranoia or any symptoms of hearing voice, any symptoms of depression, anxiety, shaking or hoarding, or anyone has ever been with any psychotropic medications. And this family history we should take for a 3-generation pedigree. Then second step, we have to, the second step is exploring a patient's interest in discussing implication of their psychiatric family history, how it will affect the next generation. So first of all, as the patient is discussing about the psychiatric illness, which is more of nowadays also there is a stigma related to the psychiatric illness, we have to assure the patient that yes, you have to, you tell confidently, and this thing we will keep confidential, and about the psychiatric illness of the family members, and whether there is a chance of children to develop this disorder or not, or if whether if uh, ever the patient children is child is going to develop the psychiatric illness, then how it can be prevented. Then third is contracting. In contracting, first is situation when a patient express interest in discussing chance for illness recurrence only. We have to correlate the research work. The patient is telling about her family history, family dynamics, but we have to correlate the research work and tell the patient about the scenario about related to the scenario in her family, and relates with how people recovers, what should be done to protect the mental health, like if whether or ever any symptoms of mental illness occurs, then whether there are some protective factor or not, like good sleep, good coping skills, and other social factors like good social support is there or not. Then another is opening emotional issues as a topic for discussion, like when the patient comes to for the genetic counseling, he has underlying anxiety, guilt, fear about their experience with personal family history, about what the genetic counselor will tell about the probability of the psychiatric illness in herself or her coming generation, whether they feel judged for wanting to be a parent or not. There are misconceptions like they think that the genetic testing will provide the definitive answer. They have anxiety for that. There is an overestimation of the probability that yes, one of my parent is suffering from psychiatric illness and my child is going to suffer must means there is 100% chance that this psychiatric illness is going to the next generation, and all women should stop taking medication during pregnancy to protect the fetus. This is also a misconception and this is to be dealt with. And next is explicit statement of the clinician's goal for the session after clear-cut discussion with the patient about why the patient has come for this, why the patient has come for this referred from other department to this session, and to address the need and question of the clients to be discussed with clarity. Then exploring patient's existing explanation for the cause of the illness, not typically based on genetic testing, rather typically based on detailed assessment of a psychiatric family history, we can we can discuss the probability of the illness, because each and every patient having, or each and every family having a genetic predisposition, there is there is no such situation that each and every person of the family coming in next generation are going to suffer from the same or other psychiatric illness. So discussing the individual risks, that number of family members affected, if number of family members affected by psychiatric illness are more, then the chance is more. The age of onset, like if there is an early onset of disease, then the genetic predisposition is more, then they are more vulnerable more of. And the sex of affected and at risk family members, like In case of autism spectrum disorder, the male are more likely affected than as compared to female. So we have to discuss clearly with the client. Then about risk assessment. Uh, uh, for Mendelian disorder, it is easy to assess the risk of the recurrence of the disease. Uh, it is done based surely on 3-generation pedigree. But in case of non-Mendelian inheritance, like most of the psychiatric illness, it becomes more complex because of the diagnostic uncertainty, decrease in penetrance, like they have the genotype present, but they are not expressible phenotypically. Variable expressivity, like the extent of the gene. The gene is present, but the severity is different, and the genetic heterogeneity. Due to this, the in non-Mendelian inheritance, like in psychiatric illness, this is difficult to assess the risk correctly. Then conveying the information to the client, it must be provided in an unbiased manner so that the right of the client will be there, and some legal issues shouldn't be there for the counselor. It is to minimize the individual perception of the risk. In addition, information about illness, medical management, available support, and service is often provided. Different information we have to convey to the client that for probably mainly in psychiatric illness, there is not a single factor responsible for the disorder. There is a genetic factor as well as environmental factor, multifactorial. We cannot control over passing the genes, but all have some genetic vulnerability for the psychiatric illness. But the fact is that there are some uh, second hit, like some environmental factors, some stressors are there to manifest the disease in genetic vulnerable patients. Higher vulnerability can thrive under right circumstances. Whoever are higher more genetically predisposed, they also can live their life without any illness. So for with good coping, with good social support, with good nutrition, good sleep, like this type of protective factors, patient may not manifest with the disease. And we have to convey them that the psychiatric illness is multifactorial. There are protective factors somewhat prevent the illness and recurrence, and psychiatric illness is not a moral failing, which is the myth in our society. It is not anyone's fault. Then support facilitation and decision making, where the consultants or the client face problem in decision making, clinicians have to support. A session may focus on attempt to reconcile the misconception and alleviate feeling of guilt, stress, anxiety, and underlying depression. And managing issues related to maternal psychiatric problems. All healthcare professionals in practice coming in contact with pregnant women should screen their patients for mental health problems. It becomes important when the woman has personal history of psychiatric illness. There is a risk of suicide. It has been seen from a study that the risk of suicide in a patient, in a pregnant woman who is vulnerable for any psychiatric illness, mostly by mood disorders, they have maximum chance of suicide in the first year of the postpartum period, and there is a relapse chance of relapse in the postpartum period if they have mainly the mood disorders. The patient manifests as postpartum psychosis in the postpartum period. Certain tools like Edinburgh Postpartum Depression Scale, Suicide Assessment Checklist can be helpful to elicit whether the patient is currently undergoing any psychiatric illness, undergoing any suicidal ideas or not. And to conclude, despite of increased prevalence of psychiatric illness, patients as well as family members are still unaware and stigmatized to attend a genetic counseling center, mainly for psychiatric illness. It is important for clinicians to routinely ask their patients about personal and family history of psychiatric illness so that individuals who could benefit from the genetic counseling can be targeted. These are my references. Thank you.
Thank you, Dr. Tekina. So, this is most important topic, I think, though, none of us recognize it because the importance of genetic counseling and also testing. So, thank you for enlightening us, Dr. Sujata and Dr. Tekina. Can you come on to the dais? And also, any questions from the audience? Yes. Sir.
More and more attention. Yeah, that's a comment, only comment I can say.
Thank you, sir.
It's very unfortunate, very little attendance.
So then if there are no doubts, then we will wind up the session then. Okay. Certificates? Practice this genetic testing in your hospital? Okay. Okay. So for even for schizophrenia and all you'd send? It's not done. Okay. 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 Yeah. Well, but these things can be practiced in child psychiatry, I think. Or then few things can be even few pregnancies can be aborted if really the child is going to have a problem. Hmm.
They are
Mm.
unable to decide.
Yeah. And we can how much percentage of risk whether really they can have the same child or not.
That person is also not fixed.
Yeah.
These are different things.
Mm.
So this counseling process is also difficult.
After this, madam, just coming for that, this girl is having that bipolar or marry or not? Whether to marry, whether to develop.
Yeah.
Doctors also.
Yeah, few questions are very difficult to answer.